year now. And the second thing which I would like to highlight, that during the first course, the birth of this World Density Federation has taken place. And I can say that there is a phenomenal expansion of this organization. We have now office in Southeast Asia, Anand has already mentioned, Western Pacific, Latin America, Africa, Caribbean, Europe. These are the countries which, the regions which we are covering. We intentionally did not start our branch in North American countries because they may not require. And the focus here is on public health approaches. You have seen it is in the name also. And when we say public health approaches, our focus is mainly on three pillars which WHO also advocate. That is health promotion, surveillance, and disease management. That is, those who are healthy should remain healthy, which all of us want. We should also map this epidemic by surveillance. And third is that those who are suffering from the disease, they should have the access to the diagnostic and the treatment, which is also very, very low. And over a period of time, we developed our resource material. We have a book on public health approaches to non-communicable diseases. Some of you will have the access to the e-copy of that book. Hard copies are also otherwise available. And we have also health promotion manuals, which we developed in three languages, English, Hindi, and Punjabi. And recently, under the World Density Federation, we have come up with the three center of excellence. One is on evidence-based research in NCD. Second is on Center for Implementation Research. And third is the Center for Sustainable Development, Health and Wellness. As the name suggests, one center, that is the Center for Evidence-Based Research, is for producing evidence, which is quite scattered in NCDs. And I am happy to share with you right now 20 systematic review and meta-analyses are going on all over the world. So the evidence which we will generate will go to the another center, that is the Center for Implementation Sciences and Research for implementation. And in this center also, we are having almost 5-6 projects, 4 in India, 1 in Africa and Zimbabwe, where we are implementing the World Density Federation guidelines for prevention, management, and surveillance for NCDs. So this is another thing. The third center is Center for Sustainable Development, Health and Wellness, where we are working on the Sustainable Development Goals. And another unique feature which Dr. Anand has mentioned about this course, that since the first course, WHO is our partner. Right? And the second thing is that this course is quite liked by the program officers who are working at the district and state level. I think we can say that almost all program officers in the country working in the states, they are trained at some stage under this program, right? And it is usually oversubscribed. We wanted to keep it 230, but on public demand, we raised it 250. And this time also, you know that it has increased. The number has increased and it is going up. And sometimes it becomes difficult to refuse the people. If some program managers say that I want to attend this course, it is very difficult for us because program manager will be contributing at the state level, at the district level. So I take this opportunity to welcome Mr. Vishal Chauhan, who is Secretary NCD, the Ministry of Health and Family Welfare. We always have his blessing, and after his taking over, I think the program is being strengthened. Program has, many aspects are being reviewed, and it is also going in a big way in digital mode because of his background from He's a graduate from IIT, so technology is with him, although he will be formally introduced. So this course, uh, has lived with the time. We change our structure. It is a dynamic course, and it is as per the requirement. As I have mentioned, that WHO ministry is partners since the very beginning. So we keep in mind that the requirement of program officers are taken into consideration, and we both are now at a age where we want to develop this second and third line of leadership. And in you people, we view the future ambassadors of NCDs. Because in NCDs, this multi-sectoral participation is very important. And we have the joint secretary, bringing this other departments for working for NCD is a big challenge. And in fact, we were discussing in the morning with Pradeep that we have now a national multi-sectoral action plan, but if you see really at the state level, at the district level or state level, we really need to do a lot. Another area which needs strengthening in this country is the NCD surveillance. I take this opportunity to remind our Joint Secretary that there are only 3-4 states where NCD surveillance round has been taken up. That is Punjab and Haryana done by us. Kerala is there, and there is one more state. And we have done this under the PIP mechanism of the National Health Mission. Ministry was not funding earlier. They were quite reluctant. We had a lot of discussion. I told them that unless you know baseline of your state, that where do you stand, how you can see the impact of your program. And that is how ministry agreed. So you come from the different states, and I'll request you, and I think PIPs are now finalized because this process starts usually in December, right? But we should try to include. We have taken the funding for Punjab and Haryana under the National Health Mission, right? By using the funding for operational research, which is available. So this area needs attention. The third thing which I would like to emphasize is that health promotion component is very weak in our program. You all know that 80% of NCDs are preventable. But we have done some analysis in Punjab and Haryana. What proportion of budget going for the preventive aspect? Any guess? It's less than 1%. 0.9% in Punjab. This is the total envelope for National Health Mission budget. And 0.9 for in Punjab, and this is the figure for 2015 and 16, which we have analyzed. Of course, there might be some change. And 1.2% for Haryana. We have also done further analysis that how this budget is utilized. 75% goes for advertisement and 25% for printing. Hardly there is anything available for activities which need to be implemented. The last thing which I would like to emphasize that in a health promotion, we talk about different settings. I will be talking school setting, workplace setting, community setting, hospital setting. And one of the most important setting is the school setting. You will all agree that our good and bad habits are formed in our child. If we are lazy from our school day, we are likely to be lazy, but you can change. Right? Those who are smoking from childhood, they are likely to be smoker. And if you can make one person quit smoking, I would say it is an achievement. I will give a standing ovation to that. Right? So I think this strategy of catch them young is very important. We have done a lot for health promotion, but I would request the Bharti Secretary also that this area needs a lot of attention. If we can, the best strategy for NCD is catch them young. right? If we can inculcate the habit of physical activity from childhood and other behavioral issues, avoid smoking, overall healthy diet, all these things they continue throughout their life. And but we talk about life course approach, starting from pregnancy, childhood, adolescent, and other periods. So health promotion area is very important, and we have also published this as a Hushiyarpur-Ambala model, and we have also calculated that what proportion of budget is required if we have to really implement health promotion program. It comes out to be 5% of the total budget, which is not high. Now, if you see the structure at the district level, who is delivering this health promotion program? This is through the district mass media and information office. Then block extensor educators at the block level, and then our health workers. But these district mass media and information officer and block extensor educator, they are doing everything but health promotion, right? And many of them, they may not be knowing the definition of health promotion. So what is required? Their capacity building. And we really need to strengthen the human resource aspect at the district and block level if we really want to strengthen this health promotion component. And asking for 5% budget allocation for preventive services in NCD is not a big deal. I think the ministry should give some attention to this. So with this, on behalf of this PGI Games collaboration and with the partnership of World NCD Federation, we welcome you all to this course, and I thank the team at AIMS, Dr. Anand Krishnan, Dr. Bari, and the other faculty colleagues, Dr. Pradeep and Mr. Chauhan, for gracing this occasion and be a partner for this journey which is moving on and getting strength day by day. Thank you very much.
Thank you, sir. Now I'd like to introduce Mr. Vishal Chauhan, sir. Sir is Joint Secretary, National Health Mission, Ministry of Health and Family Welfare, Government of India. Sir is 1988 batch IS officer of Sikkim cadre. Sir's key focus areas are non-communicable diseases, chronic kidney diseases, national program on mental health, blindness control, and etc. Sir, welcome.
Thank you very much.
I would like to welcome Dr. Pradeep Joshi. Sir is working as a National Professional Officer in WHO India office. I would like to request sir for his kind words.
Shri Vishal Chauhan ji, Joint Secretary Policy and NCD, Professor Anand Krishnan, Professor Bari, Professor J.S. Thakur, participants in person and virtual, as well as faculty members, a very good morning and warm greetings from WHO Country Office for India. Actually, Dr. Fikru was supposed to attend this session, but due to the prior commitment, he has given this responsibility to me to share his reflection, share his and WHO reflection in this course. As Professor Anand Krishnan sir and Professor Thakur sir has told that WHO is part of this course since its inception. And friends, I would just like to take you a little back when UN high-level political declaration happened in 2011. The countries started focusing on NCDs. And at that time, there was a greater need to build the capacity of all kinds of stakeholders, whether it is academicians, government, CSOs. And this was further reiterated in when SDGs were adopted. So this course, the International NCD course, is helping bridging this gap which is there regarding the skills, both at the country level as well as at the international level. You friends, you will acknowledge The NCDs are heterogeneous. The epidemiology is very heterogeneous across the states. And the highest burden or the largest cause of mortality and morbidity is due to the NCDs. But you will still know that the focus of the NCDs which is required is not acquired yet. And it is quite evident. You can see when there is a discussion at the state level, or when the progress report of the state is being there, or even say to the national conference, the NCDs were not there, but things are gradually improving, and some contribution goes to this kind of courses which generate awareness about the NCDs in that. Friends, with this unit high-level political declaration, there were follow-up in 2014 as well as in 2019. And in both this, it was clearly emphasized that the progress which is required is uneven among the countries. And basically, as Professor Thakur was mentioning, the four main pillars of NCDs which is required: multi-sectoral coordination, health promotion, health system strengthening, monitoring and surveillance is needed. And there is a great appetite for that. And if you see the structure of this program, current course, all this, and I thank to the organizers that they have covered all these components very comprehensively, and you will see the challenges and the enablers during these days of your course. Friends, the WHO also provides supports to the Ministry of Health, and we have conducted recently.
Can you mute them?
AIMS, the NPCDCS program review. And one of the key recommendation was there is a greater need of investment in building capacity because there is a high attrition rate, change of job profile, and the new NCD interventions are coming up. So it's a kind of a proud moment also for us, because this course is running from the last 7 years, and WHO primarily provides supports to the state nodal officers and district nodal officer to participate in this training. And as Professor Thakur was saying, we have covered almost all states and a significant number of districts. And indeed a proud moment that most of few of the state focal points are now, as a faculty member, they are in this course. One more thing I just want to highlight why this course is important. This is a unique kind of a course where you will find academicians, state program managers, civil society organization. So cross learning is promoted in this course. That is a very unique thing of this course. And lastly, I would like to comment on there is a greater challenge ahead. Why I am saying so? The Comprehensive National Nutrition Survey, which was conducted in 17-18, have shown that the pre-diabetic among adolescents is 9%, and stage 1 hypertension is more than 22%. And with the new guidelines coming of the hypertension and other things, the MMHG criteria has further lowered down. So you can imagine how much the epidemic we will be facing in managing those NCDs. So with this, I will end here and wish you all the successful deliberation, and hope this course will change the outlook about you, your outlook about prevention and control of NCDs, enhance your skills to manage NCDs in a better way, and improve that networking which is required for proper national NCD response. And one more small request is that once you finish this course and you fill the feedback form, especially what you would like WHO to contribute in the national NCD response, please share your feedback in the feedback form. We will be happy to contribute. Thank you. Thank you so much.
Thank you, sir. Now I want to call Dr. Bari for her inaugural presentation. Dr. Bari Daleen is professor in the Center for Community Medicine at AIMS New Delhi. Her key focus area is non-communicable diseases.
Okay, good morning, everyone. In the sort of inaugural presentation, as you said, I'm basically just trying to, I want to give an orientation or provide information to all of you about the WHO Collaborating Center who is the main organization who's hosting this um, workshop today, this time. So we are the WHO Collaborating Center for Capacity Building and Research for NCDs. And Dr. Anand Krishnan is head of the WHOCC. And we are a team of 3 members, and also other faculty members also contribute as and when the activities are there. We were designated as the WHO Collaborating Center in 2010, and we have been redesignated twice since then in every 4 years. So the last redesignation was in 2018. And the main activities of our collaborating center is basically to support the WHO in strengthening member states, not only in India, but the other Southeast Asia regional countries, and to assist the WHO in NCD surveillance and prevention and control efforts, policy making, and also promote research activities. So we have next slide. Yeah. So in this, I'm just showing you in a nutshell, right from the introduction of the, from the inception of the WHOCC up till last year, we have taken part in a number of activities which ranged from the evaluation of national health programs. We took part in the activities of the surveillance of in the NCD surveillance in India, as well as other Southeast Asian countries. And we contributed to the policy and other development of other policy documents. And also the most of the activities of the WHO India and CRO and even WHO headquarters. We mainly focused on surveillance capacity building, intervention, program evaluation, and policy making. And the surveillance activities are mostly, we had started with the WHO Collaborating Center had initially supported the Indian NNMS survey, which is the National NCD Monitoring Survey, which was conducted in 2003. And since then, we've also contributed to other countries like Maldives, Timor-Leste, Sri Lanka, and other countries in Southeast Asia. Then we also contributed to the capacity building activities and providing online and offline trainings to all the Southeast Asian countries. We took active part in program evaluation activities, particularly in the NBCDCS program. In 2018, we carried out an evaluation of the NBCDCS program. We also took part in the health and policy related activities like the global burden of diseases for India, and then even in other countries like Maldives and Sri Lanka and so on. We had prepared the contributed to the multi-sectoral action plan, which released this document, the National Multi-Sectoral Action Plan for the Government of India. And our activities didn't stop even during the COVID time. We had actually enhanced our activities and broadened our reach. And when we had taken part through the WHO India country office in doing an assessment of the emergency and the coping strategies during the COVID, and also brought out the NCD Health Emergency Framework we had also ventured into another area, which is the competency-based medical education, where we believe that the basis of everything has to start from the undergraduate curriculum. So we had done a competency mapping of the undergraduate curriculum for NCD from the NCD perspective, in 5 countries in Southeast Asia. So these are just very briefly about the activities of our network. And yeah, with this, I come to the end, and I thank you for giving this opportunity to share the activities of the WHO Collaborating Center. Thank you.
Thank you, ma'am. Now I like to call Mr. Vishal Chauhan, sir, for his keynote session on recent NCD prevention control initiatives in India. Yes.
Should I speak from there? You can speak from here as well. It's up to you. May I show his presentation? I'll start with it. So, first of all, Dr. Anand, Dr. J.S. Thakur, Dr. Pradeep, and Dr. Bari. Rather than calling the whole name. Dr. Bari, thank you very much for inviting me this prestigious course. Year also I participated in this course, and it was a very enjoyable experience addressing young participants from all the states and different parts of the country and some international participants. Non-communicable diseases, you are aware that these are known as chronic diseases, tend to be for long duration, a result of combination of genetic, physiological, environmental, and behavioral factors. So I think experts like Dr. Anand and Dr. Thakur will talk more about this. But what I want to highlight, from my side is that NCD estimate, yeah, it's not coming. That doesn't. Okay. And in which cardiovascular diseases are leading, about 27% mortalities are related to cardiovascular. Today in Parliament also we are answering this question, about the cardiovascular disease. On 8th, I am getting 20 questions in the Parliament. So I just wanted to convey that, it is getting prominence. Thanks to Professor Anand and Professor Thakur, who have been acting like a crusader in this area. It is really getting a lot of prominence. Lot of Parliament questions are coming. So it is drawing attention of the policy makers. It is drawing attention of the lawmakers that this is a problem which need to address head on. And also we are aware about the risk factors is that, 32% is the tobacco use, 15% is alcohol use. Then, yeah, we can, should I use this? Okay. Yeah, okay. Yeah. So, inadequate intake of fruits, and can we larger it? Okay. So fruits and vegetables and insufficient physical activities are the risk factor for this. So we, as Dr. Thakur was saying that, it is very important that how do we take the prevention and the promotive aspect of the NCDs. Now, Sustainable Development Goals number 3 belongs to the health sector, which says about good health and well-being. Next. Next. And what the goal says is that target 3.4 is by 2030 will reduce by 1/3 premature mortality from non-communicable diseases through prevention and treatment, and promote mental health and well-being. So there are next. Yeah. So there are national monitoring framework on the NCT. There are 10 targets to be attained by 2025. That is like, you can see 30% relative reduction in the prevention of tobacco use, 10% relative reduction in the use of alcohol, 10% relative reduction in the insufficient. So all the risk factors, there is a desire that we should reduce it by 10%, 15%, to control the NCD. Next. So these are, as I said, the risk factors like tobacco, alcohol, stress, physical activity, unhealthy diets. And one thing I want to tell you, which has not come into the focus, but it is there in the Western countries, social determinants of the health. What happens is that, it is not about the income as such. The longevity or the average age of the black in USA is less than the person in Kerala. While the income, absolute income of black in USA is double that, many times that the income of a person in Kerala, but they have lower longevity or healthy life, because there is a income inequality, there is a social inequality. So the earlier the perception was, if you are poor, you are more likely to suffer because of the communicable diseases like, diarrhea. If you don't get clean water, you don't get fresh air, you're likely to suffer with malaria, diarrhea, these kind of communicable diseases. If you are rich, you will affect the you will get affected with the lifestyle related diseases like diabetes, hypertension, and cardiovascular diseases. But it has also shown that absolute income doesn't mean anything. It is the income inequality. It is your social network, which is very. When I was in King's College, I wrote a paper on this, and a study has proved that even if you have the if you have a social network, your chances of getting affected even from the flu are less. So if you have a social network, you have a friend circle, your chances of survival of heart attack is far better as compared to the other person. So it is very important that we also start talking about the social determinants of the health, about income inequality, about early childhood development, and all these things. So I'll restrict myself to this. So I'll talk about, we have a national program for control for cardiovascular diseases, diabetes, and stroke. Next. NPCDCS is started in 1975 as a vertical national program. And then it was 2008, it was piloted in 10 districts, then in 100 districts in 2010. And then it became part of the National Health Mission. It got enrolled in the National Health Mission in 13-14. Now, then in 15-16, 468 districts were covered. Then in 2017, a major change was come, which Dr. Thakur was talking about the surveillance. We started population-based screening. Now, this is very important. Under this program, every 30 plus population is done the population-based screening for hypertension, diabetes, and the 3 common type of cancer. So that's the very important program is there. And then after that, we introduced alcoholic fatty liver diseases in 2020-21. Next. So what are the basic components about the NPCDCS program is health promotion through behavioral change, population-based opportunity screening, population-based screening for all the healthcare workers, prevention and control of chronic NCDs, capacity building for prevention, early diagnosis, treatment, rehabilitation, IC, operational research, support diagnostic and cost-effective treatment at all levels, develop database for NCD to monitor mortality, morbidity, and risk factors. Now, I must be very frank with you is that we are going to change NPCDCS guidelines in a very massive manner, in the sense that what has happened is that there is a lot of focus on the population-based screening, and then there are tertiary centers. In between, there is a big gap as far as the secondary care is concerned. Even at the village level, we do the population based screening, and we come to know that so and so maybe a suspect for a cancer. Then only solution for him is to go to the a tertiary care center, which may be in the capital of the state or in Delhi or Mumbai. They will end up in AIMS or in Tata Memorial. So what we are doing is we are trying to develop some strengthening at the district level also, where confirmatory test can be done at the district level or at the CSCs. So this is a major change we are going to bring in the guidelines. And also Tata Memorial Center in Bihar is doing very good work, in the sense that they are doing population based screening in the villages. So far they have identified some 800 cases in the Bihar, where they found that cancer is confirmed, and 200 they have done the operations also, or the necessary treatment. So there is a gap in between. Either we have tertiary care center or there is a population based screening. So that gap we have to fill up. So we are going to change in our guidelines. Next. So under the, I think one slide is missed. So under the NPCDCS program, we have state NCD cell, we have district NCD cell, and district NCD clinics and CSC level NCD clinics. Now the idea is that when we set up a district NCD clinic or a CSC NCD clinic, the focus is there on the NCDs. Otherwise, there are regular OPDs are there, but if there is an NCD nurse is there, if there is an NCD days are there, then we have seen that the improved outcomes. So it is very important that their fixed days are there at the CSCs. District hospital, it has to be on a daily basis, but in the CSCs, at least twice or thrice in a day, there has to be NCD clinics should be there, and people should come and for the treatment. So it brings a lot of focus. Next, this I have talked. Yeah. Now this is a paradigm shift with national health policy, and this was brought under the in the form of the Ayushman Bharat Health and Wellness Centers. As my previous speakers were saying, the earlier the focus was, or Dr. Pradeep was saying that focus was on the reproductive, maternal and child health care services. Today also, lot of budget of the NHM is going into the RMNCA plus kind of a adolescent health is also included in kind of activities. So what is happening is there has been a fantastic improvement as far as the infant mortality rate is concerned, neonatal mortality rate is concerned, maternal mortality rate is concerned. Fantastic decline. Our decline is better than the international decline or global decline. Fantastic work done. But also we have to say that NCDs are the next threat which is in front of us. As Dr. Thakur was saying, under the NHM, the expenditure of NCD is hardly 3 to 5%. So on the one side, we have a mortality of 63%. On the other side, we have, budget is only for 3 to 5%. So we have to address is to what this Ayushman Bharat Health and Wellness, centers have brought in is that besides the RM and CHS, which 5-6 kind of a services, earlier communicable diseases like malaria, filaria, all these issues were discussed, were treated, services were provided, and the maternal and child healthcare services provided. Now we have brought the NCDs also under the Health and Wellness Center into the fold of primary healthcare. That is why we call it comprehensive primary healthcare. So in this, mental health is there. In this hypertension, diabetes, 3 common kind of cancer screening is there. Then also we have in this eyes blindness control program is there. Then ENT program is there. So all these programs have been added. In fact, some trauma is also included. So all these were not there earlier. So we have enlarged the triangle. And then there is a referral gatekeeping is there. About the Dr. Pradeep was telling me that continuum of care, the study is complete. They will be sharing with us. So from primary health center, they are referred to the secondary or tertiary care centers, and they are reverse referral. So it's a bi-directional referral in the sense that if somebody has gone to a secondary or tertiary care center and prescribed for a medicine, say for a hypertension or a diabetes, so that monthly medicine should be available at the Health and Wellness Center. So that's the, bi-directional referral is there. Next. So this is about continuum of care I told about. one of the very important thing we are doing about is the CPSC NCD software. Now, what does this software talks about is that we, collect the data. We do the CBAC assessment. A starting point is the comprehensive assessment for the community. CBAC assessment where 25 or 26 related data is collected for the population. And what we come to know is that the risk factor is high in for diabetes, or risk factor is high for a cancer or for hypertension, and then screening is done. So we have a CPSC NCD software. And in that software, now it is also creating a ABHA ID. ABHA is, the unique health ID is now the ABHA ID. And that is the Ayushman Bharat health account. So right now we are having at least 5-6 portals in the health sector only. There is a there is a NCD portal is there. Then there is a TB, the Niksha portal is there. Then there is a RCH portal is there. Then there are so many portals. The blindness control, there is separate portal. Dialysis, we are making a separate portal. What is happening is field level officers have to do data entry multiple times. We are trying to link all this data through the ABHA ID, that if somebody data has been entered in the Niksha portal, then automatically that data will be, there's no need to do that again data entry in the NCD portal or in the RCH portal. Also, there is no linkage. If there is a pregnant woman having TB also, TB program doesn't know that she is pregnant because they have no access to the RCH portal. RCH program doesn't know that she has a TB also, because they don't talk to each other. So we are trying to do that linkage with this ABHA account, unique health ID account. So that is there. So that is a major change which is going to be there. Another thing what we are doing, using it for the continuum of care, in the sense that it has a QR code. It is a QR code. So somebody is referred to the district hospital. Then if QR code is scanned there, you get to know that so and so has reached the district hospital. You come to know through the system. So if you refer 10 people from the village, only 5 reach to the district hospital, 5 do not reach. So we have a follow-up mechanism that again 5 people have to be approached and they have to be sent to the district hospital. Now, after showing at the district hospital, after consultation, they come back to the village. They are supposed to collect their monthly hypertension or diabetes medicine from the village or the health and wellness centers. If they have not collected, then also you come to know through the QR code. Whenever they come for collection of medicine, the QR code attendance is marked. So if they don't collect their medicine, you come to know that so and so has not collected his or her medicine for the last 2 months or 3 months. So this is kind of a, we are trying to make a system for the continuum of care. And most of these practices we have taken from the ISCI project done by the WHO with ICMR. So we have all the best practices we have incorporated in the, and I think there is a separate session on the Indian Hypertension Control Initiative. So that is there. So another thing they ensured is very basic, simple thing is that, that health and wellness center should have sufficient stock for medicine for 3 months. These are very basic things to ensure, but it has shown that where the stock of medicine is maintained, the outcomes are far better. Another thing which we learned from COVID experience in Tamil Nadu is that when the COVID was there, they ensured that hypertension and diabetes medicines or NCD medicines are distributed door to door. Now they have made it a guideline, and now they have made a team, and these monthly medicines are getting distributed to the NCD patients in their house, so that they don't miss their medicine and there are no possibility of stroke, etc. So these are the new changes which are coming as far as the NCDs are concerned. Next. There is a tertiary cancer care centers. There is a scheme of the tertiary cancer care centers there. We are presently ministry supporting 39 institutions, 19 state cancer institutes, and 20 tertiary cancer care centers. Now, I did a study about the spread of the tertiary facilities in the country as far as the cancer is concerned. A large part of the country, there is a serious deficit. As per the WHO, we need to have 1 machine, one radiotherapy machine for 10 lakhs of the population. So we should have, if we take the population of the country as 135 crore, we should have 1350 radiotherapy machines all over the country. Sorry, I'm going into the tertiary sector, but I thought I'll explain to you. So we should have 1350 radiotherapy machines all over the country. Right now, we have only 700. So there is a huge deficit of the tertiary care equipments and machines or hospitals in the country. And all of this shortfall is in the Bihar, Eastern UP or UP or Jharkhand or Odisha or West Bengal or in the northeastern part of the country. So there is an uneven distribution of these facilities, and probably we need to think for some solution on the basis of revenue sharing model of Tata hospitals. Next. So this is next. So this is one of the tertiary cancer care center inaugurated by the government. Next. I will briefly touch upon the dialysis. Also, we have Pradhan Mantri National Dialysis Program, which is running in 35 states. Presently, 1054 centers are there, where 7,207 hemodialysis machines have been installed. And so far, 13 lakhs patients have availed dialysis services. And we have total 137 lakhs hemodialysis session. PM National Dialysis Program has really proved very helpful. There's a lot of dialysis has been done. So we are trying to ensure that all districts are covered. Another thing which has come is the peritoneal dialysis, where somebody sitting at his home only can do the dialysis, because at the dialysis center there is a long waiting list. And during the COVID time, we see there are a lot of problems dialysis patients face. So dialysis is also very, peritoneal dialysis, where one can do dialysis at his home. So there's a loss of wages also avoided. Next. So this National Multi-Sectoral Action Plan, just now Dr. Bari was talking about. So we keep on having meeting with the various ministries. As I said, they are social determinants to the health, and all the ministries, all the 15 ministries have a very important role to play as far as the non-communicable diseases are concerned. It cannot be only done by the health ministry. Next. Next, this is the launch of the non-alcoholic fatty liver diseases. Next. Launch of the COPD operational guidelines. Next. Next, I think this is it. Next. 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 So can we go back? Now I will talk about, we have 4 schemes by the name of Ayushman Bharat. It is in the series of Ayushman Bharat. First, I'll talk about the Ayushman Bharat Health and Wellness Centers. Now you are aware about it. Second is Pradhan Mantri Ayushman Bharat Jan Arogya Yojana. Now, in this scheme, it is an insurance cum assurance scheme. This scheme covers 3 days of pre-hospitalization, 15 days of post-hospitalization expenses. 1676 NCD related, procedures are covered in this. So far, we have 2.30 crore authorized hospital admissions in this scheme. Now, in this scheme, a poor family gets insurance or assurance coverage of 5 lakhs per year. And so far, 16 crore people are enrolled in this scheme. So this is also, there are issues because it is based on the SECC 2011 data. So there are problems where, some genuine people are left in this and some non-deserving have entered into this list, because this is a very old data or survey is there. But government, we are making all efforts to, improve, to work on this list so that maximum poor people are getting covered into this. And next. Now, another very, important scheme launched by government is the Pradhan Mantri Ayushman Bharat Health Infrastructure Mission. This is one of the biggest health infrastructure scheme is launched by the government. Total with the outlay of 16,180 crore. It's for 5 years. So in the COVID time, we faced a lot of problem. When what happened is that all routine hospital services got blocked because of the COVID. So is this scheme in every district of the country will have a critical care block, which in COVID kind of a situation will have a separate block will be there, and after the COVID is over, then it will serve the critical care patients. It has integrated public health lab. So this is a very ambitious scheme, and then there are some surveillance infrastructure is also coming under the scheme. Next. And last scheme in the series of Ayushman Bharat is the Ayushman Bharat National Digital Health Mission. Now, this is also a path-breaking scheme. I said that one is that we have every citizen of the country will have a Aadhaar ID. And then I said, I gave one example how this is going to be helpful for all others. Now, in this Aadhaar, you know what, it will maintain digitize all health records. Now, what happens is that we maintain a data of the citizens in the CPSC NCD portal. We have a longitudinal data that this person in 2015 detected with a hypertension. Then it was uncontrollable in in 15, then 16. Every month or every 6 months, hypertension is recorded and it is there in the CPSC system. Now somebody gets referred to a district hospital. He need not carry all his reports to the district hospital, or somebody is referred to a tertiary sector. What he does is he gives his Aadhaar ID. This is my Aadhaar ID. And the hospital, say, suppose somebody is staying, lives in Balia, reaches Lucknow in a government or a private hospital. Then what he does is he gives his Aadhaar ID and with the permission that my health record can be accessed from the CPSC NCD app. So doctor or whatever testing has been done, whatever test report or diagnostic reports are there, doctor need not seek the full, they can access the data from the CPSC NCD portal. It requires permission of the patient. So it will ask permission of the patient. Do you want to share your record related to cardiovascular disease with the government hospital in Lucknow? If he says yes, it can be shared. If he says no, it cannot be shared. Or if he says that, okay, share my records related to cardiovascular disease and not related to mental health, it will not be shared. So we are trying to do this kind of integration. I don't know to what extent, what kind of a shape it will take place, but this looks very exciting as of now. So these are the some newer initiatives are there. One is like multi-sectoral action plan we have discussed, non-alcoholic fatal liver diseases. There is a joint framework for tuberculosis, diabetes collaboration is also there. India Hypertension Control Initiative, I think WHO will be making a presentation to that. Urban area is, there is a lot of issues in the urban areas because they don't have a well-defined network of the hospitals. Now, under the 15th Finance Commission, some 70,000 crore is going for the strengthening of the diagnostic activities and for the infrastructure. And in this, 26,000 crore is going in the urban areas. And also last, I will talk about, some, for stroke and, STEMI intervention, because southern states like Tamil Nadu and all have done wonderful work as far as the STEMI is concerned. So if somebody is going through the cardiovascular event, then his ECG is forwarded to a control room and then they suggest for the necessary action. So this kind of arrangement is also there and we are trying to include in our guidelines also. So I'll stop here and I talk to you about some major interventions going on in the NPCTCS program. And if there is any question or suggestion, I'll be very happy to take. Thank you very much.
Thank you, sir.
Thank you, Mr. John, for that excellent overview. And as you can see from our program, almost all those initiatives that we talked about, we will discuss in detail by the concerned person in the ministry or in WHO or experts, including on CPSC software, there will be a presentation on CKD, there will be a presentation on everything that we discussed today. I think he gave us an overview, but we will take up each one of them in detail as we go ahead in the workshop. As you can see, we have Today we focus more on epidemiology and burden. Tomorrow we focus on health promotion, multi-sectoral action. Day 3 we focus on health system strengthening. Day 4 we focus on surveillance, monitoring and evaluation. And day 5 is sort of wrap up. See, we started working, I and Dr. Thakur on NCDs in 2002. At time there was, even WHO was not talking about NCDs. WHO just started talking. In fact, I started working with WHO in 2002 when they started and set up all within the WHO itself. Even country office did not have anybody in WHO. Dr. Cherian Varghese joined the country office as his first national professional officer. He will talk to you tomorrow, I think, right? So he was the first national professional officer in the country office, somewhere around 4 or 5. Yeah. Dr. Thakur also spent some time in the WHO India office as a national professional officer. And just after, I think Dr. Varghese was the person who was there. So I have spent time in the WHO regional office for many years. So among I and Dr. Thakur and many of the initiatives that you heard, we have been part of the committees or thing which we have, which I find the guidelines and those kind of things. But it is good to see that what Dr. Chauhan, Mr. Chauhan said, that there's a lot of now questions being asked in Parliament about NCDs. That was unheard of in the term that nobody used to talk about NCDs. They would say, no, because NCDs was largely thought that government does not need to do anything. It is individuals' problem. People smoke, people take high fat diet. Why should government? That was the thought process in 2002. So 2 decades, and I think there has been a complete paradigm shift in the way that we approach the NCDs. Now it is looked up as a perhaps the most important public health problem, though we still, as he said, there is still a lot of RCH in the system. Obviously, those need to be catered to. There is no competition. It is not that NCDs is going to compete with RFNCH, but the NCDs have to get due weight in the system as per its burden, right? And I also like what you talk about inequities. I think that was a very important consideration that we'll have again a session on inequities and how the socioeconomic determinants, social determinants, we'll have those later today when we look at those kind of issues and how we address inequities. In fact, one working group will look at inequities and how we can address inequities following that. And obviously health system centering, and again, initially when the NPCDS was started, the focus was more on tertiary and some on secondary. Primary was not that much focus when we started NPCDS. It's very good to see that that has been now rectified, and we are going, especially with the health and wellness centers and all strengthening of primary healthcare. And we again have a lot of discussions on the primary healthcare related initiatives and people-centered care, how we can make NCDs more of something that people can engage with it. It's not just a health system that is involved party here. We'll have long discussions on CPHC software, including from the Dell people who are making that software, representations from IHMI. So all these initiatives we will cover in details. So as final, my words are that today we see there is a lot of political will. We have very committed bureaucracy. And if you have trained health sector, I think there is nothing that we cannot achieve in the area of NCDs. All things are now merging together. And I see great potential of our country doing very well in addressing NCDs in the future. Thank you, Mr. Vishal Chauhan, for your overview, and thank you. Maybe we can take a break for tea coffee now. Yeah, we'll take a tea break. Thank you, everybody. We'll rejoin in about 10:30. We'll reconvene at 10:30. Even for people online, please have a cup of tea and then join us back on 10:30.
For his session on mortality, morbidity due to NCDs in India, Dr. Sunny Sonkar is Deputy Assistant Director General, Director General of Health Services, Ministry of Health and Family Welfare. Sir.
Good morning, all of you. And I'm taking the small part of NCD, what we have discussed in morning in the JSR presentation. That's an overall overview of the national program. So if we know what to do in the NCDs. So we must know the what are its what is the burden of disease in our country, what is the mortality rate, morbidity rate, so that we can plan our strategies according to them, and how can we integrate many of the NCDs into one. So let's see what is the disease burden in NCDs in India. Before going to detailed presentation of each and every aspect of disease, we must know the holistic approach of the health in our country. That is, we have the promotional aspect, promotive aspect, preventive aspect in on one hand, and another we have therapeutic and rehabilitation aspect. NCDs, we all know about that. This is it's not like communicable disease. We have the prevention. If we prevent NCD through promotive and preventive aspect, we can save many lives in our country. So this is really more important that in our society, in our premises, we should have this promotive and preventive part first, rather than therapeutic and rehabilitation. Yes, of course, we need that therapeutic and rehabilitation part, but if जैसे कहते हैं ना कि prevention is better than cure, so it's really important we should focus on the preventive part first. As we all know that chronic, it is a type of chronic disease and tend to be a long duration and result for the combination of genetic, physiological, and environmental behavior risk factors. And we have most common type of NCDs are cardiovascular disease, cancer, CRDs, and hypertension, diabetes, which is most common in our country. And we have major risk factors. I'm not going to much of detail of risk factor, as we have another section by Professor Dr. J.S. Thakur sir. He will talk about this risk factors in detail. So come to directly at the WHO did some exercise in 2018 and published their report where we said that all out of all deaths in our country have 63% burden due to NCDs, which accounts cardiovascular disease almost 1/4, 27%, and CRDs on second highest is 11%. Then subsequently cancer, diabetes, and other NCDs. If we see the restricted in the age group like 30 to 69, 30 to 70 years, so this proportion rather than to decrease, it increased in the CVDs and cancer. So in the government policy, in the morning session, JSR mentioned that we have a program where currently we are taking the screening part of more than 30 years of age. So this is the reason we are taking 30 years of age on priority. With respect to NMS National NCD Monitoring Survey, which was happened in 2017-18, if you see the result of risk factors, so inadequate diet is most common risk factors come out with this to have this NCDs in our country, which is almost 100%. Our dietary habit are really not up to the mark, and people are suffering with the either overweight or underweight or malnutrition or overnutrition. So we have to be very careful about our diet first. Then physical activity is the second most common risk factor, which is really have in our country. एक बार कुर्सी पे बैठ जाते हैं तो उठने का मन नहीं करता, like that. So we really think about at least in an hour we should have a 250 steps, so that this physical activity is more important. Now we can have the disease burden or disease wise and mortality in our country. As per the our National Cancer Registry Program report published in 2020, the estimated number of cancer prevalence in our country is about 35 lakhs. And the incidence is about 14 lakhs. The people are increasing by 14 lakhs per year in our country, and that's about 7 lakhs. This data is underreported. I must say this data is really underreported. We don't have registry across the country. If you see the globally in China, so they have better monitoring system, and quoting the almost 45 lakhs cases in their of cancers, and around 23 lakhs in USA. I would like to mention that we have variation in our country. So the disease variation also can see, if we talk about Uttar Pradesh, so we have more than lakhs every year registry of cancer patient. Then Bihar is the highest number, West Bengal have the highest number, Maharashtra and MP. These are the most common cancer prevalent states. And recently we don't have any published data, but recently we are have a big number from the northeastern area of cancer. If we talk about different cancer, so I have some data on breast cancer and cervical cancer. So every year more than 1.5 lakhs patients are registered in the cancer registry, have breast cancer, and about 1 lakh for cervical cancer. So we discuss about cancer, so a huge burden in lakhs. So if we go for diabetes, it's not in lakhs, millions. So the estimated population, if you talk about 0 to 19, the type 1 diabetes, around 2.3 lakhs in 2021. It is published in the 10th edition of Diabetic Atlas 2021. If we talk about 20 to 80 years, so we have estimated 75 million cases of diabetes in our country, and expected at 125 million by 2045. So we have right now the communicable kind of illness and maternal and child health priority. But if we see the burden of which is upcoming in the years of NCDs, it's very huge. If we talk about non-alcoholic fatty liver disease, so it's cross-cutting issues with all other disease. So very common disorder affecting may have many as 20-30% in general population across the world. And epidemiological studies also suggest we have almost 9 to 32% prevalence in our country also. Basically, NFL is more common in people who have certain condition like obesity and type 2 diabetes. So as I said, this is overall, if other disease happen, so uska impact on other organ may happen. So this is why we have cases of NFL. So the cancer we have, diabetes we have, NCD is very vast. So if we talk about lung, so lung we have COPD and asthma. So COPD has in India around 38 million cases of COPD, which account 18% of the global burden. And we are ranked number 2 in the world of COPD deaths. So we are standing on top 10 in any disease. So we really think to have a common goal and platform where we can provide the services to the community. That is only way is prevention. India is ranked number 2 in the world of COPD death, which accounts for 27.3%, and we have Delhi around 28%. tobacco smoking contribute, we are thinking that tobacco has a major role of smoking for lung cancer or COPD or asthma or emphysema. But the contribution of this disease is more than 50% is due to air pollution. If we talk about asthma, so asthma has worldwide around 262 million cases. And India has estimated around 35 million of asthma, contributing 13%, which is highest in the world. So we are ranking #1 in the world for the asthma cases. So we have disease, diabetes, hypertension. The consequence may be either the cardiac failure or through stroke. So if we talk about stroke in our country, the stroke is second leading cause of death worldwide, and India, we have around 163 cases per 10 lakh population. So, and if we talk about the ICMR studies, which says that stroke is the fourth leading cause of death in our country and fifth leading cause of daily. We have so if you see the report of 2016 publication, which says the cardiovascular disease on the #1, the second is COPD, the third is other, and the fourth one is a stroke. So we have very huge related to, and nowhere is any communicable disease in top 10. So if we talk about the risk factors of tobacco, and we have data due to tobacco, we have deaths around more than 8 million per year. And India is the third largest producer of tobacco. I'm not going to in that much of detail, as Thakur sir will present all this risk factor in detail. But I would like to just mention about we have the tobacco as a risk factor, we have physical inactivity as a risk factor, where due to inactivity, physical inactivity, we have produced 30% increase of risk of death as compared to have sufficiently active. The diet, if we talk about salt, we have recommended 5 grams per day, the maximum limit, but the survey says we have estimated mean is 8 grams. So how is contributing for hypertension, the disease? So we have another problem of alcohol. Worldwide, 3 million deaths happen due to alcohol only. So ultimately, we will have hypertension and high blood sugar. So we all are in these diseases in millions only, not in lakhs, nothing. We have deaths in millions, we have cases in millions, and we have the physicians and the healthcare staff in our country very limited. So the most of the things we have to give in the prevention part is really required. Another is obesity, and we also right now suffering the childhood obesity, and if we say around 340 millions, which is aged from 5 to 19, are overweight in the world in 2016. These are the major NCDs which you must be knowing all these NCDs. And apart from this, we have other NCDs like mental health. So mental health, we have challenge around the lifetime prevalence is 13.7% and current prevalence is 10.2% total population. So this is another aspect of our NCDs, which are not taking in our account in the main NCD area. And we have road traffic accidents also, which is also NCDs. And around the road traffic accident account 3% of India's GDP, which is being lost due to injuries and accidents and disabilities. And the another statistic we have of the proportion of population over 60 years of age. It is estimated that around 17.3% population will have by more than 60 years of by 2050. Around 8% elderly are bedridden right now, and quality of healthcare to the elderly population is a question mark. Are we taking care of old age people? So ultimately, this slide must be shown by JSR also. So I'm re-emphasizing on this slide that ultimately with this risk factor, we have NCDs, ultimately leads to reduction in income, then poverty. So it's a vicious cycle. Yes, of course, as I repeatedly mentioned that up to 80% cases of CVD, diabetes, hypertension are estimated to be preventable. So the prevention is more important in our country. I got this some in WHO website that is very interesting. If we invest $1 in tobacco smoking, reduced to tobacco smoking, so our return in terms of for the country's benefit is more than 7.5 times. If we talk about the unhealthy diet, if we reduce by investing only $1, so our output will be 13 times. So this is the something which is really need to have really invest in ourselves, in our family, in our country, in our community. So that's all from my side, and we in the next session we will have risk factors of NCDs in detail by Professor Dr. J.S. Thakur, sir. Thank you.
Hello. Hello. Thank you, sir. I like to request Dr. J.S. Thakur for his session on determinants and risk factors for NCDs.
So once again, very good morning to all of you, and we are going to discuss the determinants and risk factor for non-communicable diseases. The first lecture taken by Dr. Sunny was quite useful, where we have discussed the morbidity and mortality, right? And in continuation with that, he has already covered some of the risk factors, which I will be also discussing in detail. My voice is audible? This one. Now, in this presentation, I will discuss transitions in the society. Our society is changing. Is it okay now? Little bit about burden, though already covered. NCD epidemic and determinants, and what are the strategies. You know, over a period of time, our society is changing. And we describe this change as transition. And these transitions are demographic transition, economic transition, social transition, nutritional transition, epidemiological transition. When we say demographic transition, it means that our population is changing. The lifestyle and the life expectancy is increasing. So the population or the aging population is increasing. And there is a concept of, risk. Risk start from childhood and it keep on accumulating throughout our life, right? So if we have more aged population, we will have more non-communicable diseases. Then economic transition, increasing per capita income, globalization, and marketing. Now I have seen, and I think you might have also experienced. Let us take this food market. A lot of globalization is there. So many companies, Swiggy, Zomato, they have come up. Foods are being delivered at the doorstep, right? So with increase in our income, our eating habits and the food practices are also changing. Now, in this type of food, you know that the quality is not that appropriate. If you have most of these products and particularly fast foods, they are not good because they may have more refined carbohydrates, right? More fat, right? Salt content may also be high. I mean, if you take the example of KFC, you have this fried chicken. After deep frying of this chicken, nutritionally, what is there? Khatam, right? So we really need to see. Then social transition. We are a developing country, industrialization and resulting urbanization, breaking families. So moving from a traditional system of joint family to a nuclear family. This is what is happening. So in this system, there was in a joint family system, there was a lot of social security in terms of giving some wisdom by the elders. And secondly, those who are having small children and if their families are staying, the mothers know the importance of elders in the family. There are instances where, children are tortured in such type of, crutches or other places also. So this transition is also, social transition is also important. Nutritional transition, I have already discussed a little that our traditional Indian diet was cereals, dal, pulses, vegetables, salad. It was a very balanced diet, but we are moving now to a fast food culture. Even if you go to the rural areas, you will find all these fast food, chips and other things which are available. The most dangerous thing is to eat these chips. The potatoes which are used for these chips, they are produced in 2-month period. And the amount of pesticides used in these, huge. Epidemiological transition. In the morning also it was discussed that historically we were having more problem of communicable disease. With the improvement of these diagnostic and the treatment facilities, they have come down and the non-communicable diseases are increasing. So all these transitions, they need to be understood and they are fueling the epidemic of non-communicable diseases. Burden we have already discussed, but if you see at the global level, NCDs are #1 killer in Southeast Asia, India, contributing to 72%, 64%, and 62% of all the total deaths which are happening. This slide is very important. That what is the probability of dying between the age of 30 to 70 years? That is the premature mortality. We were discussing a target also, that we want to reduce this premature mortality by 1/3, right? And if you see, this premature mortality is highest in Southeast Asia. On an average, Indians are dying 10 years earlier as compared to their Western counterparts. And this is also true for Asia because of certain reasons, and which, there are certain genetic influences. There are many hypotheses. I will not get into, but this is a very substantial number of premature. You will find, people, heart attack happening at the age of 35, 40. This is quite common now. And over a period of time, there will be a shift which will happen. And if we see the trend for 2015 to 30, there is increase in the mortality in all non-communicable diseases. Now, coming to the risk factors for non-communicable diseases, we have behavioral risk factors, which are tobacco, unhealthy diet, alcohol, physical inactivity, which leads to the intermediate risk factor. As I was mentioning, that once you are exposed to these risk factors, the risks start accumulating, and then we will have this, physiological risk factors, that is raised blood pressure, raised BMI, dyslipidemia, raised blood glucose, and eventually they transform into the various non-communicable diseases like cardiovascular disease, cancer, COPD, and diabetes. Now, this is very important to understand, and Mr. Vishal Chauhan was also talking in the morning. The social determinants are very important in it, and very few of us, understand what are social determinants of health. They could be social, for example, age, economic, cultural, environmental. Right? All these factors are very, very important, and they need to be understood. For example, I was talking about globalization, right? So, and giving the example of food market. Food industry is so aggressive in promoting their products that our government advertisements are nowhere. Coca-Cola. ठंडा मतलब कोका कोला। अब गांव में लोगों को क्या है, अब गांव में पहले लोग लस्सी दिया करते थे जब आप जाते थे, अब क्या देंगे, कोका कोला। उनको लगता है कि ये पता नहीं क्या चीज दी जा रही है। हमने अपनी ट्रेडिशनल प्रैक्टिसेस जो हैं वो हमने सारी चेंज कर दी, बिकॉज देयर इज सच ए एग्रेसिव कैंपेन कि वो उनको लगता है कि ठंड जो मिलेगी वो कोका कोला से ही मिलेगी और कहीं से नहीं मिलेगी। Or you all know that Coca-Cola is nutritionally very bad. How many of you are drinking Coca-Cola or cola? We may not be raising their hand, but we have to be honest, right? Stop taking it, right? And there is a cartel of this food industry. They are so aggressive in their campaign. PepsiCo, Coca-Cola, Nestle, right? KFC, McDonald's. They have made a food industry cartel, and I had the opportunity to participate in one or two of the meetings where they were present. They are virtually bullying the experts. They don't allow the expert to speak. This is such a strong industry, and some of the people, we have a regulatory body in India. What is the name of a regulatory body for food? FSSAI, Food Safety and Standard Authority of India. And some of the people also say that this food industry has a lot of influence on this. How much it is true, but industry, they are very. There are 3-4 industries which are very aggressive. One is food industry, another is alcohol industry, and the third is tobacco industry, and the fourth is pesticide industry. They can even kill the people. There are instances in the country where they have killed the people who are activists. Right? So you have to work against, these people, and they are not in the health sector. So social understanding of these social determinants are very important. They are also called causes of NCDs. Right? The risk factors are causes, but social determinants are causes of causes, and same thing is depicted in this diagram. So these underlying drivers, social determinant of health, are very important. Globalization, urbanization, population age. Now India used to be country of villages, but what is happening? Migration is happening from rural to urban area, and these people, they are settled in mainly a middle class person or a low socioeconomic status. If he or she comes to Delhi, where they will settle? JJ colonies, Juggi Jopadi colonies. And they have lived in the rural life, having all clean air, water, sanitation, other facilities. And here, what is this they are exposed to? All risk factors related to, starting from the air pollution, tobacco, alcohol, stress, they are all contributing. Right? And now, earlier we used to call that NCDs are diseases of affluent, rich people. This is no more true. Rich people like you, they have started changing their behavior, but poor people, they are still exposed. So this social gradient which used to be there is reversing. We have done some studies on this social gradient in northern India and have found that risk factor distribution is same among the urban, rural, and poor people. This diagram you have already seen. So now there are 5 NCDs major, that is cardiovascular diseases, chronic respiratory disease, cancer, diabetes, and mental disorders. They are also very, very important. And the risk factors are unhealthy diet, tobacco use, harmful use of alcohol, physical inactivity, and air pollution. Air pollution is those who are from Delhi. We know that air pollution is a very, very important. We had the opportunity of doing some time series studies in India, where we have seen that what happens if your air pollution increases. And in winter months, air pollution usually increases, and during that time, you will have more cardiac events as well as acute respiratory events. Those who are suffering from asthma or COPD, they will have more emergency admissions. So there is such type of studies available from Delhi also and other part of the country. Now, if you see the Delhi attributable to top risk factors for both sexes, and this is the data from the Global Burden of Disease Study 2019, you will find that high systolic blood pressure is at the top, followed by smoking, high plasma glucose, high body mass index, LDL cholesterol, ambient particulate matter, pollution. So these are the ranking of the risk factors which are important. Now, what happened over a period of time? This is the trend for the last 10 years. That is change in Delhi attributed to the risk factors. Delhi is a disability adjusted life year. And what does one Delhi means? 1 year of healthy life lost. And what is there in the Delhi? It is a composite measure which measures premature mortality and disability. Right? For example, if somebody is having a stroke, right? So you have chances of premature mortality. That person may die even in the first stroke, or if there is a second attack, the likelihood increases. But at the same time, if the person is having a paralysis, facial paralysis or the limb paralysis, there is a substantial amount of disability also. So the daily for a condition like stroke will be high. Okay. So you can see that over the period of 10 years, this high blood pressure, tobacco, fasting plasma glucose, their ranking has changed. What has happened? They have come higher in the ranking. Earlier in 2000, malnutrition was number 1, right? Now you can see this high blood pressure was at 4, but has come to number 3. Tobacco from 5 to 4, right? So this is the situation which we are seeing. Now, if you see the Delhi attributable to the leading risk factor by sex globally, again here you will find that dietary risk, high systolic blood pressure, tobacco, air pollution, high fasting plasma glucose are important. This is the data from India, prevalence of overweight and obesity among the urban adults. You have also heard Dr. Sunny also. So you can see that the prevalence of overweight and obesity is high in the country, more among women as compared to men. Why it is so? Why overweight and obesity is more among women? They are more leading a sedentary lifestyle, right? Similarly, if you see the prevalence of hypertension among the urban adult, right, you will also find that the prevalence varies from 15 to even in different states of the country. Despite we were talking about India Hypertension Control Initiative. And this is the prevalence of diabetes among urban adults, right? And this is all the data is from the National Nutrition Monitoring Bureau. And here also you will see that the prevalence of diabetes varies from 10 to 20%, but in some of the states like Puducherry, 34%, which is very, very high. And we have also seen the association of hypertension and diabetes with the BMI. So if you have, this is the normal and the overweight, this red part bar represent the overweight or obese part, and blue is the normal. And you can see that those who are overweight and obese, they are having higher prevalence of hypertension and diabetes. This is our own study from the Punjab, that is comorbidities and overlap between diabetes, hypertension, and dyslipidemia. This is another problem that all these NCDs, they coexist. If there is a diabetes, there may be hypertension or dyslipidemia, and these are the figures which are there from Punjab, where this comorbidity has been found to be high. And so diabetes and hypertension, they are also taken as risk factors, right? We also need to know that. Now, this is the point change in the prevalence of overweight and obesity and underweight in the last 20 years in India. So what has happened over a period of time? So this overweight and obesity is increasing in the country, but at the same time, we have a problem of malnutrition or undernutrition. Now, if I have to start a NCD program targeting malnutrition, it cannot be same in every part of the country, right? For urban area, overweight or obesity may be a problem. So I will focus more on overweight and obesity. But in slum areas, you may have undernutrition, which varies from even 30 to 40% in some of the slums. So there, your strategy for diet has to vary, right? It cannot be same intervention everywhere. Now, this is also the data from the STEP survey which we have done, and I'm sure under surveillance you will discuss this stepwise approach to NCD risk factor surveillance, and I was referring in the morning. So, what is the situation in Punjab? Less than 5 servings of fruits and vegetables are not consumed by about 95% of the people, despite the fact that Punjab is known for growing vegetables. We were puzzled when we have this type of figure. We did some focus group discussion, and the response which we got was quite surprised. क्या response मिला होगा? कहते हम पेस्टिसाइड इतना यूज करते हैं वेजिटेबल में, ये अपने आप नहीं खाते हम, ये तो मार्केट में बेचने के लिए है। हम तो दालें और चिकन खाते हैं, राइट? एंड रेज सॉल्ट इनटेक 80 to 90%. High blood pressure, 40% of the population is hypertensive in Punjab, right? And if you take this low physical activity, almost 30%. And if we combine overweight and obesity, it is also 40%. And if you take Asian cutoff, 58% of the people in Punjab are overweight and obese. And if you take base circumference, हमारे in this country, this is also a sign of prosperity. पेट किसी का बड़ा हुआ है तो लोग कहते हैं खाता पीता आदमी, और पंजाब में है ये तो देखो पेट निकले है कि चौड़े होके चलते हैं वो उस तरह से. And when we take this central obesity, then it is 80% in Punjab. So you can see we are seeing the epidemic. Another important thing here to understand is that even alcohol consumption is also quite high, that is 27%. It is reflected, among women it is 0.3%, but there is some underreporting. Many women, they are drinking, and I am not judgmental. They have every right. If men are doing, they can also do it. But when it comes the question of reporting, they will not report, right? Unless you use all these skills. I was reviewing one thesis for Punjab University girls. What proportion of them were drinking for MPH? It was almost 70%. And around 75% were smoking. Smoking has also been, but our national surveys are not capturing, because they will not say to the interviewer that they are smoking. I think that thing should be kept in mind while doing such type of surveys. Now, what is the situation in Haryana? The same situation in Haryana in terms of 5 surveys. 99% of the people are not taking 5 surveys. We will discuss serving during the subsequent lecture. 1 serving is equal to 80 grams of fruits and vegetables, and 4 serving around 400 grams. And we have done some calculation in Indian terms. हम सर्विंग के हिसाब से तो नहीं ना खाते, हमारे तो कितनी कटोरी सब्जी खाते हैं, कितना सैलेड खाया, right? कितने फ्रूट्स खाए. So we have done some calculation. If we are taking a average plate of salad, 2 katoris of vegetable and 1 seasonal fruit, it constitutes roughly around
5 servings, right? How many of you are eating? Raise your hands. Very bad. So we have to become practitioner. High salt intake, almost 85 to 95%. High blood pressure, almost 26%. But in Punjab, it was 40%. Alcohol use, 18%, 0.2%. Right? Physical activity. Haryana is one state which has a sport policy also. Here you can see their low physical activity prevalence is only 15%. Right? And overweight, obese. One important thing which you will understand in both the surveys, raised albumin creatinine ratio in the urine. This is an indicator for large proportion of people who are untreated for diabetes. It is the risk of the chronic kidney disease, and it is high in both these states. As I have mentioned, NCDs are interconnected. If somebody is hypertensive, he may be having, say, diabetes, and also coronary artery disease. So multi-morbidity is a very important feature in non-communicable disease. But if you even see the program, is there any guidelines to address this multi-morbidity? अब जिस फैमिली में इफ यू हैव ए पेशेंट, आप किसी बड़ी इंस्टीट्यूशन में एम्स या पीजीआई में चले जाते हो, गया कोई आप में से जिसके फैमिली में एनसीडी हो और ऐसी इंस्टीट्यूशन में गया, आपके जूते बसते एक डिपार्टमेंट से दूसरे डिपार्टमेंट में, दूसरे से तीसरे में, तीसरे से चौथे में, एक लैब से टेस्ट करवा के दूसरे लैब में, और एक आदमी नहीं आता पेशेंट। लोग कहते हैं एक ही अटेंडेंट लेके आओ। हमारे देश में कितने अटेंडेंट लेके ऑन एन एवरेज चलते हैं लोग? 2-3। एक उसके पास रहेगा, एक वो चक्कर काटेगा, है ना। 2 तो मिनिमम होते ही हैं। आप देखोगे हॉस्पिटल के प्रेमिसेस जो हैं ऐसे लोगों से भरे हुए। क्यों भरे हुए हैं? बिकॉज हमने एनसीडी की जो केयर है उसको फ्रेगमेंटेड रखा हुआ। आप कैंसर का ट्रीटमेंट, अब कैंसर में देयर आर 3 थेरेपीज विच आर इम्पोर्टेंट: रेडियोथेरेपी, कीमोथेरेपी, मेडिकल ऑन्कोलॉजी, सर्जरी, सर्जिकल ऑन्कोलॉजी। अब इंस्टीट्यूशंस में ये बहुत कम इंस्टीट्यूशन है जो जहां एक रूफ के अंदर है, अदरवाइज चक्कर काटते रहे। सो ये जो चक्कर है ये बहुत इंपॉर्टेंट है। और एनसीडी पेशेंट में आपकी किसी ने रिस्क असेसमेंट की जब आप जाते हो? Why this if there is a patient of cancer, is anybody doing the risk assessment that which risk factors have contributed to this? This is very important, right? Under the program there is a checklist which will be covered. What is the name of that checklist? CWAG. What is CWAG? Community-based assessment checklist, which is used for assessing the risk. Unfortunately, it is not a validated, checklist, and we should use a sort of a composite risk score, which is validated. Right now, how much is the time allotted to you? Okay, so we also need to see that strategies for prevention and control, they are population strategy and a high risk strategy. Population strategy means you cover whole of the population. High risk strategy means that you have a clinic where you identify the people who are at risk, that is overweight, obese, smokers, taking alcohol. So this will be covered in the subsequent lectures. We have discussed about these 3 pillars, that is surveillance, prevention, and management. They are the 3 pillars, and 4th is multi-sectoral participation. We want to have this type of arrangement, if we really want to deliver the program. Surveillance means mapping the epidemic. Prevention means reducing the level of exposure to the risk factors. And management means those who are suffering, they should access the treatment and diagnosis. दवाइयाँ मिलती हैं हमारे सेंटर्स में. बहुत कम जगह मिलती है. Secretary was saying in the morning, we have made the provision for 3 months. Tell me, show me any center where you are giving medicine for 3 months. I will start dancing. Right? And कितने दिन की देते हैं? 3 दिन की. जब 5 दिन की, जब 10 दिन की. So we really need to change our mindset. Now, when we are talking about determinants and risk factors, we should think of this global monitoring framework, which was discussed in the morning also, that there are 9 targets and 25 indicators which are achieved by 2025. And in India, we have a national action plan where there are 10 targets and 21 indicators. The 10th target being the indoor or the household air pollution. So in these targets, there are targets related to morbidity, mortality, risk factors, and the health system. So unless we address these risk factors, we may not be able to, achieve these targets and reduce the burden of non-communicable diseases. As we were discussing in the morning, 80% of the NCDs are preventable, around 70% of cancers are preventable, but there is a little focus on prevention, right? And you will be discussing best buys also, what are the cost-effective interventions in the subsequent. These are some of the key initiatives which we have developed. In NCD surveillance, we have developed a mobile app for doing NCD surveillance. In fact, our step survey in Haryana was totally paperless. In service delivery, we have primary healthcare models, task shifting. Some of the tasks can be done by the nurses, but nurses are very underutilized in this country. We rate them very low as a profession, but they can do many things. Implementation research is important. And in health promotion, we have models for schools, workplaces, and community. I will be discussing in the separate lecture. I think we have already discussed. All these efforts are achieving the target of health and good health and well-being, that is 3.4, that is of reducing the premature mortality by 1/3 by 2030. And this is not possible unless we receive the give due attention to the risk factors. So we know that, just to summarize, the key messages are that burden of NCD is high. There are 5 major risk factors and they need to be addressed. But at the same time, we have the multiple drivers which are causes of causes, like social, economic, and behavior. And it calls for prevention, control, and surveillance. And I think best way we will discuss. We have discussed in the morning around this World NCD Federation. So there are publications which are also available. A book on public health approaches to non-communicable diseases. We also publish International Journal of Non-Communicable Diseases, which is a quarterly peer-reviewed journal. And we have also manuals for the health promotion which are available. So thank you very much for your patient hearing. And if there is any question at this stage, I will be very happy to take. And we should ask questions. You're talking about the NCD risk factor survey. So, in NCD step-wise approach, the target age group is identified, that is 18 to 64 years. So this data is pertaining to this age group. Right? And there is a standard way of doing a sampling population proportion to the size, right? You take proportionate urban and rural population. All these papers, I have made these available. They are both for Punjab and Haryana. They are published in PLOS One. So you can go through this article and ask any specific question if you have.
Yes, sir.
Any more questions? Thank you very much.
Thank you, sir. Now I like to ask Dr. Harshal Salve for his session on air pollution and non-communicable diseases. Sir is additional professor in Center for Community Medicine, AIIMS, New Delhi.
Okay, good morning, all of you. Let me know how many of you are from the program side. You raise your hand, please. So I consider all program people are a central pillar of whatever we discuss in a good AC room. It is important to implement the things at the ground level. And all these program people are our soldiers who implement all the policies, all the program related activities, and they are the real, what we call it as a change agents. That is also important to give adequate information, technical information, which are actionable with the actionable points, right? So, and I hope after this session, it will go to say something which is with respect to the new risk factor, right? We have heard about most of the risk factors with respect to physical inactivity, dietary risk factors, salt intake, inadequate food intake, right? The glycemic control, your blood pressure control. But this now air pollution exposure. All of you must be hearing it from the media houses, from the social media regarding air pollution. And we are fortunate, unfortunate people here working in Delhi who are exposed to it. You are fortunate that you came here in the moderate season of air pollution, I will say, right? So we'll discuss briefly. So there will be some technical information and there will be some actionable information to be shared during this presentation. So the basic information, this might be sort of additional information, or I will say the reinforcement to the faculty members who joined this course or for the students also with respect to basics of air pollution. But I think this is important for the program people to understand this. What is the extent in India? What are the sources of data? As I said, it is important to take this agenda of air pollution and NCD forward. We have heard from Professor Krishnan and Professor Thakur that how the journey of NCD started almost 20 years back. The similar thing has to happen for most of the environmental risk factors, be it air pollution or climate change with respect to other non-communicable diseases. So what are the data sources and what are the interventions to address these issues? So basics. So air pollution is the presence of any solid, liquid or gaseous substances in the atmosphere in such a concentration which may be or tend to be injurious to the human being or other living creatures. So again, this environmental exposure related science is evolving science. Let me put it at the outset, it is very difficult to establish what we call it as a cause and effect relationship when we talk about environmental exposures, be it pesticide exposure, be it air pollution related exposure, be it exposure related to heavy metals, right? So that's what, and our science is also evolving, our technology is also evolving. So we are getting more evidence, more what we call it as a robust evidence in terms of hierarchy of the evidence we are talking with respect to all the environmental risk factors. So we are able to detect particulate matters. We are able to detect the hazardous, the various levels of gaseous, right? So previously we used to talk about PM10. Now we are talking about PM 2.5. I am sure in the coming time we are going to talk about PM1, right? So this is what we are going to talk about. If you see the literature that is with respect to air pollution, you will see the two types of air pollution we talk about: the indoor air pollution or household level air pollution, or outdoor air pollution or ambient level air pollution. So coming to the air pollutants, right? So based on the origin of the source, so this can be natural air pollutants, the dust, sea salt, and the forest fires. These are natural air pollutants. Anthropogenic, that is human driven, human activity driven air pollutants are stationary point sources, mobile sources, water disposal, landfills, control burning, right? What we see in the waste disposal landfills in this around the city. Method of origin, from where it is originating, the primary air pollutants, that is sulfur dioxide, carbon monoxide, lead, and ammonia. The secondary air pollutants like ozone, we call it as the nitrogen dioxide, photochemical smoke. Again, we have heard about ozone layer, so now, right? But here, O3, that is ozone, is an important, one of the major studied, I will say, the air pollutant with respect to all health outcomes. And regarding chemical compositions, you can sort of divide it on the gaseous air pollutants, particulate air pollutants, as I said, particulate matter. So it is a particles of the size, all of you are aware, 10, 2.5, and 1 designates is the surface area. So the smaller the surface area, more deeper it will go to the respiratory system, and more concerns it will cause. And we are going to discuss about the major air pollutant. As I said, more information is available for these commonly available, commonly studied air pollutants. We will discuss more about it. So PM, that is particulate matter, the major concerns of the city, because their values are 5 to 7 times higher, right? When you see, even currently in Delhi, if you see the particulate matter concentration, it is almost, I will say, 3 times, right? 3 times, more than 3 times at the current level. We will see how to look into that levels. So you can see the crustal component 40%. So you can see the difference between PM10 and PM2.5. Okay. As I said before, it depends on the size of the particle we designate the particle. So this is a national ambient air quality standards, which is mandated as per the Air Act, and it is recent, was a year 2009. The currently government of India is in the discussion to revise these standards. Again, these are the standards, is not at par with the international standards. We are a bit lenient with respect to all environmental standards for that matter. Why? Because we are not able to measure it with that accuracy. So this is important to know that if we look at the particulate matter. So as I said, it's not a daily standard which it is with respect to the all regulatory mechanisms or research related activities. It is important to know. When you study for the researchers, when you study the association of the, let's say, particulate matter, you always look into the annual or 24 hours exposure, right? This measurements has been done continuously by the territorial sort of stations, as well as the information available from the satellite, where the optical density has been reflection from the optical density has been measured, and the PM level has been sort of documented. And the stations, territorial stations, they measure using a chemical composition, all the environmental risk factors. So it is important to sort of unit of measurement is a average annual exposure or average daily exposure. That is a unit of measurement. So you can see here there is a difference between sort of setting where we are measuring. It is different in ecologically sensitive setting like bird sanctuary, forest areas, and ecologically protective areas, as compared to the rural. The more standards are more stringent with respect to the ecological areas. Now these are the estimates which are seen in this slide. You can see on the A, that is on the right side, it's a PM 2.5, right? What is again the estimates made by this team? You can see the red one, it is more PM 2.5 concentration is more there on the what we call as a Ganga belt, right? On the northern part. The reason being there are multiple theories about it, the wind flow, the activities, agriculture related activities in northern part of mostly in the Punjab. There's a parali burning issues you must have heard of. And there is also measurement issue, which nobody talks about. You can see most of the stations of the CPCB, that is Central Pollution Control Board, which is a sort of regulatory authority which measures, give the information regarding air pollution, is situated here. Almost in Delhi itself, we have 350 stations. Where in the northern, where in the western part, southern part, so you will see very scarcely located or sparsely located measurement stations. So again, this is also evolving in terms of the implementation of the program. On the left side, you will see the ozone concentration, O3, that is again equally distributed. It is again ozone level emission. It is linked to the vehicular pollution, right? It is majorly emitted through the vehicle combustion of the diesel, particularly, right? So that's why you have seen many interventions addressing this issue. So that's why you can see here it is more sort of equally distributed as far as the exposure is concerned in the country. Now coming to the most important information, we have many faculty members, academicians here in this course. So they will definitely ask you from where to get, even the program officers. Now we have a national program for climate change and human health. Hopefully you have got the information about it. Most of you are the nodal officers of the NPCCH. So to do any epidemiological study, it is important to discuss about the data. So from where to get the data regarding air pollution. So as I said, under National Clean Air Program. So there is a, as I said, the territorial, the stations are there. You can see this is the clustering of the station, as I mentioned before, it is more there in Delhi and the Delhi NCR region. But government is planning to sort of increase this station. There is increase in station in recent years. So you can get the information from this station. The information is available in the public domain on the CPCB website. You can request for the information. You can get the data of your requirement. Then, as I mentioned, the satellite-based PM 2.5 database. We, along with IIT Delhi, has developed estimated exposure for 1 by 1 kilometer in entire country using optical density parameter using satellite data. So that data set gives you 1 by 1 kilometer exposure for mostly for the PM 2.5 and ozone for the time being. We are working on other parameters also. So if you really want to conduct any research or any epidemiological assessment, you can use that data set. There is other network like IMD, ISRO. There is a SUFFER app, which is I will show you in the subsequent during this presentation. So these are also database. The IMD SUFFER comes under IMD, Indian Meteorological Department. That also captures the data with respect to the air pollution. You can also request the data from the IMD. And the recent and the newer things which are coming up in terms of personalized exposure. I'm not sure how many of you are involved in research related to air pollution, but there are personal monitors. You must be having air purifier if somebody is from Delhi, or PM 2.5 measurement device is there. There is something called a personal monitors also you use in mostly in the research setting, where you have to wear the monitor and get the reading and then correlate the information. So this is the data set which I was talking about, 1 by 1 kilometer sort of data set of PM 2.5. Similar pattern which is observed with respect to exposure. The sources of air pollution data, you can go into CPCB website using this link, or the SUFFER India website, which is at the IMD. You can request for the data, and obviously with all the procedures, you can get the information. Now coming to the NCDs, back to NCDs, as mentioned by Professor Thakur in his talk, air pollution is important. Not only important, it is a second leading cause of NCDs after the tobacco smoking. So because it's, you have heard, you must have read in various technical reports, it's important risk factors with respect to all mortalities and morbidities. And NCD is a major cause for mortality. All of you must acknowledge, right? So almost 30 to 40% mortality in India is attributed to non-communicable diseases, and exposure is so much with air pollution. So obviously you will get that association, right? So and it is more recognized, household and outdoor air pollution recognized one of the important risk factors. So both are the important risk factor. Till till we had this Ujjwala scheme implemented, our biomass fuel use and household air pollution were on the higher side. Still, the NFHS report says almost 40% of rural household, they use biomass fuel as a predominant fuel for their daily cooking purposes, right? So it is still a risk factor in spite we are having a good Ujjwala scheme for LPG usage. So as for the estimate, 7 million premature deaths are due to the air pollution related, and majority of it are from the NCDs. As I said, the science is evolving, research is evolving. So as the data, we are getting a data. So these are the major NCDs which are linked to the air pollution so far. So almost COPDs, mostly the impact is on the respiratory system. So exacerbation of the COPD, exacerbation of the asthma are the important risk factor, important outcome of the air pollution related impact on NCDs. Then lung cancer, ischemic heart disease. And again, we are getting more evidence as we are working on it. This has been shown by Professor Thakur just the previous presentation. The both previously approach was 4x4, right? So 4 outcomes, 4 exposures with respect to NCDs. But in 2018, they have added 1 outcome, that is a mental health related issues, and 1 exposure, that is a air pollution related, right? So it has become a 5x5 approach. So as I said before, major exposure studied so far, PM 2.5, PM 10, ground level ozone, we call it nitrogen dioxide, sulfur dioxide. Again, it depends on the technology of the measurement of exposures. The technology is still evolving. Once we get a good technology, we'll be able to assess more air pollutants. And when we sort of study the impact of air pollution, we divide into short term and long term. When we say short term, it's a 7-day impact. Till 7 day, we call it as a short term impact. If you look into the studies, absolute literature, you will going to see, you will going to appreciate this difference of short term and long term exposure. Again, it is easier to do the short term sort of exposure assessment and its impact rather than long term, because there are a lot of confounders which are there in this analysis. Health outcomes, the cardiovascular and respiratory outcomes are commonly studied so far, but the newer outcomes with respect to neurological outcomes, the developmental related issues, the Alzheimer's, the Parkinson's disease are also, the studies are coming up from European countries, from China, where science is more evolved in terms of air pollution and the health outcome assessment. So the evidence is also emerging in this regard. So these are the few publications which are available in the public domain, which are linking air pollution and the non-communicable diseases, right? I encourage all of you to work on this area, be as a part of PG thesis or as a part of any research activity, or at the program level, as mentioned by Dr. Thakur, do some epidemiological assessment with respect to NCDs and get some information from available data sources with respect to air pollution and try to link it, involve the medical colleges so that our science get more. And again, it is very important to generate a local data, right? Because all the WHO estimates depends on the what country level information is available. And currently, most of the information with respect to the research, I will say, it is there from the southern part of the country, right? Dr. Kalpana and her team is doing majority of research that is more located in the southern part of country, not in other parts, western, northeastern is totally missing, north is not that much. So that again, we need to generate the local information so that proper estimates related to mortality can be generated. This is a study what we are doing in collaboration with the IIT Delhi at the Ballabgarh, which is our field practice area, where there are many studies available, as mentioned by Dr. Thakur, also time series studies linking mortality and hospital admissions. But here we try to do the cause specific linkages with respect to the air pollution exposure. Here we again use the same satellite based data, and we have a system of verbal autopsy based cause of death assessment in the NCD. So you can see here there is a clear-cut association of the air pollution and the mortality. Then these are the interventions related to community level and individual level. Community level, we should sort of promote a clean fuel use. Clean fuel, the LPG, the PNG, these comes as a clean fuel use. And urban planning, which is important, green spaces, and try to for non-motorized sort of transportation mechanism. And individual level, again, if you really want to mitigate, as I said, again, the science remains the same. Basic risk factor control, the obesity control, hypertension control, glycemic level control remains the thirst area, and obviously reducing tobacco and alcohol consumption. The regulator mechanisms are already there, adhering to the norms which are there by the CPCB. I will not go into detail here, but multi-sectoral action is also needed here because multiple sectors are involved with respect to this. There is a role for policymakers, NGOs, and health professionals for addressing these issues. All of you are aware, and the template remains the same for all the actions. It is easier said than done, I know, to involve the multiple sectors, but that is the only way forward. This was I was talking about the National Program for Climate Change and Human Health. So we have working on a state level action plan. So these are the important action needed for the state level with respect to situation analysis, risk reduction strategies, monitoring surveillance, and health system strengthening. And obviously advocacy and communication remains the important pillar. So if you're working as a program officer, you will get this document and try to incorporate air pollution related exposure assessment and linking with the NCDs. So these are the two applications which are available. So after this session, go to your Play Store and try to download these applications, the Samir application and the Suffer app, and let me know what is the PM 2.5 level here and at your home place, right? So any more questions? So just if you can see, this is a Samir application where you can see the PM 2.5 level at across India, which is used by the CPCB, right? You can download and see. Yes, please.
So my question is also monitoring and evaluation of programs which are currently in place, like the NCAP. There have been certain challenges seen, and in general, there seems to be for monitoring. So I think we need that as a pillar within.
Obviously, what we is lacking entirely is the data. We have seen in the COVID also, and data is more lacking on the health side, I will say. The environmental side data set is available in the public domain, but health side data set is not available. It is not central located. It is not made publicly available. There are many issues with it. So of course, the availability of data is the issue, but of course, followed by that, the quality of the data set. But we are still struggling at the first phase itself. Hopefully, if we thrive for it, we will help the authorities to get the data set.
So most of the health institutions now they are taking care of this air quality index in their hospitals and like up to PSC level. For Kaikal visit, they are taking action for the same.
Yeah, just touch a bit about it. There is something term called as a climate resilient health system. So it is a part of it, what he's talking about. There are other factors like rainwater harvesting, solar energy use, all this is a part of climate resilient health system. And I think in the NPCCH, there is one of the sort of action points for the program officer to promote and discuss with the health system implementers. We can have discussion at the time of lunch. Thank you so much.
Anand, should I start or Anand? Should I start or is there an introduction or something? Okay, so I was just wondering.
I want to introduce Dr. Prabhakaran. He is Vice President, Research and Policy, PHFI, Executive Director, Center for Chronic Diseases Control, Delhi, and Professor of Department of Epidemiology in London School of Hygiene and Tropical Medicine, UK.
Right. Okay. Thank you. So thank you very much. There's some echoing, I think, right? Is there an echoing? No? Okay. I'm getting an echo. Right. Anyway, let us see how it goes. Huh? Let's see how it goes. The topic assigned to me is use of technology in managing NCDs, issues and challenges. So I'm going to speak for around 20-25 minutes or so. So let me first start off with my introduction on chronic diseases, also known as non-communicable diseases. So it is said they are the #1 public health challenge of the 21st century. That's because not only they cause enormous number of deaths across the world, but they're also a threat to the economic development of a country and sustainable development, particularly if you're not going to address NCDs, you're not going to address the SDG goals. So what are NCDs? NCDs essentially are 5 major diseases: cardiovascular diseases, cancer, respiratory diseases, diabetes, and mental health. I mean, this is the definition given by WHO. They have classified these 5 diseases as the major NCDs. And these are bound by 5 main risk factors: tobacco, unhealthy diet, physical inactivity, alcoholism, and air pollution. However, some purists also say that not only the big 5, you have to address cirrhosis, kidney disease, oral health, eye health, and others. But essentially, when we talk about non-communicable disease, we are talking about these 5 major diseases and 5 major risk factors. So if you have to prevent or manage NCDs, you require 2 approaches. As all of you know, that there is a population approach and there is a high-risk approach. The population approach caters largely to primordial and primary prevention, whereas the high-risk approach caters to high-risk primary prevention, secondary prevention, and rehabilitation. So we really need both. And that's where technology that is low cost, easily available, potentially scalable, equitable, and sustainable is quite useful. And I'm going to give you some examples. But let's think of what we can do in terms of primary prevention of NCDs. Again, there are 3 main components here in primary prevention of NCDs. First is education. You want to educate people and professionals so that people, when they become aware, they can refer themselves to a doctor. Or when patients come into the hospital, there can be an opportunistic screening. As you all know, that there are 3 types of screening. You have a mass screening, you won't screen everybody in the population, which is not viable, which is not cost effective. So the other 2 types of screening, which is done for NCDs, is an opportunistic screening. When people become available to the health system, you screen them. Second is what we call as targeted screening. In terms of professionals, we need to give that education as to how to do that screening. What are the things that are required? When I say professionals, it not only means doctors, but everybody in the health system, nurses, ashas, community health workers, all of them can be involved in screening. Second step is, once you screen, you need to risk stratify. What do I mean by that? If you look at, take blood pressure as an example, we treat patients with hypertension and say these are people at very high risk. Somebody who's got a blood pressure of 140/90 and above, we provide them treatment, be it lifestyle, be it drugs, we provide treatment. But what happens to somebody who's 138/say 88? Aren't they at high risk? Are they really low risk that we shouldn't be treating them? We have moved towards a concept of saying that even people who do not have hypertension, if their blood pressure is high, they are at high risk. That means if you have a blood pressure of 130 millimeters systolic, it's bad as compared to a blood pressure of 120 millimeters systolic, because most of the deaths occur in that area. So you need to really risk stratify these people. And how do you do the risk stratification? you take in other factors. Is the person obese? Does the person smoke? Does the person have high blood sugar? Is there a family? So a lot of things are put into that. So many of the technologies are using these engines actually to risk stratify. And so you need to risk stratify these people. And this can be done by targeted screening to simplify. Now we do have these technologies which can actually give you a heart age and which can give you things to screen. Then the next thing is, and then there are guidelines as to how to do it. The next thing is in terms of management, what are the treatments that can be given for people with hypertension, people with diabetes, people who have heart attack, people who have stroke, how do you prevent cancer? So there are a lot of questions that need to be answered. And this is where affordable health technologies are useful. And there are three affordable technologies that are required. One is what we call as point of care devices. Now you imagine the workflow of a villager who goes to a primary healthcare center. There they register them. Then the doctor has 1 or 2 minutes to see the patient. Can you hear me now? Is this better? Yes. Okay. So you can kind of, where was I? Okay. In terms of the workflow of the patient who goes to a primary health care or even to a private practitioner here, they go, then they give a history, then they are screened, then they are investigated. So it takes around 3-4 visits actually. I mean, in the best case scenario, it may take 2 visits, but may even take 3-4 visits. Instead of that, can we develop a point of care device which will give accurate values in terms of screening, say for glucose, for lipids, for creatinine, and so on. That's one. Second is we need to give what's called as a decision support system. Means that if the person, community health worker or a nurse is screening, that person can provide the report to the doctor, printed report. And in that, we put in a set of questions in terms of identifying what's the right kind of treatment. Let me give you an example. If there is a patient who walks into the clinic, her blood pressure is found to be 160 by 100, non-smoker, no diabetes, nothing else. So the decision support system should easily identify what's the appropriate treatment for that person. And that's called the decision support system, and it can be made electronic. The third technology is okay. So the third technology is using mHealth, like in telemedicine, so that there is a virtual interface between the physician and the patient. So these are the three important technologies that we need to look at, and I'll give you some examples of what we're doing with that. In terms of secondary prevention for people who have developed disease, we have a lot of evidence. We have clinical trial evidence that there are very simple drugs that work, lifestyle that works, but its implementation is a problem. So we need to work on that. So we need to improve practice patterns of healthcare providers by integrating effective secondary prevention into primary healthcare, enabling uptake and adherence by patients in terms of getting availability, affordability, motivation, support systems, and simplified regimens, and strengthen health systems for chronic care by both upward referral as well as downward referral, and involving non-physician healthcare providers and monitoring and evaluation. So these are the two major areas in terms of chronic diseases, the primary prevention and the secondary prevention. Primordial prevention, where we talk about tobacco control, health promotion, technologies used across both these segments. But there are several challenges. The first challenge is the health workforce. The health workforce is really inadequate. I mean, in terms of, if you take even primary care physicians, they're not available equally in the rural and urban areas. We all know about the asymmetry of the availability of doctors in rural areas, but not even in urban areas. They're concentrated in the metropolitan cities or in some states. There are several states who do not have adequate number of, forget the specialists, adequate number of primary care physicians. The second is our non-physician healthcare providers like nurses and community health workers are not permitted to prescribe any of the non-communicable disease drugs. There's limited permission to prescribe in infectious diseases, but not in non-communicable diseases. Healthcare services are fragmented, as you all know. There's the public health system provides services only to 20 to 30% of the population, largely in rural areas. A large majority of the services are provided by the unregulated private sector. So you require a solution for that. The third is drugs and technologies. If you go to a primary health care, in the Indian public health standards, as well as the essential drugs list, there are several drugs which are really good, inexpensive, that should be available. But there are huge stockouts in many times. I mean, drugs may be available in April, May, and June, but in July, August, it may not be available. Then the money will come, they'll buy the drugs for September, October, November, December, January, February, no drugs. So this problem is a big problem. I'm sorry. Let me put this off. So the health financing is a problem because even though we have Ayushman Bharat and social insurance schemes and things like that, it caters only to the people below the poverty line or only to 40% of the population. People who are lower socioeconomic, lower middle class, for example, have to spend a huge amount of money even for OPD care. I mean, if you're talking about anti-diabetic medicines, it can take away nearly 40% of the non-food expenditure, which is a huge expenditure for them. And there is no integration amongst NCDs. There are no integration with other health programs, and there is no multi-sectoral coordination, which is so required for chronic diseases. So these are all the health system challenges. So if we have to address these disparities, what are the technology solutions that we have? First is surveillance. We need a good surveillance system. We need to keep a good count of what is happening so that you can be nimble enough to address that. If you look at from 1990 to 2016, cardiovascular disease in this country has risen by around 50 to 60%. So much so it's become the leading cause of death, whereas in 1990, infections were the leading cause of death. So you need that kind of information to target your programs, to put where your money into those programs. And for surveillance, now we have a lot of mechanisms, but I think they're underutilized. Mobile phones, tablets, electronic health records. I mean, biomedical sensors, you can do it in a small proportion to understand the mechanism of disease, but that's really not required. In terms of screening and diagnosis, as I said, you require a point of care device, which is inexpensive, can be done by a community health worker in the community at a very low cost. The third is in terms of management, we need electronic decision support system and telehealth. I'm not going to talk about the others because that has no relevance here, but these are the three things. You require simplified data collection tools, you require point of care devices, you require electronic decision support system, and you require telehealth. Now I'm going to talk about some of the technologies that we have developed. I'm going to talk in detail about a technology called Digi Sahayam, which is an assisted telemedicine solution, which we have piloted in slums of Chennai. And the digital technologies which go into Digi Sahayam include AI and artificial intelligence enabled ECG system, Swasthi Sahayak, which is a point of care diagnostic device that we use, a high definition camera, a digital stethoscope, and an electronic decision support system. The second technology that we are evaluating is the role of digital photography for early diagnosis of cancer using machine learning or AI techniques. Because diagnosing oral cancers takes a lot of time, you will have to do a biopsy. So this particular thing, by training the AI-based system, you can actually predict or close to 90% accuracy. You just need to get it higher than that, and we are working on that. I'm also going to talk about another digital platform called Mithai, and I'll explain what that is. So Mithai is mass integrated transformational health with artificial intelligence to provide primary health care at home. And it can provide comprehensive care and real-time service. It's developed to work within the existing regulations and health system and can be universally acceptable. So there are two platforms in Mithai, which is digital health platform and mobility platform. The digital health platform consists of icon-based health content. Now, the big problem is education and the language barriers that we have. So instead of that, can we have icons which people press and say, okay, do you have hypertension? Yes, no. So you can just put a cross or a tick. You train community health workers to do. So the barrier of the language is taken away. Then you can look at image-based signs and symptoms for screening and a modular multi-sensor handheld screening device. In the mobility platform, we developed a two-wheeler modular boxes-based platform which can transport vaccines, drugs, and the health records, and a drone which can actually deliver these vaccines and drugs in remote areas. So these are temperature controlled and platforms. So this is how it works. So you have this interface, which is icon based. There's no text, and it takes an image. Like for example, it can take the image of the house, and it can take the image of the surroundings and give you what are the problems in terms of the environment. Is there water pollution? Is there what's a PM 2.5? So it can give you quite a bit of details. And in addition, so you can input the health data, and you can actually link both the environmental as well as the health data. And you can provide the services in terms of the solutions. Here you're collecting the data in terms of surveillance, but you also need solutions, and you can see the solutions. It can be delivered by a community health worker on a scooter, or you can use the drone technology to deliver it. I'm going to give you another example of chronic diseases across the lifespan. So the principles that require, you may develop a technology, but the technology has to use some of the principles which are being used in the prevention and management of chronic diseases. That includes a life course approach. Because as somebody said, chronic diseases starts in the womb and ends in the tomb. Like you have to have good maternal health care, good care for the newborn, good care for the infant till 2 years, then good program for the school-going children, prevention of smoking amongst young adults, the right kind of dietary practices amongst young adults, and once people develop disease, the right kind of care. So it should encompass across the lifespan. The care has to be continuum, starting from the community to the level of rehabilitation, you have to intervene. It should cater both to the population and individuals. It should address both biology and social determinants. The reason for us having a high propensity to diabetes is rooted in biology. It may be low secretion of insulin in the pancreas. It may be something else, but also social determinants are very important because of the poor eating habits amongst the people who cannot afford a healthy food. So you need to address both. The care has to be integrated. It has to be integrated across diseases, and it has to be a team-based care. And we need research to policy translation. We need to build networks and collaborations. There needs to be multidisciplinary, and we have to talk to the patients because their lived experiences, when they go to the hospital, what happens? When they take the medicine, what happens? When they change the lifestyle, what happens? Can one person in a family reduce the salt whereas others are eating the normal salt? So you need those lived experiences if you have to design an intervention program. So this is an example of how we put together all the studies that we have done in the last 15 years in terms of using the principle of continuum of care. We use an electronic decision support system. We provide integrated care. We try to improve quality of the care, provide rehabilitation, and provide team-based care. So I'm going to talk about two examples. The first example is the Empower Heart ML system, which is a clinical decision support system for hypertension and other cardiovascular risk factors. So why do we need ML technologies? Because for the consumers, it provides improved convenience, more active engagement in self-care, and greater personalization. For the clinicians, it reduces the demands on their time and refocuses on the art of medicine. And it has the potential to change every aspect of the healthcare environment and to do so while delivering better outcomes and substantially lowering costs. However, there was a need for a real world clinical, because this is theory, you need to prove that it actually works. And the innovation should be low cost and potentially scalable and sustainable and make real differences to people. So how does this work actually? So the patient walks in to a primary health care or a clinic. The nurse care coordinator, who's trained, obtains the conducts the initial assessment and puts in the examination details in the nurse portal. The medical officer gets a printed electronic decision support system recommended. I gave you the example of hypertension. A patient comes, but in the back end, we have put 3,000 case studies. So there is a machine learning algorithm which actually does permutation, combination, matches that and gives an advice to the medical officer. The medical officer can accept or rewrite the prescription. Then the patient comes back, because the doctors are so busy in these clinics that they don't talk to the patient, they don't provide advice. But the nurse or the care coordinator actually talks to the patient, provides lifestyle advice, And actually there is an auto texting feature so that the patient can be called for follow-up. And this is how the system goes. So people are very happy with the system. There's a lot of time saved for them and the controls are much better. And so we have done this across the community, primary, secondary, and tertiary care. We've done a lot. We've used several research designs that include formative research, RCTs, demonstration projects. Several high-impact publications are there, and you can look them up. And there's been a state and national level scale-up. In fact, in Tripura and Mizoram, we have incorporated this across the state. And this is trying to become a sustainable program. We are doing a national level pilot at Nawaz Shahar in Punjab. And we are also moving into new areas beyond hypertension and diabetes. So now we are looking at pregnancy-induced hypertension and gestational diabetes. We have developed a program for depression, cancer, and TB and several others. But we are moving towards what is called a symptom-based DSS. Patients don't come with hypertension, diabetes. They come with symptoms. They come with headache. They come with, fever. They come with cough. Using system, how do you approach non-communicable diseases? That's what we are attempting. The next thing I wanted to talk about is Digi Sahayam, which is an assisted telemedicine solution. Basically, the problem with current telemedicine system is you require two levels of education. One is you require literacy. Second, you require digital literacy, how to operate a mobile phone, how to get into the system. So that's a bit of a problem. So what we are doing, and the doctors are also frustrated because people go to a different specialty and they're expensive. So the question that we posed was, can we train very low levels of community health workers to provide this assisted telemedicine? And can they use this interface to connect to the doctors and the specialists who are sitting very remotely? So what happens in the first panel, you can see patient visits the clinic, the trained nurse takes history and examination, any lab tests are done there itself. There's a consultation with the doctor, virtual consultation with the specialist, and post-consulting counseling by trained nurse. And this is done within a matter of 1 hour. And so the patient goes back, need not come back. 80% of them don't have to come back. It reduces the load, it's environmentally friendly, it can address issues of climate change and air pollution in a larger scale. So there's upskilling of health workers in providing assisted telemedicine. It reduces the need for follow-up visits. And I'll show you, talk about the platform. So there's a primary to tertiary level consultation with telemedicine clinics. And within a matter of 6 months, we have touched nearly 20,000 patients or so. And we are providing doorstep telemedicine because, as you can see in the last panel, where this lady is carrying 2 small bags, it's only 4 kgs. So there's a backpack and a small bag, which is all the equipment required for the telemedicine, and she's providing a home-based telemedicine assistance. So this is how the platform looks like. So it can give you general physical examination findings. It can give the template-based history. As I said, if there is fever, it has a set of 8 questions, which comes as a drop-down box, and people can ask questions and it can fill it up. It gives trends in terms of the vitals, like for example, has the pulse rate changed, has the blood pressure changed over this course of 4 visits or so. It can give lab test results with trends. It can give it can give electronic decision support report in terms of the diagnosis and treatment. It can generate a e-prescription history and provide a markup for follow-up visit. More importantly, it can actually simulate a clinical scenario. Like for example, a doctor wants to hear the heart sound. They can sit remotely and with a lot of clarity hear the heart sound. For example, here it is kept at what we call as a second aortic position for a cardiologist. That's the most important location. Hear cardiac sound very clearly remotely. And the impact over 1 year is given. We have treated almost 30% of the elderly population, 62% of them were females. 3,000 patients with NCDs were detected in these slums. And the cost is coming down rapidly because we had a lot of setup costs and other things. Right now, this whole thing, including the specialty care, everything, we want to bring it down to 300 rupees per person. So that's a kind of thing which we're thinking of. And you can provide home visits, and patient satisfaction is very high in this. And it can spin off into several other things. Doorstep medical assistance. You can create a kiosk, which is to come in a suitcase. You can take that kiosk, set it up in a mall or in a railway station and do a teleconsultation. Or you can create these vans where people can go to small clusters of villages with less than 5,000 population, as an example. So there are immense possibilities with this. But you need to look at few issues and address them in using technologies in healthcare. One is quality control, and you have to keep an eye on the quality. It should be scalable. It should be interoperable. It should address contextual needs. It should be easy to use. Even people with 10th grade education should be able to use this platform. It should be very inexpensive, and privacy issues have to be addressed. The next thing that I wanted to show is something on air pollution. Like, for example, you want to understand the mechanisms of disease. You want to relate air pollution to a health outcome. How can you do that? So we're using machine learning and artificial intelligence in understanding disease mechanisms. Now, I'm giving you an example of a program that we did in Delhi and Chennai, but Delhi here. So we wanted to link PM 2.5 levels to incident cardiovascular risk factors and outcomes in Delhi and Chennai. We developed an exposure model to predict daily concentration at 1 kilometer spatial resolution for Delhi. So you can see Delhi has been divided into 1,635 grids, and we have data over a period of 7 years. We have everyday data of PM 2.5, and it had around 4.2 million observations. So you can't do it manually. You have to use machine learning technique. So we obtain data from the monitoring stations. In fact, convert some of the PM10 data into PM 2.5. We use satellite data. And most importantly, many of the people who do this air pollution use only the satellite data, do not do adjustments for the land use, because the greenery, the road network, the traffic network, the parks, the wind speed, the humidity, all of those matter. So we put in all that data, use a chemical transport model. We call this ensemble modeling, which is a machine learning model, and obtain PM 2.5 levels. So you can see here from 2010 to 2016, how air pollution increases over that 6-year period. You can see the color of in 2016, starting from the month of September itself, October, you start having this red color, and it persists till February. So this is an important information that can be given to policymakers to make a change. The second thing we have shown is blood pressure levels are higher where people live very close to extensive traffic and road networks. If the houses are very close, their blood pressure levels are higher. This is how you use technology to look at important things. If I have to summarize the air pollution and hypertension program, we have demonstrated that long and short-term exposure to particulate matter concentrations are associated with increased blood pressure and risk of developing hypertension in urban India. So in Delhi, for example, in 2016, the annual PM 2.5 was 125. PM 2.5 is particulate matter, which is very, very small. The PM 2.5, PM can get into the circulation, cross the alveolar blood barrier, get into the circulation, can cause stiffening in the arteries, can cause arrhythmias, can cause inflammation and diabetes, but you need proof. And this is a direct example of the proof that we have provided using a longitudinal study, because most studies that are being done are cross-sectional. You require to follow up people and actually relate that PM 2.5 to the blood hypertension they develop. So we have estimated that if you achieve national ambient air quality standards, it can potentially reduce prevalence of hypertension by 15% in urban Delhi. So that's the power of policy, and that's where technology should be used in terms of addressing these risk factors. So we have established link with other diseases such as diabetes, heart failure, stroke, obesity, heart attacks, and several others. Not only that, not only that you should use technology in terms of linking something like air pollution disease, but you also should be looking at how to mitigate that. We're working on a trial now to look at low-cost air purifiers in improving survival in heart failure. And it's a large randomized controlled trial. So you need to create the low-cost air purifiers, because heart failure is a disease which kills people. It's worse than cancer. 50% of the people die by 3 years. And air purifiers have a major role, because if your PM 2.5 is very high and people are exposed to that high levels, they can have arrhythmias or irregularity of heartbeat, worsen the failure, and they can die. So can we prevent that? And we are doing a trial. So I just gave you a sample of what can be done with technology. So if you have to put it all together, public health challenge needs research and needs potential solutions. When we talk about research and solutions, we are talking about very few things. We're talking about etiology, burdens, clinical trial efficacy, and how do we give it to population. But we're not talking about many other things, such as what is the efficiency of distribution of that factor? What is the availability of drugs? What is the distribution? All that really requires technology to address, but the technology has to be simple, scalable, low cost, equitable, and everybody should understand that easily. Our philosophy in terms of using technology should be from the bench to bedside and beyond, from molecules, small molecules to markets. Markets means I'm not meaning that it should go to Pfizer or somebody. When I say markets means it should be available to everybody at a low cost, and from individuals to population. That should be the philosophy. So this is my last slide. As you saw, you were going to the lowest level PM 2.5. So it's a reductionist philosophy, but our solutions have to be holistic. You have to use the reductionist philosophy in technology and apply it to health and provide holistic solutions. So let me stop here and I'll take a few questions if you have any. Thank you. Yes. So when you say sensitivity and specificity, what are you comparing against? Because here there is a patient. I mean, there's a patient who connects to a doctor. So there is no question of sensitivity and specificity. If you're asking me about the sensitivity and specificity of the point of care device, we use what is called as a bland Altman analysis, and we get a correlation
Shukar. He is a professor and head of preventive and social medicine in JIPMER. I will be playing the recording, and sir is online also for the discussion part.
Greetings to the participants.
I don't think it has been started here, but we have many state program officers and the state program officers. Attention. And hearing but not seeing. So we have many state program officers here, and I think a lot of initiatives are being done at state level. So we are ready, we can start presentations for state program. So we can 15 minutes, we can talk about your state's initiatives. Not say what is everybody knows, program everybody knows, but any state level initiatives you want to talk about, I think we can find a slot for that one of the. So if you are interested, just let Abhishek know. State program managers, without a presentation. Group on initiatives.
in the subsequent side. So the chronic diseases are considered to be a problem of the age. Chronic non-communicable diseases are a problem of in the urban areas, and it affects more men more than the women, and is a problem of the elderly, not about any other thing, and cannot be prevented. I'm sure the last point will be discussed in subsequent sessions, but in this session we are going to talk about these 4 points. So now let's come to the first point of chronic diseases are a problem of the risk. Is it the right way to think? Because the facts says otherwise. Non-communicable diseases, if you look at the 2021 WHO status report, it says non-communicable diseases kill 41 million people each year, which is equivalent to 71% of all deaths globally. Out of that, that means almost 77% of all NCD deaths occur in low and middle income countries. So it's not the disease of the rich. Each year, more than 50 million people die because of NCD in the age group of 30 to 69 years, which are called as the premature mortality due to NCDs, and 85% of these premature deaths occur in the LLMICs. So this is the first fact. Now, what does the global evidence say about it? So if you look at the systematic review that was published in the Lancet in 2017 by Allen, it says it tries to tell us tries to cover the context of socioeconomic status.
Sir, should I present it now, sir, live? If that is not working?
Yes, sir. Yes, sir, you can do that.
Yeah, then you have to give him a share this. So, go ahead, sir. So if you can share your slides and make the presentation online. Go ahead.
Okay, sir. I'll do that, sir. Just give me the sharing link, the co-host. Make me co-host, then I'll share the slides. Okay, can you see the slides, sir? Is it visible?
Let's go to slideshow, yeah.
So, good afternoon, everyone. I know we are near the lunchtime, so let me do this quickly. The topic of today's discussion would be socioeconomic patterning of NCDs and its risk factors. And I'm very thankful for this opportunity. So in this next 20 minutes or so, what we're going to talk about is the background of the problem, how NCDs are a problem now, public health issue. What are the myths related to chronic NCDs? And what evidences tell us about these myths and how to dispel it?
We've already seen some slides, so can you just go straight to that slide on? Yes, sir. We can. Yeah, next. Yeah, I think we just finished this when you you can go from here. Yeah.
All right, fine, sir. So this is the meta-analysis that was done in 2017. And where 75 studies were included in the meta-analysis, where 4,242 records were analyzed with more than 2 million individuals of more than 10 years from 39 countries of LLMICs. And the evidence says that low socioeconomic groups were found to have a significantly higher prevalence of tobacco and alcohol use than did the high socioeconomic group. So that's one point. The second point is this group also consumed less fruit, vegetable, fish, and fiber than those with high socioeconomic status. And if you compare it with the high socioeconomic groups, they found to be less physically active and consume more fat and salt. Hence, two things are happening here. In low socioeconomic group in LLMICs, there is one section of the people who are having a lot of other risk factors, which are tobacco and alcohol use and less of fruit and vegetable intake. But in high socioeconomic status, they are less physically active and they are consuming more fats and salts. So why we are more concerned about the relationship between poverty and NCDs? This is a very interesting finding where we try to look at the population in the low and middle income countries were exposed to increased risk factors like unhealthy diets, physical inactivity, tobacco use, and harmful use of alcohol. That in turn leads to non-communicable, and because of the limited access to effective or equitable healthcare services, they go into the poverty trap. There is loss of household income and high cost of healthcare, and that leads to poverty at the household level. In one way, they get the disease and risk factor more in them, and they spend more to come out of it. Hence, the trap continues and the cycle continues like this. So if we look at the evidence from India, that is, I encourage all of you to read this report, that is India Health of the Nation States. We'll see there is a beautiful concept that has been proposed in this particular document. It is known as epidemiological transition ratio. So whenever we talk about ratio, it is ratio between A and B. In this case, A is the daily loss due to chronic, the daily loss because of communicable, maternal, nutritional, and neonatal disorders. To the second part, the B part is the daily loss because of NCDs. So when you take a ratio between A and B, that is, if it is more than 1, then what happens is the denominator is less than the numerator. So in the 1990s, when you look at the diagram here, the map of India, where a lot of colored red color and orange color things can be seen, where the ETR is more than 1, which indicates that maternal, communicable maternal, neonatal, and nutritional disorders contribute to more of daily loss. And in the 2016, the scenario has changed and more non-communicable diseases are contributing to daily loss. But it is very important to remember that if you look at the EAG states, the empowered action group states, which are considered to be poor or relatively poor compared to the other states, in 1990s, we have a lot of daily loss because of the maternal and communicable disease. But in 2016, the scenario has changed and non-communicable disease also are leading cause of daily loss or morbidity. Now, when we look at the same thing in the report that was just published by the Registrar General and Census Commissioner of India, as the causes of death statistics 2015-17, you can see that in EAG and Assam and other states, the proportion of people who are dying because of non-communicable diseases are 44.7 and 57.3% respectively. Similarly, between male and female comparison, if you see in EAG and Assam, it is almost more or less similar. And in other places, it is 59 versus 54.7%. So that is the first component of our discussion, where we discussed about the myth 1, where we said that the myth is chronic diseases are a problem of the rich. It is not so, as the evidence says. The second part of the myth is the chronic non-communicable diseases are a problem only in the urban areas, which is, we are going to talk about this using this particular report of National Non-Communicable Disease Monitoring Survey conducted in 2017 and 18, where the tobacco use, if you see under the rural areas, the prevalence of tobacco use is more. And similarly, inadequate consumption of fruits, vegetables per day by area of residence and gender. Also in urban and rural area, you see 98.7% compared to 97.7%. And among the men and women also, there is no difference can be observed. Hence, the chronic disease are not only limited to urban areas anymore, it has moved to the rural areas as well. So when you look at the obesity BMI categories as per Asian Indian cutoff, you see there is a difference here. In urban area, the overweight and obesity is more compared to the rural area as per the survey findings. And in the men and women categories, it is more or less similar. So when we look at the hypertension as a disease, the stage 1 and stage 2 distribution of prevalence in urban area, it is 19.2%, and in rural area, it is 16. And in stage 2, it is 10.8 versus 6.3. So rural area is catching the prevalence of rural hypertension among adults is catching up with the urban areas. So similarly, in the distribution of deaths by major causes in the rural and urban areas, if you compare, in non-communicable disease contributes to 51.2% in rural area, and in urban area it is 58%. Similarly, we have also evidence from rural Indias where isolated studies conducted in Gadchiroli in 2011 and 13. You can see that NCD accounts for 38.5% of death in 2011 and 13. Similarly, a study conducted in Chandigarh in 2004 and 6 also points to that factor, the prevalence of physical inactivity, central obesity, overweight, and hypertension are found to be statistically similar among urban, rural, and urban slum population. The third part of the myth is CNCD affects mainly men and more than women. We have seen in previous slides that the distribution of risk factor and disease conditions are more or less similar in men and women. But if you look at the clustering of case risk factors of more than 3 risk factors in the age group of 18 to 16 years, the men and women, it is 41.4%, which was 39%, almost similar. So coming to the last myth, CNCDs are a problem only of the elderly. If you look at this Lancet publication that we just discussed earlier, and you try to see there are 3 types of disease burden that usually we describe. One is a communicable disease depicted in light pink, and light blue indicates the non-communicable disease, and in the green part is the injuries. So in more than 70 years, NCDs are a problem, but it is not, we just cannot ignore in the age group of 30 to 69 years age group. So similarly, from the cause of death statistics, 37.6% are in the age group of more than 70 years. And if you add in the productive age group of 30 to 69 years, 30 years onwards, you can see that the total prevalence will be around 42%. Hence, the take-home message from this discussion is the myths are not true. You have to just add a component of not to each of those statements. So chronic diseases are not a problem of the rich. Chronic diseases are not a problem of only in the urban areas. Rural areas are also equally affected. CNCD affects mainly men and women equally. There is no preponderance of men to be affected by chronic non-communicable disease more. And it is a problem not only of the elderly, but also in the productive age group. CNCDs can be prevented by the WHO best buys. I'm sure in the subsequent session, you will be all coming discussion will happen on best buys. And hence, I'll just stop here in the interest of time. But if there are questions and clarifications, I'll be happy to take it. Thank you so much for your attention. Dr. Abhishek or sir, could you hear it, sir? Was it?
Yes, sir, it was audible.
All right.
Thank you, sir.
Thank you, Abhishek. You can, if there are no questions, we can move to the next session.
Yes, sir. So next is we will be moving for lunch, and we will meet at 2. The next session is by Dr. Shankar Pinja, Professor, Department of Community Medicine and School of Public Health, PGI, Chandigarh. Sir, you can start the session.
All right, thank you very much. So I'll try to share my screen. Let me know once you are able to see my slides.
Yes, sir, we can see.
Okay, now this will be a problem, so hold on. I think I'll do it this way only. I'll just reduce this slide and that way it could be better. So thank you very much for the invitation. So the topic that has been allotted to me is to talk about NCD and development and focusing on the economic impact of NCD. And what I'm going to cover in the first about 10 slides is the impact that the NCDs have on the household, on the health system, and the macroeconomic impact. But I have a few other additional slides where I'll like to talk about in general about the applications of economic principles to NCDs and how those applications could be used to make NCDs more affordable and equitable in order to access the services. So I'm sure that these kinds of slides would have been shown to you, which try to highlight that the share of NCDs in the overall mortality in the low and middle income countries is rising. So this is a slide that I do not need to emphasize more on you. This is just showing that what is the proportion of deaths that are attributable to the non-communicable diseases. And we see that over the last 15 years or so, this has increased by about close to 15%. And similar is the increase in the share of the overall disability adjusted life years that could be attributable to NCDs, which is again a reflection of the fact that the overall morbidity burden that can be attributed to the non-communicable diseases, both in terms of the years of life lost as a result of premature mortality and the years of life that are lost as a result of disability is rising. And the fact that the proportion is rising means that the absolute numbers are rising at a rate that is proportionately much higher than the all-cause morbidity. So which is something that is worrisome. And what implications does it have for us as public health professionals, as healthcare managers, is that this has impact on different aspects of the society. This has impact on the health system. This has impact on the individual or the family, which has to bear the cost of treating these illnesses. And this has a much more broader macroeconomic impact. And these are the three things that I'll try to touch upon in the next about 8 or 9 slides. So because the proportion of the non-communicable diseases are rising, so as we see that the decadal trends in terms of the NSSO data, that also shows that the proportion of outpatient consultations and the proportion of hospitalizations that are attributable to NCDs that has increased over the years. And which means that out of all the patients that are admitted in a hospital, the numbers that are representative of non-communicable diseases are going up, which is in sync with the disease burden data. So doesn't come as a surprise. But what it means is that health system has to bear the challenge of making sure that the care is provided and the care is affordable. Whereas we know that the cost of treating these non-communicable diseases is pretty high. And this is just a slide to illustrate to you that the cost that the health system has to bear also is quite substantial. So if you look at the bottom row, it shows that what is the cost that is incurred by the health system to provide a single valve replacement, a double valve replacement, or likewise, or even a balloon valvotomy. And you can see that these are single episode costs, the costs per procedure that is performed, and these are pretty high. These are much higher than what would be the cost per encounter or per hospital stay for a communicable disease, for that matter. And this is just one example to illustrate in case of a cardiac condition. This is the same whether you take other non-communicable diseases. So in this particular case, this is an example of how much does it take to cost to provide care for cancer using different radiotherapy technologies. And the bar on the left side shows the intensity modulated radiotherapy, which for a given patient, it takes about 1,70,000 rupees. So, and if you go by some of the other technologies, again, the cost is pretty high, about 70,000 if you have an IMRT, about 54,000 per patient cost if you do use a 3D CRT. So what it means is that we have one high burden translates to high number of patients who report to your health system. And there's a very high per unit cost of treating these non-communicable diseases that the health system has to bear. So that's the fundamental message that I just wanted to highlight. And linked with this is the fact that it is not just the health system that has to bear the cost of treatment, but in a country like ours, where the treatment to a large extent continues to be paid by out of pocket by individuals or families, the treatment for non-communicable diseases incurs a high out of pocket expenditure also. And when patients undergo treatment expenditures and when they have to pay these out of pocket, that leads them to face catastrophic expenditures or leads them into an impoverishing effect of these healthcare expenditures. And this is not to say that the other health conditions which are not non-communicable diseases do not impose any hardship. They also impose a hardship. But the point is that in case of non-communicable diseases, the risk of incurring a catastrophic expenditure is much higher as compared to a communicable disease. And this table shows how much additional is the risk of incurring catastrophic expenditure in case of a non-communicable disease, the different types of non-communicable diseases, as compared to a communicable disease. So if you look at cancer, there is a 2.7 times higher odds of a family or a household facing catastrophic expenditure if the treatment is for cancer, as compared to if the treatment was for any other communicable disease. And similarly, the risk of impoverishment again is 2.3 times higher in case of a cancer as compared to any communicable disease. So which means that this is an important aspect that we need to understand, and which means that any kind of a policy that we develop for universal coverage, it would be incomplete unless we are able to make sure that the treatment costs for different types of non-communicable diseases are part of the health benefit package that is prepared. So even in this, the large publicly financed health insurance scheme that we have in our country, like which is the Pradhan Mantri Jan Arogya Yojana, we have a large number of health benefit packages that are actually catering to the needs of non-communicable diseases. So even within cancer, for example, we have several hundred packages that are for medical oncology. There are close to about 70 packages that are for radiotherapy, and there are another close to about 100 packages that are for surgical oncology. And similarly, there is a list of packages for cardiology, for cardiothoracic surgery, and other non-communicable diseases as well. So besides the fact that the health system has to bear cost and the individuals have to also bear the costs, there is a larger macroeconomic impact of the non-communicable diseases. And this is because there are large proportion of daily wages that are lost as a result of premature mortality. There are also large losses that the family has to bear because the patient is not productive enough. And there has to be a caregiver who has to accompany the patient into hospital and to take care of that. So this is what we mean by societal cost. So there was a recent study that we undertook in order to measure the health impact of one of the risk factors for non-communicable diseases, which is alcohol. And we tried computing that what is going to be the health impact in terms of life years lost, quality adjusted life years lost, as a result of just one risk factor leading to non-communicable diseases, which is alcohol. And what we found was that by 2050, if you continue to have the same levels of alcohol consumption as it is today, there are close to about 30 million life years and nearing about 100 million quality adjusted life years that are lost as a result of alcohol consumption alone, just one risk factor of non-communicable diseases. And the average life expectancy in terms of the quality adjusted life years, they are lost by about close to 9 days. Similarly, we also estimated that what's going to be the macroeconomic impact of alcohol as a risk factor. And there was a substantial overall gross economic burden on both the government and the society. And if you compute that, or if you compare that as against the overall gross domestic product, then the figures are quite staggering, that close to about 1.8% of the GDP on an annual basis are lost as a result of alcohol as a risk factors. And these are primarily attributable to the cost of treatment, the out-of-pocket expenditures lost, but also to a large extent by the productivity losses. So much of this 1.8% is as a result of the productivity lost due to premature mortality or due to the lost wages that are attributable to the morbidity. So with this kind of a background on what's the kind of the developmental impact of non-communicable diseases, both in terms of the developmental impact on the household, on the health system, the households, and the overall societal level, I'd just like to touch upon a few additional things which could be of interest to understand, because this comes from a much more macro perspective, that how does the insights into economics help us inform some of the policies related to non-communicable diseases. And on this slide, I'm just trying to put here what are the 3 key areas that economics tries to inform decisions with regards to the health policies or allocation of resources within health sector. And then in the next slide, I'll try to take the example of one of the non-communicable diseases, which is cancer, and try to illustrate that how each of these pieces fit into the broader policy recommendations for a non-communicable disease. So just to say that what are the 3 broad areas that economics tries to inform in case of healthcare. The first is microeconomics, where we try and understand that what are the different dimensions of demand for healthcare services. And linked to that is also the study of supply of healthcare services. That means how much do we have in terms of the number of, let's say, the healthcare personnel, the healthcare infrastructure, and what are the kind of incentives that drive the behavior of these healthcare providers in order to provide services that are in the best interest of both the patient and the payer of the healthcare service. So that's what we try and understand in this discipline of microeconomics. The second important field that is worth considering is the field of financing, where we first try to answer this question of how do you collect the resources or money to pay for the healthcare services, and then how do you pay the healthcare providers who are providing you services, and secondly, how much do you pay the providers? So one is that how do you pay your providers? That means, do you pay them a kind of a capitation fee? Do you pay them a fee for service? Do you pay them a case-based bundled payment, as is the case in case of PMJY? Or do you transform to even more sophisticated methods like DRG-based systems? And how much to pay providers is that what's the amount that you pay, let's say for a cardiac surgery, or what's the amount that you pay to a provider who's providing you treatment for cancer, let's say head and neck cancer using radiotherapy technology. So that's what gets covered under financing. And the third important thing is the allocation of resources. So ultimately, you'll have very finite bucket of money that would be available to provide all the gamut of services for non-communicable diseases. Now you have to make decisions around priority setting, that what you can do and what you would not be able to do, despite there being an advocacy for universal health coverage, you might need to make some hard decisions about allocation of resources that's more efficient rather than being inefficient. And one of the tools that helps inform such decisions about allocation of resources is health technology assessment. So with this backdrop of what and how economic understanding and economics knowledge and principles can help inform decision making, now I'll just flip the coin around to say that what are the specifics of a disease condition in case of non-communicable disease, and how does it impact each of these different learnings that we can draw from health economics. So the first is, and I'm specifically talking about cancer, but the lessons can translate to other non-communicable diseases as well. So the first thing that I wanted to highlight is that you have a certain amount of services that are available, but the services are largely too less in number. The providers are too less in number, and they are very inequitably spread across different regions of the country. So which means that this has impact on the access to services for non-communicable diseases or cancer in this particular case. And linked to this is the problem that there is a high cost, which we have already discussed. And that means that because of these two reasons, the access to treatment facilities is relatively more inequitable. And this leads us to a recommendation or a way that there has to be a very, very strong role of government or the entire public health infrastructure that has to be created for delivering services for non-communicable diseases. The second important feature is that in case of non-communicable disease, although this is something that cuts across the health sector, that there is a high asymmetry of information between the buyer and the seller. So the doctor knows much more than the patient. This is the case in all the illnesses, but this becomes even more accentuated in case of a non-communicable disease like cancer or cardiovascular disease, where the doctor knows much more about the disease condition and how to treat that and what can be done as compared to the patient. Now, while there is no problem in that, but the problem arises when the incentives of the healthcare providers do not align with the broader societal goals, and the provider becomes a bit more profit maximizing. And that's where the problem arises, and which has implications in terms of the vast private market that exists for providing care for non-communicable diseases. And also the fact that given the uncertainty and given this high asymmetry of information, there is a need to have standard treatment guidelines, which unfortunately, even the current standard treatment guidelines leave a lot of freedom ultimately for the providers to decide on what is the best treatment to offer to a given to a given patient with a non-communicable disease. And the third obvious problem that is present in the context of cancer and non-communicable disease in general is the high cost, which we've already discussed. And but we have very finite resources. If you look at the budgets for non-communicable disease, they are much finite. And that's why there is a need to have more value-based practice guidelines. So pay for treatments that really add value to the health of the population. And now I'll just try and take you on over the next 5-6 slides to illustrate some of these points that I've already made. So just to say that when I said that there is a shortfall of health facilities for treatment of non-communicable diseases, this is just one example to illustrate that how much is the extent of shortfall that exists for various kinds of facilities that are required or personnel that are required for treatment of non-communicable diseases. And this is just one example of radiotherapy facilities for cancer. And while on one hand, there is a overall shortfall at the absolute level, the other problem is that there is very inequitable spread, regional spread. So this shows region-wise distribution, with the first bar showing how much is the proportional mortality as a result of cancer in different regions. And the subsequent bars represent the proportional distribution of the different health facilities that exist for treatment or the number of doctors that are produced. And the last bar is the proportion of the population. So clearly what we see is that if you look at the north, west, and south region, the proportional mortality that is accounted for each of the three regions is less than the proportionate number of facilities that exist for addressing these health problems, which means that there is more than the required supply of facilities or resources for treatment for these kinds of health conditions. However, if we look at the east and the central region, both the proportion of the mortality and the proportion of the population far exceeds the proportion of facilities that exist in these regions. So which means that the inequities in the availability of resources are much more in the east and the central region. And there is a relatively more abundance in both the north, west, and the south regions. And we know that the demand is rising. This is something I don't need to emphasize to you. But ultimately, this has implications in terms of how we organize our care mechanisms or care pathways, and which means that you can't, given the fact that there is this kind of asymmetry and violations of preconditions for market, the government needs to play a very, very active role in both the financing and provisioning of healthcare services. And one of the mechanisms that the government is trying to do so is A, by upgrading the public facilities for treatment and for prevention of non-communicable diseases, and B, by creation of mechanisms such as PMJY, which help to provide free cashless services for those who are in need of such high cost tertiary care or secondary care. And the second thing that the government is trying to do is through regulation, and whereby the government is trying to regulate the prices of, for example, the high cost drugs, stents, implants, or these kinds of high-end medical procedures. And there are barriers to seeking care for treatment of these non-communicable diseases, where I don't need to emphasize that financial barriers become very important in case of cancer or non-communicable disease. And this gets well exemplified in this particular slide, where we show that what's the share of out-of-pocket expenditure as a proportion of the consumption expenditure, whereby consumption expenditure represents the ability to pay of the individual. So on the y-axis, we have this indicator that how much is the overall spending by the household on treatment for these conditions as a ratio of the overall consumption expenditure. So we see that for a lot of the non-communicable diseases, this share is much higher. In case of cancer, it can go up to more than half of the overall annual consumption expenditure. So which means that if you incur any of these non-communicable diseases, there is a very high economic impact on the household or the family. So this is my last slide on the way forward. So the way forward is that given this high economic burden of non-communicable disease, we need to focus on prevention. And we need to focus on the cost-effective ways to preventing the non-communicable disease. So we know that even if we know that screening is one of the strategies for prevention of, let's say, cervical cancer, or then even within screening, there could be n number of different ways in which you organize the screening program. And what we need to be mindful of is that we need to choose within that the best possible strategy in terms of the method of screening, in terms of the population age group that we choose for screening, and in terms of the frequency over which we would like to screen as well. So there could be n number of different ways in which we organize our public health program, and we need to be ensuring that we choose the right strategy that offers us the best value for the money that we are spending. The second that I mentioned is regulating the prices. That's the second way forward that we need to recognize, and we need to understand that this is again going to be important as we move forward towards more bulk procurement mechanisms, or towards more arrangements where we have large purchasing decisions that can take place through either the creation of these medical service corporations or through creation of these large payers like the National Health Authority that purchases care on behalf of patients under the publicly financed insurance schemes like PMJY. And finally, all of this would help develop strategies for making treatment for non-communicable diseases more affordable and equitable. So I'll stop at this point, but not before I just make a announcement about an important consultation paper that has been hosted by the National Health Authority for developing a framework for setting the provider payments and price setting under the Ayushman Bharat PMJY. And I would take this opportunity to encourage the participants and the other public health professionals who are here to go through this consultation paper and to provide any feedback that they have on the email that is shown here on your slide, because this is a consultation paper that is up for all the stakeholders to give their feedback, which would ultimately be used to develop the policy for pricing and provider payment under the PMJY. Thank you very much. I'd be happy to answer any questions if there are.
Thank you, sir. Are there any questions from the delegates? Sir, there will be no questions.
All right.
Thank you, sir, for your presentation. We will be moving to the next session. The next session is on global and regional scenario and initiatives of NCD care by Dr. Cherian Varghese. Sir is regional advisor, non-communicable diseases in South Asian region. You can start.
Good morning and good afternoon. Greetings from WHO Southeast Asia region. Congratulations for the 7th edition of this course, which I have been following.
Sir, your voice is a little low.
Is it okay now? Can you hear me well?
Yes, sir. Yes, sir.
Okay. So, as I said, this course has come out very well, and this is a 7th edition. And I just heard Dr. Prinja sort of bringing out some of the critical elements of NCD prevention and control. So I will do a very short presentation because I know that most of the items have been covered already. As you know, non-communicable diseases have come into prominence over the last 2 decades, since 2000 mainly. So we have the global action plan and the regional action plan. There are the NCD targets that you might have heard of, and the SDG targets, which are not just for NCDs, but also for universal health coverage, which is 3.8, and 3.A, which is another SDG target on tobacco. There has been major global developments in NCD, which I'm sure you are aware of. In addition to health ministries, at the UN General Assembly, when heads of states and governments meet, they have political declarations. In fact, the first UN General Assembly dedicated session on a disease was on HIV, and following that UN AIDS was formed. So that is the level at which things are being taken at NCDs. But unlike communicable disease, NCDs are quite complex in the way that one has to address. So I think as public health experts, all of us have to really understand that it is not just lack of information, some additional inputs into your hand like a flip chart. That is not going to make the difference. In fact, Shankar Prinja also mentioned it is legislation, regulation, taxation, creating an enabling environment that makes the difference. I don't know whether it is right, but there are studies which says that doctors and nurses are very unhealthy. Do they lack any knowledge? No, they know everything about NCDs. They know about healthy food and diet and tobacco and alcohol and everything. But then are they practicing that? So there's a lot of difference between what is information and what is behavior change. Okay, so I think that is something that we need to consider. So the overarching global architecture is something like this. So there is a sustainable development agenda, the political declarations. WHO looks at it through governance, reducing risk factors, health systems, and surveillance. There are the 2025 targets and the 2030 target. But globally, overall deaths are going up in the 70 plus age group, but even in the 30 to 70 age group, where one should actually be reducing premature mortality, there also NCDs and mental health conditions are going up, which is not very good. And within that, cardiovascular disease, which is the most common, is still on the increase. Cancers, chronic respiratory disease has not gone up that much, but the one condition that is increasing everywhere along with obesity is diabetes. The Southeast Asia region has achieved some progress, but we are still far away from achieving the 2025 and 2030 targets. I'm sure you would have looked at this paper on the universal health coverage related aspects from Gita Menon in ICMR, where she has very clearly shown the out-of-pocket expenditure and the catastrophic health expenditure for cancer and cardiovascular disease, which is very high, even in states which we think have got reasonably good public health systems. It is more than 60,000 to 70,000 rupees are being spent as out-of-pocket expenditure for these conditions. And universal health coverage is measured through different components: reproductive, maternal, child health, NCDs, infectious diseases, and service capacity. So if you look at the NCD line on the top left graph, the blue line is flat, whereas communicable disease capacity has gone up, the service coverage has gone up. So that means things are not really sort of moving the way we want in terms, even though if you look at any of the health system burden, it is primarily non-communicable diseases. People go into impoverishment not because of malaria, it is because of renal failure, because of heart attack. But the whole public health system is still sort of hovering around maternal child health communicable disease, because I think I would like to say that most public health teaching is also still on communicable disease and maternal child health and immunization, which are extremely important, if not sort of reducing their importance at all. But the changes in the situation has not been seen. So WHO did a midpoint evaluation of the global action plan, and to summarize it, it is a half full glass or a half empty glass. So things still have to change. So the global targets are there, which are not being achieved, but targets are important to be aspirational. This is a very nice graphic to explain to you the epidemiological transition from Africa to Southeast Asia to Europe. This is from the WHO Global Health Observatory. And because of this wavy lines, it is so clear that the brunt of health burden is from NCDs and also injuries. So that is not getting reflected adequately in public health systems, neither in education, nor in research, nor in publications, nor in practice. So at the global level, I was developing this implementation roadmap where we really want to accelerate through prioritization, through PHC and UHC, and learning from the COVID-19 experience and to build back better, aligning with what is currently out there, and have a good accounting mechanism, which almost all of you know about the NNMS and the WHO steps and other things, which will help us to account how good we are. We have developed a tool, which I think Dr. Prinja also referred to in terms of prioritization. This tool actually helps countries to understand by picking a few interventions and sort of providing an appropriate scale of coverage, maybe 3 to 5% per year. And they can have a visual impression of what the change in premature mortality is. And some of these things you can see: CVD, primary prevention, or heart failure, or trans fat elimination, or aspirin for ACS, or PCI for acute coronary syndrome. You can see that by picking interventions, you can see which are the ones which are going to have maximum impact on premature mortality, because no country can provide all services for all people, but key services for the most important people, especially those who are going to be left out of the mainstream, is something that should be the priority. So there are ways of doing that. What is WHO currently doing? We have a lot of initiatives now. You might have heard about childhood cancer initiative, cervical cancer elimination, hearts package for cardiovascular disease, and others. Just a word on global strategy on elimination of cervical cancer, which I worked very closely with. We actually did modeling to see what is status quo, which is the gray line. Then girls only vaccination plus once lifetime screening,
Girls only vaccination plus twice lifetime screening and cancer treatment, which is the purple. And you see how an incidence of 14 can become an age-adjusted incidence of about 3 to 4 per 100,000 by 2060. Imagine it is not just in 3-4 years, it is another 20-30 years it will take, even if you do that. But it is one cancer that we can eliminate, and India should go for HPV vaccination. I know some states have started, but I think again, these are the kind of guidance that have to come from the policy to the policymakers from the public health groups. So this is the life course approach to cervical cancer. We have the primary prevention with vaccination, secondary prevention. Again, thanks to Dr. Prinja, who mentioned about inappropriate screening. I think we waste a lot of time and effort on just screening, by just screening some people with some test without understanding what it is. So that has to be looked into. Screening is quite a complex procedure. So the test, the population, and most importantly, the follow-up treatment of screen positives is what matters. And then, of course, invasive cancer has to be treated. There are very ambitious target, 90% of girls to be fully vaccinated. I was talking to Maldives today. They have already achieved 90% coverage, which is excellent. And we know from Scotland and Australia that HPV vaccination after 10 years can substantially reduce cervical cancer incidence. For countries like India with huge population where screening coverage is less than 10%, I think vaccination should be a priority. Hypertension, take the simplest condition. Okay, it doesn't need any great postgraduate expertise. Ordinary nurses and doctors can treat hypertension, but still, do you know the coverage, the control of hypertension is less than 10%. That means even after a person is getting diagnosed and treated by a health provider, only 1 in 10 or less than 1 in 10 get the hypertension under control. So what are we trying to do? How do we change the status quo? Because if you don't get hypertension under control, they will end up with heart disease, blindness, renal failure, and then we spend a lot of money. So the WHO Hearts package clearly shows how to approach this. We are, as you know, the India Hypertension Control Initiative is there, which is based on the WHO Hearts package, which actually has shown that it is possible. Similarly, the WHO package of essential NCD interventions also brings out a set of interventions for primary healthcare. Again, there is a lot of talk about PHC, but what is the fundamental weakness of PHC? It is not education. It is basically the capacity to manage NCDs. Every PHC can manage maternal child conditions, immunization, some infections, TB and HIV. But when it comes to how do we manage diabetes appropriately, oh no, there is no blood sugar, there is no HbA1c, there is no metformin. So unless we plug the basic hole in PHC, which is the functional limitation of providing NCD services, then it is not going to work out. We have also updated the WHO total cardiovascular risk, which is important to assess the total risk because in countries like Asian countries, the total cardiovascular risk is very high because of multiple levels of risk factors, like some little bit of obesity, some smoking, a little bit of salt intake, BP not very high, but high, borderline blood sugar, and they actually lead to very high cardiovascular risk. We have also developed an app called WHO Pen app, which you can download, where you have all this information available. This is from Kerala, where they have taken a massive expansion of primary healthcare. Look at how primary healthcare looks in public sector. That is the level of change that we need. That's what I'm saying, that unless there is investment into primary healthcare, where primary healthcare is equipped and enabled and staffed, and there is no escape. One more module is not going to help that. There has to be actual investment which translates into these sort of pictures and human beings which are manning that. Then only we can make the difference. And of course, private sector, as the cliche goes, it is the elephant in the room. 70% of NCD care is in the private sector. Again, how do we bring private sector? Not only just bring them into this thing, how do we ensure that they go into protocol-based management and tell us what is the outcome of patient management in private sector and NCDs. So we need a progressive approach. What are the services to be strengthened? What is possible in the near term? What are the equipment and medicines and furniture, even registers, computers, to improve the human resources and the infrastructure? And how do we work on outcomes? I think we waste a lot of time measuring process. We have to look at outcome. If we measure a lot of process in how many consultations, how much time counseling, how many records being meant, and if the people are not getting good diabetes control or hypertension control or asthma control, then we are not making a difference. So I think focus on the outcomes, use a small number of outcome indicators and measure that, and then make changes accordingly. You know, the global SDG progress, SDG 3 also has many accelerator themes, which are all covered, I think, in the topics already, like PHC, sustainable financing, civil society engagement, fragile, vulnerable settings, research development, and data and digital health, which are all important for NCDs. So I'll stop by saying that service delivery models are important, package and are important, knowledge is important, but unless you put in enablers, which by mean the actual service delivery that is actually happening with appropriate government orders, additional staff, additional equipment, we are not going to bridge the gap. So in summary, you can actually see how the NCD inputs into public health programs for reducing risk factors, a good primary healthcare program to act as gatekeepers so that they don't refer unnecessary cases. We don't have to treat hypertension in all day Institute of Medical Sciences. They can actually treat phylostetrology or renal failure or something like that, which PHC cannot treat. But if you look at most medical school hospitals, tertiary hospitals, and go into the OP, what are they treating? They're treating hypertension and diabetes, which should be treated in PHCs. And that is the difference that we need to make and measure that they relate to outcome indicators. So it's not a run of 100-meter dash. It is actually a long marathon, and one should really be prepared for this. So thank you very much. And thank you, Anand and Thakur, for keeping this going, and all the best for the course. Thank you.
Thank you, sir, for your presentation. Online, if anyone want to ask question, you can add in the chat. I think there are no questions.
Yeah.
Thank you, Dr. Cherian. As I said earlier, Dr. Cherian Varghese was the first national professional officer at the WHO India office. Yes, then moved to headquarters and is now recently back to Delhi as regional advisor at NCDs. Just this week, he has come back. So,
thank you, Anand. Thank you.
Hope to work closely with him. And thank you, Dr. Cherian. And if there are no questions, we'll move to the next session, which is by Dr. Pradeep Joshi, who has already been introduced to all of you, the morning session. I know at least on day one, you will probably get same messages multiple times. I think there will be some repeats. We'll get reinforced. Some reinforcement is necessary, but some maybe over reinforcement is also there. But that's part of a problem of a multi-faculty workshop. From tomorrow, I think we will more specific issues. I'm hoping that we will not have too much of repetition from tomorrow onwards. Hope you all had a good lunch and took care to take very healthy food and not a very unhealthy food. Maybe you all can go around for a walk for 15 minutes outside. It will be very helpful, is it? You know, we plan to have a walk on day 3 at the end of the day. We'll go to a park nearby. We'll see after the sun has, or at least it has cooled down, not in this heat. But I think the point that Cherian made, that doctors are not necessarily the most healthy people. Huh? All of us have theoretical knowledge, but none of us practice. I'm absolutely certain in this room, not more than 5, maybe I'm exaggerating, would be eating 5 servings of fruits and vegetables. I'm absolutely certain of it. There is no doubt in my mind that I'm right. I never do a survey, but I'm sure it is going to happen. None of us. 5 is ज़्यादा बोल रहा हूँ मैंने. We are about 60 odd people here. So one thing is that obviously knowledge does not lead to this, and this is what something we'll discuss tomorrow. It's not that we don't know, but we cannot do it, is it? Even I, perhaps the best expert in this, even I find it difficult to reach 5 servings. 4 to ho jata hai, but 5, most of you will not even touch 4, but even touching 5 needs much more effort. Apart from affordability, probably in this room, it could said to be affordability may not be a big issue. But if we people who are most knowledgeable and largely can afford fruits and vegetables, do not consume food delivered, do not exercise for 30 days, minutes a day, almost certainly. But thoda zyada better, I think we are slightly better in physical activity than in diet. So you have to be changed. And if nothing, I say at the end of this workshop, if you start thinking how I can change myself as the first step, then you can change others also, right? So start thinking how you can change yourselves. Maybe get up in the morning and those who are staying, this is a very good campus. You can take a walk in the morning. Anyhow, that was just to fill the time. Otherwise, I can keep going on.
Thank you, Anand. Yeah, thank you, Anand, sir. And good afternoon again. In the morning session, we have already listened about what the Ministry of Health and Family Welfare is doing, the various initiatives which has been undertaken. And then we had presentation from Dr. Bari also, what AIMS is providing the support for the NCD prevention and control, followed by Professor J.S. Thakur also, what interventions PGI Chandigarh is supporting on this. So the topic given to me is NCD scenario and initiatives in NCD care. Most of things you have already learned by now. So what I have done, I have just structured the presentation, giving a brief about the NCD scenario and then what WHO is doing to support the national NCD response. And what are the areas of concern and where the WHO country office will be focusing on 2022 to 2023. As you, I just want to make you aware that we work in a biennium work plan cycle. So every 2 years we get updated our work plan. So we have in the morning listened about the NCD mortality, but coming to the point, we talk about what is the premature mortality, because the point given is that everyone has to die. But if the death is occurring in the productive age group, that is of more concern. So if you see the proportional mortality of NCDs, which is between 30 to 69 years of age group, it is more than 57%. And the distribution is same which we have seen in the morning. And Dr. Shankar has mentioned about the out-of-pocket expenditure. And this is something which we have also done. So we have found that it is around 47% based on the NSSO data. The total undiagnosed and uncontrolled diabetes, as Dr. Cherian was saying, more than 50% are still not there, and control rate is 30%. And the important part is, and I'm repeating again, that 80% of this CVDs, diabetes, and chronic respiratory illnesses can be controlled or can be prevented through cost-effective measures. And this is from the Harvard study, which says that if we don't take business as usual, there will be $4.58 trillion in the economic output loss, which India is supposed to have. So this is about, and the return of investment, which Dr. Sunny was mentioning, it was global one. I'm just projecting what India has return on investment. So for every 1 rupee you invest, you will get, for reducing tobacco, there is 9, for unhealthy diet, it is 7, and for reducing the use of alcohol, it is 3.6. The rest ranges between 3 to 2. So there is return on the investment. Every rupee you invest, there is a return on investment, and highest is it in the tobacco use and unhealthy diet, which is reduction in the salt intake. In the morning, I was mentioning about the UN high-level political declaration, and for the participants who are new to this, this is only on the second time after HIV when the United Nations General Assembly addressed any disease condition, which was NCDs in 2011. After that, there is follow-up meetings happening in 2014 and 2019 also. So every country has to report how they are doing on the commitment they have made at the United Nations General Assembly. So WHO publishes the progress monitor every 2 years. So this is the recent one, 2021. And if you see, I don't know whether you are able to visualize it, but most of this for the tobacco, for alcohol and other things, we are not yet there. And as Dr. Cherian was mentioning that if the targets are there for 2025 and SDG targets for 2030, if we don't implement this cost-effective measures, we are not going to achieve this. These are the enablers. WHO country office usually support Government of India and the state government. We have a WHO country cooperation strategy, which is a 5-year plan, which is jointly developed with the Ministry of Health and Family Welfare. And it is for all the WHO activities, including NCDs. And we are guided by the UN high-level declarations, World Health Assembly resolutions, because these are the member states, the health ministers, which decides what are the priority interventions to be taken forward. And then there is a regional, for 11 countries, we have Southeast Asia Regional Office. We have regional committee resolutions, which binds us to work with the country office. And then there are international treaties like FCTC for tobacco prevention and control. And enablers, we have already seen and then we have estimated guidelines and population-based density screening guidelines for cancer. So from here, what I will do for WHO is providing support to the 4 pillars, which has been described in the roadmap 2023 to 2030, which is multi-sectoral coordination, health promotion, health system strengthening, and monitoring, surveillance, and evidence generation. So, first of all, you have heard about the National Multi-Sector Action Plan, which we have developed with the aims and other academic institutes. Now it is time up to 2022 has to be extended for another 7 years and aligned with the global roadmap. We are facilitating the international meeting, which is very important because you have learned in the morning that health sector doesn't have much power for reduction of the risk factors. It requires other sectors, for tobacco use, alcohol use, and we will be discussing next day on this one. There is a joint United Nations agency task force mission where all UN agencies come together for the SDG response. So in India, we have 2 missions. First was 2014, and the last one was in 2018. Which guided what are the priority interventions which are required by the government and what the United Nations agencies can do to United States. Then we are doing state level multi-sectoral training, capacity building. We have done in 3 states, and gradually we will be implementing in all other states to build the capacity of the states or the national center. And with the civil society organizations, especially the and DFI, we have done framework for engagement of society. Continuing in the policy support, and this will be also reflected in tomorrow's presentation by Dr. Katika, that for the dietary control, there are different policy or regulations options which WHO is providing support. One is about labeling and display regulations, the front of plate, back labeling, which we are providing support. And still in the draft stage, discussion is going on. The other one was the limitation of trans fat from 5% to 2%. Big achievement, and India has committed by 2025 or by 2022 and then food safety and standards for the safe and wholesome food for school children, which has been recently in 2020 tobacco, I am not touching much because right from the beginning. Providing support to the government of India, whether it is the COTPA implementation, recently the electronic cigarette ban, which has been happened. We provided those evidences. Alternatively, livelihood. because the industry takes the shield of farmers for moving ahead from the agenda. So alternative livelihoods, clean rooms implementation, pack warning. India has now 85% of principal display of the pack warning on the tobacco products, and then the NTCP expansions. In the physical activity with the Fit India mission, we have developed age-appropriate fitness protocols and guidelines, which are for the all age groups. For the road safety, we are doing the multi-sectoral coordination for the road safety and provided inputs for the recent legislations which was amended in 2018. So legal development program for road safety, legal and policy provisions. And recently, because you have seen in the COVID times, there is an online sale of the alcohol and home delivery of the alcohol. So we are advocating with the government to restoring the ban on the online sales of alcohol. So it is a work in progress, and hopefully we will be able to, the 5 or 6 states which have been started, to revert back on their decision on online sales of alcohol. Health promotion interventions, you have heard about the National Tobacco Quit Line, which is the number is displayed on all the tobacco products. WHO is providing technical support in the Quit Line centers, and these are going to rapidly expand to most of the regions now. We have M-Health interventions. This is a unique intervention, which is a cost-effective one, where you send text messages to the people for over a period of time. The government of India is sending currently for the M cessation and M diabetes. So there are regular messages for health promotion and awareness, which you will receive once you register or once you give a missed call to that number. Healthy setting approach, you have heard from Professor Thakur, but in this workplaces, we have developed minimum set of guidelines for healthy workplaces. We have also developed the guidelines for promoting health in higher education institutions. We have also, in the Smart City mission, to bring the emphasis on the health, we are developing the data health model and the tobacco-free education guidelines for the tobacco institutes. There are radio campaigns which WHO supports over a regular period of time, and there is a manual which you can find on the ministry website about the counseling of the risk factors. Health system strengthening, basically what in the morning we have discussed, we are providing all the necessary support, whether it is from the development of CPSC NCD solution or development of the medical officer training manuals, or even the NPCTCS program review, which Dr. Bari was mentioning in the morning, and including this international course on public health approaches to for the state nodal officer as well as the district nodal officer. The national NCD framework, we have seen in the morning TB diabetes, but we also have a framework for TB tobacco also. There is a telemedicine consultation guideline, which has been recently come up for hypertension and diabetes, especially linking the CHOs to the tertiary care provider and how the disease can be managed over there. There are operation guidelines for rheumatic heart diseases, and there are few work which is in progress, that is guidance framework for continuing NCD services during emergencies. This will be based on the recent assessment which we have done with the AIMS, and there is a separate presentation for that also. We have also done situation assessment of childhood cancer care services in India, and that would also help in defining the childhood NCD services and cancer control strategy for Kerala. That is because the state government has requested us, so we have provided that support. So much talked about this one from the morning is India Hypertension Control Initiative. It is basically a multi-partner initiative with the Ministry of Health and Family Welfare, state government, ICMR, Resolve to Save Lives, and WHO Country Office for India. It was initiated in 2017, initially in the 5 states as a phase 1, 25 districts. Now it has been expanded to 21 states and 103 districts, and there are more than 2.2 million enrollments of hypertension patients under this ISCI, and more than 15,500 facilities, whether it is district hospital or CSC, PSCs, are providing that kind of protocol. So what are the essential components of India hypertension control initiatives? And that's what Dr. Cherian was also mentioning, that if we want to prevent and control, especially diabetes and hypertension and chronic respiratory illnesses, these are the 5 basic things which we have to do. First is there should be a standard management protocol. It should not be like varying. So if you have a standard management protocol, then you can have a forecasting of the drug, so the drug availability can be ensured. Then it should be a team-based or a task shifting, where the staff nurse takes the blood pressure and the doctors provide the treatment. So everybody is contributing in the prevention and the control. Uninterrupted supply of medications, patient-centric care, so closer to the people, providing those medicines, and most important, the information system. In the morning, or most of you are belonging from the states, you see that we emphasize on the how many we have screened, how many we have diagnosed, but when we come to the how many are controlled or how many are treatment, this kind of indicators are not being discussed at the state level. There is another interventions which the WHO country office will be supporting in selected states, which is strengthening the continuum of care. And in this, besides the hypertension, diabetes, mainly which is being discussed, is the early screening of the complications of diabetes and hypertension, whether it is retinopathy, nephropathy. So how to enable the early screening of those things, and whether there are policy level interventions are in place at the state level to support that, and how to strengthen it, that would be there. And including strengthening the health management information system. I think there are 50 participants from the states, and you know that the CPSC NCD portal, which in the morning we were discussing, there are a lot of issues related to that, and there are multiple data entry points which is happening. So that needs to be taken or rectified. That is something which we will be providing support to that, and generating this lesson and providing the best practices through the implementation research. Now coming to the last pillar, which is monitoring, evaluation, and the surveillance. So the first one will be covered in the day 4. We have already talked about the NCD program review 2019, and it has given some prioritization of the states, where the states stand against the different parameters. We also provided support in the National NCD Monitoring Survey and Burden of Diseases. Similarly to the Global Adult Tobacco Survey and Global Youth Tobacco Survey, we are supporting the states in the WHO STEPS survey implementation, recently being concluded in the Mumbai city, and also the Global School Health Survey. There are, I don't know how many of you are aware about the Comprehensive National Nutrition Survey, which is being done by the UNICEF and Ministry of Health and Family Welfare. So there were data related to NCD being collated over there. So we are developing the NCD thematic papers. What is the NCD burden among the adolescents in this one? And then the country capacity assessment, which I just mentioned, NCD progress monitor is there. And also something related to the assistive technology use and other things. These are evidence generation which we do, economic burden of alcohol, tobacco, and taxation studies on SSBs and alcohol and tobacco. Just give you some of the figures which we have found in the taxation studies, that if we increase 44% of the increase in tax in SSBs, after post GST, there will be 10% decline in the consumption of the sugar sweetened beverages. And for alcohol, if there is a 10% increase in the tax, we can prevent 14 people per 1,000 to entering into the alcohol use. So this kind of evidence helps in government to take decision on raising the tax. Similarly, for the we have just heard about the alcohol burden. Now, what is the burden related to the tobacco is almost 1% of the GDP, and the number is around 1.77 lakh crore. That is the burden of the tobacco related disease we have in India, and it is a huge contributor. So similarly we do the marketing strategies related to the HFS foods, tobacco and alcohol. What are the strategies are there, and that helps in defining this pictorial warnings and other things. And then health impact assessment, how the other sectors can impact on the health, and evaluation studies, whether it is tobacco-free films, rules, or OTT, the new platforms where the tobacco and alcohol consumption is rampant. So that kind of evaluation study WHO conducts on a regular basis. These are area of concerns which would be helpful to you over the period of 5 days. And this is basically based on the NPCDCS review. We have discussed in the morning, there are so many components of the NPCDCS which are there, whether it is CKD, NFLD, which needs to be integrated into one basket, and how to do it is a area of concern. There is streamlining between the NCD interventions, which the Health and Wellness Center is doing, as well as the NPCDCS is doing. We don't have a proper monitoring and evaluation framework. We don't have standard management protocol yet. In the ISCI, we have for the diabetes and hypertension, but still for the other diseases, the standard management protocol is lacking. And when you want to review the program, and you have seen from the TB and HIV, if you don't monitor or evaluate the programs, you can't give the recommendations how to improve. So that kind of monitoring and evaluation mechanism is required, including the dashboard provisions at the higher level. So these are the priorities for WHO for 2022 and 23, and mostly which I have discussed in my earlier slides about the National Multi-Sector Action Plan, population-based screening, integrated NCD care, scale up of ISCI, and development of policies, legislations, and other cost-effective measures to mitigate the risk factors. And especially working on overweight and obesity as a dietary risk factors, and including the civil society organizations and private sector for their meaningful engagement for the NCDs, and healthy setting approach, whether it is urban, whether it is school level or higher education level, and FCTC, that would be the core of WHO work for the tobacco control. So that's all what we are doing to provide support to the Ministry of Health and Family Welfare in support with the WHO collaborating centers. We have more than 16 WHO collaborating centers across India, and this WHO collaborating center not only provides supports to the country office or to the government of India, but to the other countries also. So that's all from my side. I know that the session after the lunch is very difficult, and especially when you are just listening what are the interventions being done. So thank you for being with me. Thank you.
Thank you, sir.
Yeah, it has been already prepared. It has been sent for peer review, and we are in discussion with the Ministry of Health and Family Welfare. So once we get their concurrence, we will be putting on this on the ministry website and starting this capacity building interventions also for how to use this teleconsultation manual, and especially in the limited facilities at this point of time, because teleconsultations have shown in the COVID that it has very important role, and different assessments which were done by the AIMS as well as ICMR for the NCDs has already also find that this has helped in continuing the NCD services. So there are standard protocols which are there, and it is basically not between the patient and the provider, because e-Sanjeevani is already there. It is between the care provider and the care provider at the higher level, how to engage and what can be provided, what feedback can be provided based on the patient. Yeah.
Cadres going ahead, or do you think that this program in itself is enough for this whole basket of diseases? I'm just curious about it.
No, the evidence which Dr. Cherian was also mentioning, and from the WHO with the universal health coverage and primary healthcare approach, what government of India is doing, especially for this comprehensive primary health care, where they have included the NCD services. And as I mentioned in the first slide, we have to take a public health approach. Which diseases are major contributor of the mortality? If CVDs are there, if diabetes are there, cancers are there, and if chronic respiratory illnesses are there, whether those interventions are at place or not. Because if you are taking those interventions into account, you are going to prevent and control the mortality of more than 80% of this. So it's not only risk factor reduction, because if you have seen the other slides which I have shown in the health system strengthening, we are also advocating, similar to the ISCI and ensuring the continuum of care, how we can early screen the person and put on the treatment and achieve the control rate for the hypertension, diabetes, and gradually how to reduce the time lag between the person who has been screened or suspected of the cancer to the management of the cancer. These are the things we don't think there should be a separate vertical programs are required. It should be taken here under the comprehensive primary health care at the primary component, and then the NPCDCS program, which takes care of most of the illnesses which are major contributor of the morbidity and mortality. Yes. See, I can understand that. And that was the reason, because see, when the NPCDCS protocol were developed and we were part of that, we can't bind the states to one drug regime. There are 4 classes of antihypertensive drugs. So that was the discussion at that level, at that point of time in 2016-17, when the NPCDCS treatment management manuals were developed, not binding the states to any particular drug. But because when ISCI was started after in 2017 late and 2018, it has provided that when you go to a standard management protocol, which starting with 1 class of drug and then adding on the drug, it ensures your availability of the drugs at the health facility level, and also it is easier to train the medical officer. So now I think even in the morning when Joint Secretary Sir was there, he was also mentioning that these are the best practices which we will be trying to adopt in the new operational guidelines of the NPCDCS. So most probably you will be seeing a kind of a standard management protocol. And the same thing WHO has also advocated, which Dr. Cherian was mentioning in the PAN protocol. If you go to you can download the PAN. It is very easy, and it will be quite useful for you. And I will recommend everyone, whether you are on Google Play or iOS, you download that. There is a WHO PAN, and you will identify whichever disease you want, especially these 4 conditions: diabetes, hypertension, chronic respiratory illnesses, and cancer. How to manage those conditions? What are the risk factors? How to manage those risk factors? It's very easy and user friendly. So I completely agree. There is a kind of a confusion whether to stick to the NPCDCS one, but the government is working now to standardize all the treatment protocols, starting from hypertension, diabetes, and other chronic illnesses. Yeah, yes, definitely. Because they will give the alternative. It will be a standard treatment protocol, but you can choose from one protocol. It will be like a linear one. Start from one drug, add on to another drug, that kind of thing. But you have a multiple options. State can choose whatever protocol they want to choose. Like in the PEN protocol. If you see the PEN protocol, you will understand what I'm trying to make you understand. Definitely, I don't have the slide right now, but after tobacco, the first most important risk factor which contribute to the 4 NCDs is unhealthy diet. That has been shown into the global burden of diseases. So that is the major cause. If you have to prevent the risk factor, the unhealthy diet is the major contributor in the dailies, morbidity and mortality related to the 4 NCDs. Then comes the tobacco use, and third one is alcohol. So definitely there are best by interventions. If you want to understand which are the best by interventions, I will suggest you go to this tackling NCDs. This is some. Pardon, sir? Yes, there is a session on the best buys. So you will understand that what are the best buys for the alcohol. And taxation is most cost-effective interventions for the, like for the tobacco and for alcohol as well.
So even it has some side effects, no, sir?
No,
If they increase the, if you increase the taxation or ban on delivery.
That is there. Person try to switch because these are addictive things. Like if you raise the tax of tobacco, person they shift to the BD. Same for the alcohol. If you increase taxation on certain amount, they may switch to a country liquor or other things. But that doesn't stop that you don't increase the taxation on the alcohol products. That is the win-win situation. You at one hand you generate the revenue, and other hand you are discouraging the people, especially the young people. If there is a high taxation, you discourage the young people entering into use of alcohol, and that is something of major concern to everyone.
They will go for alternative substance otherwise.
Yeah, but
thank you, sir.
Thank you, sir.
Thank you
for your presentation. Next session is by Dr. Rajesh Sagar. Sir is Professor, Department of Psychiatry at AIIMS, New Delhi. Sir, you can join.
Okay. Good afternoon to everyone. You can hear me. You can hear everyone?
Yes, sir. Yes.
Okay, great. Wonderful. I will just share my screen. Yeah, so that you are able to see my screen also. You are able to see my screen also?
Not all of it, only part of it. It's too big to fit this.
You can see my screen?
See your screen, but it is showing.
Yes, sir. Sir,
You can see?
Sir, it's zoomed out.
Zoomed out. I think it's, you are able to see my screen. Is it fine? Should I go ahead?
Go ahead, sir.
Okay, good afternoon to everyone. And first of all, my thanks to Professor Anand and Professor J.C. Thakur, and for this very, very important conference on International Conference of Public Health Approaches for NCD. And very happy to know that you have a dedicated session on mental disorders. And I know this is a 7th edition, and very happy to be part of it since beginning, I understand. And very, very important session. And I'm sorry that I'm not present physically there, though I wish to, because there is a meeting important. So, so I'm making this online presentation. So next 30 minutes, the topic assigned is a burden and epidemiology of mental disorders in India. This is what I will be speaking on. Now, this is just a disclaimer and my own personal experiences with related to psychiatry epidemiology, and like I have been part of World Mental Health Survey, a coordinator of India. In fact, what was very happy to hear Dr. Cherian Varghese, in fact, he was also part of this, and also part of the study on CRPF police personnel, and some of the WHO activities in Maldives and also in Nepal, and also being a chair of Global Burden of Disease of GBD International, part of INCLIN Neurodevelopment Disability Epidemiological Study with children. And also currently, myself and Anand, we are together NMHS Mega City Survey. And of course, there are several thesis work which have been part with related to epidemiology. So this is what I have been involved with. Now, this will be the outline for next 30 minutes. That is introduction to epidemiology, why major mental disorders, evolution of psychiatric epidemiology, global burden of disease. We'll talk about that, what we have learned so far, and the data till date, world literature and India literature, and common challenges and issues in measuring mental disorder. Basically talking briefly about our own experience, which is there, and also what can be done for the future, and in that way. Now, I'm sure that you are all are well versed as a public health expert about epidemiology and the definition. I think, and I think you have been know the much vast knowledge about this. But basically, it is a study of distribution and determinants of health-related events in specified population, and the application of this to the control of health problems. I think that is what the simple definition of epidemiology is. And of course, then with regard to psychiatric epidemiology, is the study of distribution of mental illness and positive mental health and related factors. I think the key thing is the related factors in human population. Now, I think it's very important, especially those who are young and postgraduates, and we always discuss about this, what the uses of epidemiology are. And I think just to recapitulate, to know the magnitude of illness, what the extent of the problem is, and so that one can build on services and so on, so to understand the magnitude. So by and large, I can tell you many of my, when we talk to our students, when we say epidemiology, they always think it's to calculate the prevalence of the illness, to look at the magnitude of the problem extent. But actually, it is one of the only uses of epidemiology. I think that is what is the key. The other aspects is which are very, very important, offering those to study the natural history of disease, like in the general population when you are, so you can see at different stages of, and that's how one can understand more in detail about the genesis of any disorder overall. Completing the clinical picture, identifying new syndrome. In fact, many times the new syndromes have been identified through the epidemiological study. So not only in psychiatry, but also overall for health conditions. So basically the idea is to have to identify the new syndrome and also to detect the individual at risk. So one of the very, very important key feature of epidemiology is to earmark, that is to know the risk factors overall. So So that way we can understand, that way we can modify it, that way we can, we can help individual. And assessing and evaluating services, which again is very, very important. And especially it becomes important for psychiatric disorder, because we all know that the resources are very less, the available services are very less. So that way it becomes a very important, of course, to determine the causes of disease. We all know for psychiatric condition, it's not pathophysiological the way you have been understanding the medical disorder. So here, of course, there are genetic factors, there are other biological factors, there are socio-cultural factors, and so on. So, but that way, this all becomes important, and that's the reason that these are important uses of epidemiology, or more so when we talk about psychiatric epidemiology. Now, methods, I'm sure you are all would be aware of it. Just to recapitulate, of course, the descriptive studies, I think in psychiatric epidemiology, these are the one, actually, these are very common type of studies which are available. Phenomenal work which has been done in this from our own country. The mainly they are targeting towards a descriptive study, basically observation of distribution of mental illness or mental health and related condition. Mainly there are more of a prevalence study. So these are in our country, if you want to say that what the epidemiological studies we have in our country with regard to mental disorders. So basically it is descriptive study, and more specifically it is a prevalence study, though incidence study are very, very less, only in for few conditions we have, but mainly it is prevalence study. Then analytic studies, I think I'm sure you are aware that it is basically to explore the basis of variation which is there in the illness rate among different groups of the population, and identify the potential risk factor which contribute to the development of disorder. Basically, with regard to case control and cohort studies, recently some of the cohort studies have come with regard to mental health, but again in the country they are very, very less, very few are there. But of course, we know that cohort studies are there, but they also become a very important method in epidemiology, analytic studies. Then experimental studies, again, not many such studies are available in psychiatric epidemiology till date. So basically, it is the test is presumed association and between risk factor and the disorder, and to seek to reduce the occurrence of the illness, how we can modify it so that we can control the disease, so-called. So RCT, comes under this. These are the types of experimental studies. Now, what's the need for psychiatric epidemiology? I think that's what the topic we need to know, so to put the context correctly. That is the awareness of psychiatric illness. We all know is increasing. More so, we know that post-pandemic, so much talk is there about mental health issues. And recently, we all know the government also has announced a budget, specific budget for the first time for national tele-mental health services. So we know the importance of this, which already we believe that was already there, but it's rather not a fortunate way to say that to know the importance of mental health, you need to have a COVID-like situation. So to understand the extent, pattern, and determinants of the mental illness. So again, the important point is it's not just a number. Again, I am emphasizing this point. It is basically to know the pattern and the determinants of mental illness. And of course, in the mental health epidemiological studies, data, it contributes to the overall clinical science, scientific research, as well as the health policy decision. I think, and that becomes a very important aspect whenever we talk of policy. We do have in our country mental health policy, which was released by Government of India in 2014. And we all know that this epidemiological data uses, it's important with regard to the policy decisions. And it also leading to better understanding of psychiatric illness, and again, which helps to better manage these disorders. And of course, for the better planning, funding, delivery of care, and so on. So one can understand there is a tremendous need for psychiatric epidemiology, which was there in our country, which we talk later on in much more detail. So there is a need for this. And of course, one of the important aspects is psychiatric disorders are not alone as such. It may be comorbid with other medical conditions. So it may affect the morbidity, it can affect the prognosis. Anyone, let's say, who has a diabetes, also having a psychiatric like depression. So obviously the outcome and other issues, the complication, again, they are different. So we need to know the kind of comorbidity which is there and which is also a part of epidemiology. And of course, the important aspect is it increases the intentional and unintentional harm to self and others, which again is important aspect. And but we all know that the actual picture is elusive, and in that regard. So, but always the attempt is there to understand more about these disorders. So there is a need for psychiatric epidemiology. Now, we'll discuss about the evolution of psychiatric epidemiology, how it has evolved over a period of time. Now, there are different waves which have been described, and the first wave, late 1800s to mid 90s, that is was mainly non-systematic type of data collection, dealing with the treatment seeking population, like in hospital, how many patients have come, and so on. So like say, for example, Esquirol 1838, the study in the hospital in Paris, where there was a documentation of increase in admission due to insanity. That's what the term which was used. And of course, the comparison was there 20 years ago and now. So just looking at the admission, the attendance in the hospital. So that was the first wave. Brugger in Germany in 1929, again, the documentation of prevalence of mental disorders by the census method. So these are some of the important aspects, important studies which were there in the first wave of studies from late 1800s to mid 1900s. Then came the important second wave of study, that is post World War II after 1945. That is, there was a great interest in mental health and mental illness was there after the war setting, and a lot of issues were there. We all know stress related PTSD and so on. And the primary research had emerged from the war setting, people having depression and other symptoms. So that was that year marked the second wave of studies in psychiatric epidemiology. In that, basically, there were non-structured interviews and symptom checklist was used for the first time. Symptom checklist was employed to explore the community sample or the general population. So major studies, of course, in this period is a Midtown Manhattan study, that is and documented 23% of the community sample, like general population sample, and they were surveyed by the trained social worker, were found to have a mental illness. Of course, they were corroborated by psychiatrists also later on. So that 23% was the figure. Midtown Manhattan study, one of the important studies. Sterling County study, again by the lay interviewers, had surveyed about 1,000 adults using a questionnaire for the first time, and also found about 20% having mental illness. So this is second wave of studies which are post World War II. Then came the third wave of study, late 1960s to early 1990s. Third wave of study. And now the time we have a better, more structured measurement instruments were available now. A better statistical analysis was there. And also looking at the specific mental illness like schizophrenia, depression, bipolar disorder, and so on. And of course, the standard nosology, like classification of disorder, was used. Mainly by this time, the DSM-3 had come, 1980, it had come, 80. So one of the major study was epidemiological catchment area study, or famous known as ECS study in 5 centers of US, starting 1980 to 85. So that was the time when this instrument which was available was DIS, which was the first time the instrument for assessment of psychiatric disorder had come. And of course, the important, consequently important was National Comorbidity Survey, NCS, 1994, where the important data had come with regard to mental disorder. I will talk that in more detail later on. So this was third wave of studies. Then we have the fourth wave of studies, that is late 1900 till date, and more comprehensive and dealing with both mental illness and the positive mental health. and mainly ecological in nature, analyzing data at the population level, taking cultural aspects also into consideration, and aim was to develop to aid in the developing health policy as such in that way. So again, we need to know that these are important studies. Just a minute. I think. Yeah, so these are and this is the time when it earmarked the World Mental Health Survey, and this again World Mental Health Survey, more than 28 countries were involved in this, and the huge data was taken, and of course Brazilian multi-center studies. So this was the fourth waves of studies of psychiatric epidemiology. Then, of course, the discussion on the psychiatric epidemiology with regard to India. Till now, we have talked about the global. The first effort was there by Dr. Govind Swami. That's where he talked about in detail about the psychiatric epidemiology. Dr. Govind Swami. Then, first successful study was conducted by Professor K.C. Dubey of Agra, 1961. It started with a total budget of 10,000 during that time. And 1960 to 1980 in our own country, that is, several population-based descriptive studies were done, and a survey of general psychiatric morbidity was done, small to medium-sized population in various parts of India. Of course, many myths were there, like psychiatric problems are not common in India, which we all know it's not true. Mental disorders are not relevant in rural India. The belief was rural India do not need a psychiatric help, and so on. And it's difficult to organize due to high cost and so on, which we all know the community care is much cheaper as compared to hospital care. So there were many myths were there with regard to psychiatric disorders. Then, of course, late 1980s, that is third wave of studies, we had after that many studies were there with regard to specific disorder like schizophrenia, depression, and so on. Specific population were studied. Like population, I'm meaning elderly and children population were also some studies were there, and specific setting also like primary care setting, the important study was there, and hospital setting and community setting and so on. And the incidence study also have been there with regard to schizophrenia. And we have a large scale epidemiological study like NMHS and so on, where there has been refinement with regard to case definition, screening, diagnosis, classification, and so on. So of course, there has been evolution of psychiatric epidemiology in our own country, and this is what the trend has been. Now we'll just talk briefly about the burden of mental disorder. And just to tell you, because always I project this slide to give the importance of what WHO talks about GBD. And you can see at the top, the leading cause of disease burden, unipolar depression, unipolar depressive disorder. And you can see the other disorders also, but at the top, you can see the longest bar is of unipolar depression. And these are the figures of women aged 15 to 44 years in high income and low income countries all combined together. And this, so why we say that the depression is one of the leading cause of disability. Then this is important to depict that how much psychiatric disorders the proportion is in the overall burden of disorder. And you can see the burden, the 13% of global burden of disease is basically related to mental disorder, like either by the, when we talk of Delhi's a premature death or years lived with disability. So that's a combination leading to disability adjusted life years. So it's about 13%, which is projected to increase further, that is 15% and so on. But the important point is that years lived with disability, you can see up to 33%, almost 1/3 of years lived with disability is because of mental disorder. So that is very, very important aspect. That is why we need to gear ourselves up to take care of the psychiatric disorders. Now, just to give you the glimpse that what the ranking would be in 2030, and the leading cause of burden, just to give you the glimpse that unipolar depression is number 1, shifting from 3 to 1. Then again, 422 is ischemic heart disease, road traffic accident, cerebrovascular disease, COPD, and so on. But here, if you can see the projection in 2030, unipolar depression, the percentage of Delhi is 6.2, and it's a number one in that way. When you see even diabetes mellitus is number 10, and so on. So you can see that how important it is in that with the projection which is there with regard to depressive and psychiatric disorders. Now, this is just to tell you that you may be aware that this was published in Lancet Psychiatry, the burden of mental disorder across states of India, the global burden of disease. I will just tell you give you the glimpse of it that this was published in December 2019, and just to give you that 1 in 7, 1 out of 7, around 14%, or total was 200 million. That was the figure for the whole country. Had a diagnosable mental disorder. That is 1 out of 7. Then prevalence number in 2017, if you can see the 1990 to 2017. So the depressive disorder was 3.3%, the anxiety disorder 3%, and bipolar disorder 0.5, and so on. Even childhood conditions were also, the percentage prevalence figures were there, 4.48, 0.8, and so on. But the important thing is that many times that is a discussion that is the number increased over a period of time? Is the burden increased over a period of time? This is the only study which says that when we compare 1990 to 2017, it has been doubled now. So this is the evidence when we say the mental disorder, the burden has doubled from 1990 to 2017. So this is the only evidence presently to say that burden has increased over a period of time. And the important aspect, mental disorder, the leading cause of year-lived disability, we just talked about 14.5, and now these are the figures of India now, 14.5% in 2017. So one can say that almost 15% the years lived with disability were because of mental disorder, and they were the leading cause of disability in that way. Now, these are the subsequent other studies. I'm not going to much details of these studies. One of the largest quoted study of Lancet of GBD. In fact, more than 10,000 citations are there for this study. And basically, this was GBD 2016, and one of the most comprehensive worldwide epidemiological study till date. And it talks about mortality, morbidity of major diseases, more than 300 diseases, injury and risk factors, global, national, and regional data is there. Examines the trend from 1990 until date, that was 2016. And top 15 NCDs, we had depression and anxiety were among the top 15 Delhi's lost. And these are the more than 18% was because of mental and substance use disorder. So, and this is about the study where has been basically, again, it's on the years lived with disability of 328 conditions published in Lancet. But if you can see here, like here also, there are, the top 5 leading cause of years lived with disability. It's low back pain, migraine, age-related hearing loss, iron deficiency anemia, and major depressive disorder. So these were 5 leading cause of years lived with disability. And this is the burden data from GBD study. Okay, so what we have learned so far. So ECS study I was talking about 1990 to 85, and of course incidence and prevalence figures in the USA more than 20,000. Looking at the mental health services need and the utilization, and the tool was diagnostic interview schedule. This was made in that time, and data was collected by the trained lay worker. And the 20% of the studied population had some mental illness in past 6 months. So past 6 months, the prevalence figure was about 20%. And of course, there were limited. DIS was not validated. DIS did not correlate well with the clinical interview finding. And of course, sample was non-representative. So these were the issue with the ECS study. Then later, the group had national comorbidity surveys. Based on this, the World Mental Health Survey was made. In fact, the main PI, Ronald Kessler, both PIs were same. We also worked with them in the World Mental Health Survey. So in NCS, that is 1994, 8,000 participants from 174 sites. as a representative. So this was a country representative sample, and the instrument was CD, that is Composite International Diagnostic Instrument. This is a WHO instrument which was modified by this group, and data was collected by trained lay workers. Now, finding a very, very important, 49% had a lifetime history of mental illness. Now, what it means is, that is what we say in US, 1 out of 2 people have a life history of lifetime prevalence of mental illness, diagnosable mental illness. 1 out of 2. That is what we always. 30% respondent had 12-month history. That almost last 1 year it was 30%. And most common diagnosed depression, the lifetime was 17%, and so on. So again, to emphasize the point, 1 out of 2 had a lifetime history, diagnosis of mental illness. And World Mental Health Survey, which we are part of it, of course, it started by the WHO group, and there was several rationals were there, that we all, it was that mental and addictive disorder are among the most burdensome, and burden is going to increase in next decade. And based on this, the World Mental Health Survey was, there. And of course, this was published at more than 60,000 from different countries that time, house to house survey. And DSM-4, at that time it was DSM-4, and 6 developing country, 8 developed country, because India was added later on. So this was published in 2004, before this. So the figures, if you see 12 months prevalence figure, 4.3 to 26% in USA, and the treatment gap was 35 to 50% developed nation, and 76 to 85% developing nation. So you can see the difference in the treatment gap. Now, these are some of the other studies which have been published on World Mental Health Survey, and I'll skip. And these are the Indian data, Indian figures from general prevalence studies, more than 30 studies from various parts of the nation, and wide variation has been reported at 0.9 to 30%. And you can see that all the prevalence figures are there of different time epidemiological studies which were done for psychiatric 0.95, 7.3, and so on. Now, these are 2 important meta-analyses in psychiatric disorder, and basically Reddy and Chandrasekhar 1998 published in IJP, that is 13 studies, more than 33,000 sample, and this was the figure, about 558 in 1,000 population, basically 5.82%. Ganguly again 2016 studies, meta-analysis, 73 of 1,000, that is 7.3% as such. And of course, there were different methods were used in selection and so on. And this is the only study by which the time trend has been mentioned, that is Nandi study. Same group was assessed after 20 years, 1972 and 92, to compare the epidemiological data. And one can see that the anxiety, hysteria, and schizophrenia were found to reduce over a period of time. You can see the 10.5 to 2.2, hysteria 24, which was much talked about earlier, it came to only 3%. But you can see depression has increased from 49 to 73%. So depression, mental retardation had increased when we compare this, the only time trend study of 20 years. Now, these are some of the important work which has been done with the, our community medicine department of AIIMS, and this is, I'm sure Dr. Harshal will be there. And as an epidemiological study, this was a very important study published in important journal, that is Psychiatry and Primary Care. And you can see in 350, the overall prevalence figure of 25.4%, depression was 15%, and MINI was used and PHP was used. These were the diagnostic instruments which were used, and suicidal ideation 10%. And of course, these are the risk factors: illiteracy, long duration of migration, and so on. Then, of course, this was again important study where the burden of psychiatric morbidity was seen among the attendees of secondary level hospital, which is there in a Ballabgarh. And basically, the idea was to implication with regard to mental health care at the sub-district level. And you can see the records of patients were assessed, about 2,800. And you can see that almost neurotic stress related disorder was 24%, mood disorder was 16%, and other episodic and approximately 12%. NMHS survey, it's a very important survey which has been going on 15, 16, and these are the prevalence figure, 34,000 in 12 states. and the overall prevent 10.6%, but when we included tobacco, it was around 13%. And these are the figures of an MHS survey. You know, these are all 4 per thousand, 3 per thousand, and so on. Now, this is one study which was based on our World Mental Health Survey data was published for all centers of the country. This is a 12-month prevalence and treatment gap, which was published in Indian Journal of Psychiatry 2017. And in that, you can see the overall number 24,000 and overall was 5.5%. But the important finding here was treatment gap was 95% for last 1 year. So it was a very important finding with regard to treatment gap. Now, these are the important figures which were there for mood disorder, anxiety disorder, substance use disorder, any disorder based on the World Mental Health Survey of all sites of the country. I will skip this. Depression, again, it's important as a part of World Mental Health Survey, age differences. So these were the important studies which was published. That is a 12-month prevalence which was there, and findings which were there that was less in 65 plus as compared to younger respondents. But this was only seen in developed country, not in developing country. And the comorbidity was there, which again increased with age and so on. And prevalence of physical condition also increased with the age, which again is not surprising, but we know that with increasing age, more medical condition also come up. These are the about suicide, which again was a part of World Mental Health Survey, and some of the important papers were published about suicide also. We all know suicide rate NCRB 10.6 per 1 lakh population and so on. And World Mental Health data also had data from developing countries. Prevalence of suicide ideation 2.1%, prevalence of suicide plan 0.7, and attempt of 0.4%. So about suicide also epidemiological data. Child adolescent psychiatry also we know that few studies have come up in India, but more needs to be done. But one of the important study of ICMR is 12.8% have diagnosable psychiatric morbidity. Now, this is published in Lancet to see the transition in the epidemiological, across the states of India, because traditionally we knew that country like India, the communicable disease, maternal conditions, and so on were more prevalent. But this study mentioned that NCD had more share as compared to other conditions. In fact, it is published in Lancet, which is available. As I said, we were also part of doing the study of CRPF police personnel. We could not publish because of it was sensitive matter, but we had submitted a report 2011, and very important data. This was taken up later, but a lot of recommendation had come which are being used currently based on the epidemiological data. Now I come to the last part, that is the common issues and challenges. I know time is short, so I will just quickly go through it. Now, wide variation reasons are many. One is, of course, defining a case itself is a problem in psychiatry. And for pathophysiological condition, it's much easier. Say, for example, if you want to know tuberculosis, so we know it's much easier. But in psychiatry, sometimes it's difficult. So there is no clear-cut boundary between the illness and the normality at times. And one of the important aspects is to have the clinical significance. Like when we make psychiatric diagnosis, it is not just a symptom. So we all know that symptom is one part, but to make a diagnosis, it has to have a clinical significance also. It has to have a dysfunction also. So that has to be there to make a diagnosis. So again, this may be at times difficult and challenging. Of course, there has been differences in the screening instrument also, PHQ, SFQ, PSQ, and so on. IPSS was also Indian psychiatric schedule, survey schedule was also made, and having number of informant. Ideally, we need to have more, but most of the study have used only one informant. Wide variation in sampling has been there. And of course, the concept like disability, care given, they are difficult to measure, we all know. And in psychiatric disorder, they are very important. And there has been a underreporting, we all know, for a number of reasons in that way. Now, these are some of the important challenges. Nosological issues means, the classification system keeps on changing. Like we had DSM 1, 2, 3, Currently, we have DSM-5, and every time the diagnostic criteria also changes. So it becomes a challenge in that way. Even ICD also, the diagnostic criteria have changed over a period of time. So that becomes challenge with regard to psychiatric disorders. And classification again based on clinical manifestation of illness, because there is no pathophysiology or etiological based diagnosis, which again, so there is high level of subjectivity in that way. And case and caseness, again, we know that large amount of morbidity is normalized. When we go to community, talk to people, they always say, no, it's okay. They try to minimize the problem and so on. And we all know the spectrum exists from much more in the normal as compared to disease, and there is no clear-cut demarcation, and there is a wide variation in the definition, which may be there due to subjective bias. Instrument again is a major challenge with regard to psychiatric diagnosis and epidemiology. Again, sometimes they are based on feeble classification system. Which one to follow? That is also a question. They are not well validated, and in that way, and there is also scope of subjectivity, and biological markers are not there. In fact, psychiatry, we do not use biological markers, only the description of symptoms. So that becomes epidemiological study much more challenging. Sampling again, also there are several limitations with regard to sample size and so on. Sometimes there are non-representative sample, and we all know large sample size, but again it is costly. We do have lack of resources. We all know the lack of number of psychiatrists which are there to really say that that becomes a challenge. Door-to-door survey again becomes impractical and very costly, and the lay interviewer data may be unreliable in that way. The information which is gathered sometimes may not be reliable, and single informant again is sometimes non-reliable, in that way. One of the major challenge is the psychiatric disorder versus other disorders, the stigma which is attached. I think the stigma, lot of underreporting. People do not come forward to tell about the problems, giving the false picture at times, because and we have seen ourselves, like if a lady is there who is married, when the someone is there at home, so obviously they will not reveal about the past problems, and the life history again is a problem. So there again, there is a poor treatment seeking, and samples are non-representative and so on. There is a lack of understanding of causal factors, and we all are aware of that, which again makes it challenging. And the cause and effect again is difficult. Like say, for example, stress and psychiatric disorder. We never know the stress came early or later. When the illness has started, sometime the stress may be there, because and that's a vicious cycle at times. And again, the concept of burden and disability are difficult to measure, and because as they are not so well defined in very categorical terms. So risk factors, again, we all know mental illness are multifactorial. So again, there is a big challenge in that way, and at times they are difficult to study, and a lot of cultural variations are there, and we need to be aware of it. And so valid tools, that becomes a very difficult. Other issues, there are several other issues. We can talk in length about that. The translation of, again, is a major issue, and we need to be aware, because there are some disorder which has a lack of insight. They are not aware of their own illness. So they may not tell you about their own problem. Someone else has to be there. And so there are several issues which makes a psychiatry epidemiological in real sense very, very challenging in that way. So we need to be aware of all these factors. So of course they are costly. We need to know, and may not be justified with regard to cost. So we really need to see that what's the cost benefit ratio, because when we do epidemiological study in psychiatry, they're very costly in that way. Non-standard implementation with regard to screening, diagnostic tools, and with regard to reliability, validity, and of course what we are measuring illness, which of course is the ill-defined. Now, just to give a glimpse of this, because post-pandemic, I'm just last part, I'm just giving you this. This was published recently, the prevalence of depression, anxiety, post-pandemic, 204 countries. And India data is also there in this, which was said to be 35% increase is there. Many people ask that what post-pandemic, how much increase is there? So it's the figure is 35%. And this all data was collated. But again, there were several issues in this, which we also have published with regard to many as a critique. Sometimes the symptoms, depressive symptoms are clubbed with a depressive disorder. This should not be done. Symptoms are separate and the disorders are the diagnosable entity. And of course, online surveys have this own critique in because personally we feel that these are face-to-face interviews. When we do online surveys, then it has its own problems. So we cannot extrapolate from there. So we have done some publication with regard to this. And because in sometimes what happens, there may be overestimation, which happened with 35% increase in our own data also. But we need to further have more studies in that way. And there is a whole concept of whether after the stress, then there is a resilience also. So symptoms goes down. So we need to be aware of some of these intricacies and nuances which are there with regard to epidemiological study in that way, even with the post-pandemic. So to conclude, I think it's very important, psychiatric epidemiology, overall planning of services, several advancement has taken place with regard to epidemiology. And of course, several issues and challenges are there, which we need to be aware of. With this, I will end here. Thank you very much. And I know I've slightly overtaken the time, but yeah, thank you.
Thank you, sir, for such a knowledgeable presentation. We will be having a break. Any questions from the delegate? Any questions from online participants? You can add questions in the chat box. Yes. If there is no question, we can have a break right now. We will meet after 15 minutes. Thank you, sir.
Thank you. Thank you. It was a pleasure. Thank you to Dr. Anand and whole team there. And my thanks to you. Yeah. Thank you so much.
But tomorrow, yeah. Oh, that's what I'm saying. You can rotate it. At least some people can see a little bit more better than that.
हेलो आ रहा है?
Department is blooming with so many lovely colors, and it's very, very calming for the mind. I want to thank the organizers for having me here today to speak on how we can promote mental health in the country. My apologies for not being with you in person.
Hello.
Nevertheless, this is a very exciting topic to speak about.
Hello.
And I hope I'll be able to discuss some of the important
It's working. I would like to request Dr. Atrey Ganguly for the next session on best. Hello. Hello, hello. I want to introduce Dr. Atrey Ganguly for the next session that is on best practices and challenges, district mental health program. Dr. Atrey Ganguly is National Professional Officer in WHO.
Thank you so much. Okay. At the outset, many thanks to the organizers, Dr. Anand and Dr. Thakur and their team for giving WHO an opportunity to be a part of this this event, and more so giving mental health a session within where we will be discussing the public health perspective of mental health. So I know mental health is very boring. Okay, I mean, at least for people who are non-psychiatrists, non-psychologists, they'll say, oh my God, we are all talking about mad people. In fact, the stigma of being a psychiatrist was so great that I know in my days, even if you get married to a psychiatrist, they will say, didn't you have anybody better to marry? So it was that bad, right? So that was 25 years ago. I'm talking about my own experience, okay? And now it is so heartening to see that mental health is being discussed, and we have a dedicated session for mental health. We have so many people amongst us who are really keen to deliberate and discuss. And at the same time, there's a lot of positivity around mental health. We have moved away, or we are trying to move away from I to we. That means we were earlier just considering mental illnesses, now we are talking about mental wellness, we. So I to we, definitely we need to be, I mean, because WHO definition of health says that it is physical, mental, and psychosocial well-being. You know, the definition of health. If you are physically fit, but you are mentally disturbed, then you are not a healthy person, right? More so taking this I to we. Earlier, it used to be just, like it's just the domain of the psychiatrist giving treatment, but now it is we, like more than one person, it's a team. It has got psychologists, psychiatrists. So taking that I to we, I would like you to be that we, okay? So I would first like to listen from you, what is, how you at your workplace have been taking forward mental health agenda, and that will also help me to shape my presentation. So may I just, anybody volunteering, please? You just had a nice cup of tea, coffee, full of enthusiasm, right? You must be, more like vibrant to respond. May I hear from somebody, please? Yes. Right. You can switch on the mic.
When we started the district mental health program a year back, even though sanctions were given in 2018, we have seriously started working on mental health from 2015 to 2020. When we started mental health program, and we have called separated program for identification. Everything we have ASHA districts program, wherein ASHA US is there. ASHA will identify people and see, we have made. So we have made a schedule for the psychiatrist to go to the PHCs. Instead of the suspected persons coming to the nearby district hospital or faraway place, we have made the psychiatrist go to the PHC. We have provided necessary mobility and all. In spite of that, the problem is branding them. Like out of the questionnaire, he has some or other defect, but bringing them to the PHC is a major challenge for us. And fortunately for us, under our dynamic commission, ma'am, we got even opioids are being prescribed to the psychiatrist, but being dispensed by the PHC medical officer, and it is being followed up. But only problem is making them come to the PHC. That is a major problem, ma'am. So from the regular cadre also, we have about 27 psychiatrists from the regular cadre, and we have recruited 23 from mental health program. So as far as specialists are concerned, we have no issue. But major challenge and issue which we are facing is this, ma'am.
Right, right. So we've kick-started the best practices and challenges. As Sir said, it is very difficult to bring the psychiatrists to the periphery, and the best practice is that they have empowered the PHC medical officer to dispense medicine. So we'll be discussing this. Anybody else? I think you all will be contributing to the presentation. Anybody else, please? I'll be really happy to know. Yes.
So I think taking forward what you just mentioned is like shifting from I to we. So what is essential in mental health, what I believe is from the public health perspective, is that mental health is now being used as a screening. We really do not have a target population, and that has helped remove the stigma. We are not targeting the people who are already affected. We're rather trying to find out people who could be affected, or what are the possibilities of preventing a mental damage. And when we realize that we realize that all age groups are actually falling under mental health cover. So that means that this is how this topic has gained so much of importance. Like we feel now a woman needs mental health program, an adolescent needs mental health program. So this is kind of a converging cover which everyone needs. So it is not about just getting psychiatrists to the periphery, because it's not just people who are already affected that we are tackling. We are trying to prevent further or at least the initiation of a mental health damage. Like school health. Why are we giving them about personal safety, talking to them about good practices, safe practices? It's all to maintain a sound mental health. So I feel that inclusion of mental health under the primary healthcare cover, wherein we start screening and we start doing health promotion activities, that is more important. Advocating mental health is more important than actually talking about curing mental health, because curing mental health definitely has a bigger, it's a very, as you said, a forbidden area. But this is a more approachable area. So I think that is how it's important. I'm from Bhubaneswar. No, I'm a faculty in a medical college, but this is Kalinga Institute of Medical Sciences.
Thank you. I think ma'am has really hit the nail at the head. We definitely, screening and treating patients definitely is important, but then to prevent, as we had, when I came, my colleague Dr. Pradeep was talking about alcohol, that if you raise the prices, lower the people. So everywhere we are talking about health promotion, and mental health promotion in particular is very important. So I really think that this is important, and these are, so I'll take the presentation forward. We'll be discussing about the burden of mental health disorders in India, what are the government interventions and challenges and practices under DMHP. So mental health burden of mental health disorders, I won't go into detail. We had a very vivid presentation by Dr. Sagar, and that was really quite information and quite, opening our minds to it. I would just like to highlight the fact that about 150 million people in India needs intervention for mental health disorders, and only 30 million of them seek care. So why? We need to, why just 1/5 of them seek care? Is it that there is a facility but people are not going? Is it whether there is no facility? What is it? So this is what we need to see wherever we are posted. Secondly, I would also like to say alcohol and substance abuse is also contributing greatly to mental health issues. During COVID, we'd seen, there was increase in alcohol intake, and, then there was a ban, and then many of them went into, delirium tremens and alcohol withdrawal. So how to deal with such situations, which becomes another part which aggravates the already existing mental health issues. That's important. Third is the workforce. As we know that this is at least a little old data, because we don't have data from the 2020 mental health atlas, but yes, of course, the number of people who are actually in the mental health domain is very few, and more so they are all confined to most of them confined to the urban areas, preferring to do private practice, because of course these programs don't pay them well, right? So how to solve this? Okay. So we have a lot of interventions, like the government did consider mental health as a priority from 2014, in fact, when we had the mental health policy coming in, and thereafter the Mental Health Care Act came in 2017. And this National Program for Mental Health, this is way back in 1982. In fact, it is very interesting to know that mental health program is one of the oldest programs in our country, but unfortunately it didn't take off the way it should have. We do have other programs which did take off, multiple reasons, but yes, we are now ambassadors for mental health, I hope, and then I hope that you at your place will really help mental health being taken forward, right? So we have the National Mental Health Program, which has some district level activities and tertiary level activities. Under this, the government supports a creation of mental health cadres, like the hospitals, the medical colleges are supported, the Department of Psychiatry is supported to create more of MD seats, or more of psychologists, PhD clinical psychology, psychiatric nurses, psychiatric social workers. We have 4 cadres. Does all your state have got 4 cadres of mental health professionals in your state? Everybody can. Do you have psychiatric nurses in your state who are there in the public healthcare system? You have? Okay, Bangalore, you have NIMHANS supplying. Okay, any other state apart from that? No, very few. So nursing, psychiatric nursing and psychiatric social work, does all your state have? They do have? You're from which state, ma'am? Okay, great. So this is great to know. States are making efforts. In fact, with the onset of COVID, mental health is one of the major priorities for Government of India, and they are, there's a lot of guidance from the national level to the state, to the district, to the sub-district level to strengthen the mental health care. And we also have there is a digital academy, because the people who are concerned cannot be sent to another place for a long time, because they have to perform their duties. So the digital academy has come up in a big way, wherein people can sit at their own place of work, and there are many centers, like NIMHANS is one of them. You have CIP Ranchi, there is one in Gujarat, LGBT Sport for Northeast, who who trains people online. And before COVID, they also used to go to their place and give some on-site training also. Do you know about this in your state? Any of your people had got trained? So you're from which state? Gujarat, great. So you have the digital academy there. So some of the states are doing real good work. And very lately we had the Health and Wellness Center also has a package for this is called MNS packages, mental health, neurological and substance use disorder package, which provides care. But again, to tell you that it is more on a curative basis. So we really need to move from a curative model to a to a wellness model. We cannot leave behind the curative model, but we have to incorporate the wellness element in a big way. So this was the national mental health policy, and it had some very progressive steps, very good to read, and very enthusiastic government commitment. So this is something really great, and our country should be happy about it. Then came the Mental Health Care Act. This is also something very progressive. This is in line with UNCRPD. You must have heard of UNCRPD. Anybody? UN Convention for People with Disabilities. Okay, so there is a convention, that UN convention, wherein people with disabilities and mental health, certain disease conditions does fall into disability. So people cannot be discriminated, people cannot be coerced for treatment, etc. So there are a lot of good progressive clause in that UNCRPD. Also, WHO has something called the quality rights, wherein the care which is being provided, is it of good quality? Is it complying to the human rights? Because we've seen with mental health people with disabilities, a lot of brutalities had been created in the past. They used to be chained. They used to, and you must have heard of the Irrawaddy massacre in 2001. It happened in Tamil Nadu, where in fact that was a landmark. The people did lose their lives, but it was a very heartfelt and very traumatizing experience for all of us, because about 22 people with mental health disorders, they were chained to poles, and this was in a shed next to a madrasa, next to a mosque in Tamil Nadu, and that had the thatched roof, and the roof caught fire, and it fell on these people, and they were burnt alive. So after that, the Supreme Court came and said that no chaining of people with mental illnesses. They are all free people, and there are guidelines even in institutions. Certain things have to be adhered to. They should have access to regular change of clothes, their personal hygiene, everything like hair, nail cutting, etc. And they should be fed well. No coercion with them. That's all. So okay, so even and in this we also have this. This is further taking forward these progressive steps. You have the Mental Health Care Act, which says that suicide is decriminalized. Earlier, you must have seen people with committing suicides. They were tried in court of law, but now the government said that when a person commits attempt suicide, they are going through some mental health, mental turmoil. So rather than penalizing the person, and it's the government's duty to provide care, mental health care. So mental health has become a right for people, and all these what you call the coerced or forced admissions and all those things have been now. If there is the patient has a right to appeal in the court of law if he or she feels that he is ill-treated, right? So these are, even for electroconvulsive therapy and all, there are certain guidelines. It can't be done. So this is it, and the rules came in 2018, and thereafter it started being implemented. And this came on a very iconic day, because 2017, 7th April, all know it's the World Health Day and it's WHO's birthday. And that particular year, it was dedicated to depression. And this act was passed by the Parliament on this very day. So it was a real jubilation for, World Health Day and depression prevention efforts in India. So coming to district mental health program, you must have heard of district mental health program in your states. All of you have? All your districts have the program? Okay, good. So primarily, this is now, out of the about 750 districts in India, we have it in 714, which is very encouraging. And this happened in a span of 5 years, from 120 to 714, is really shows the commitment of the government at the central level and also at the state level to pull up. So basically the components, what it was discussed, is to provide the basic mental health care services. Now this basic is like what it was in 1982, it is different today. And district mental health program came into being in 1996, when it was felt that national mental health program has to go to, as Sir said, it has to go to the field, it has to go to the community, because there's so much of stigma and discrimination. People will not come for care, so we have to move, we have to move to the people. So that was the reason why this district mental health program started happening. And now with most of the states are having it in all the districts. The states, like many of the good states like Karnataka, Chhattisgarh, Orissa, to name a few, and even others, they are now going to the taluka, the CHC level, PHC level, and they are having sessions, dedicated days for mental health, so that people can come close to the community, they can come access care, and care is taken that all the services are available at one point, so that people will not say, oh, he's a mad person, he's going for that. So that those things are also taken care, so that if it is a one window approach, then nobody will point fingers if somebody is coming from mental health. So, and then outreach programs, you have targeted interventions, as ma'am said, very importantly, skill development in education institutions and schools, colleges, workplace stress management. This is very, very important. We have a lot of our workplaces which are unorganized sectors, and there's a lot of exploitation. Alcohol is in a very big way in these. So how to reach to these unorganized sectors? This is a challenge, definitely. And then suicide prevention services. So this is the MNS package. This is the latest one. You can access this from here. Now coming to challenges. We had the first is dearth of trained human resources. Do you agree? So how do you think we can fill this dearth? How can we produce psychiatrists overnight? How can we produce psychologists who will be primarily in doing the mental health promotion part? Training. Whom do we train? Right. So what we will do is we will train the non-specialist cadres, right? So in the next slide here, I have enumerated the challenges, and next slide we'll be discussing, right? So then limited awareness and associated stigma and discrimination. We all know, people still now feel that it is upar ka saya hai, some it's the punishment for our crimes we committed in our previous lives and all those things. Even for alcohol and drugs, they say, "Arey, isko pata nahi kya ho gaya, why is he taking alcohol?" So, but then they fail to realize that it is a disease like any other disease, right? So that is it. Third is poor availability of, at the community level, we don't have the earlier, like we have it in tertiary care centers, hospitals, but in the community level, it's not there. Availability of medicines or other essentials, these are also very crucial, right? Then record keeping at the district hospital, like this is very important, because one patient comes and then today he's looked after, again 6 months later he'll come, we don't have records, so the doctors have to start from scratch. So this is also very important. Then other sectors, also involvement of other sectors. Do you agree that mental health is needs involvement of other sectors, or are we just creating a crowd by calling others? It's needed. How is it needed, ma'am?
To involve the education sector. Then talking about the fact that women can be more vulnerable if you want to involve those departments. So there are various ministerial departments, and also I think beyond the ministry, if you want to involve CSOs working in those spaces and bring their expertise on board.
Totally agree. Okay. So next is like fewer opportunities for targeted interventions for suicide prevention, because anybody who has prior attempted suicide or has suicidal ideation or tendencies, they will hide it. People will not, their parents or their family members will hide it. They will not share it with people, and then when the child or when somebody does something really aghastful, then they feel sorry about it. So this is a very difficult situation, and we've seen how COVID has affected us all. Do you agree with it? Do you think COVID had been very detrimental to our mental health? Anybody who does not agree to it? I think we've all been affected. Nobody can say, that COVID didn't hit us, right? So even if you had not got the disease also, we've been under stress. So all these have been really, really, so we have to find a solution. We can't have human resource trained overnight. So how do we fill up the gap? So there is this non-specialist cadres have been trained, and also the digital academy and online trainings. So non-specialist cadre, what has been done? This is also in line with what WHO called the MHCAP, or mental health global analysis program, global action program, sorry, wherein the algorithms are there, right? If somebody comes with different symptoms, you have it in many diseases like STI. Also, you have the syndromal management. I don't know if you have been. So you have, these are now the trend wherein you just give these symptoms, and then there are algorithms to do this. If you're having ABC symptoms, then do this. If you have D, then do that. So it navigates you, and then the doctors can give treatment. Also, the non-specialist psychologists, those who have done MA psychology, not a clinical psychologist, they also can get tips on counseling. They can be done a course, as ma'am said, counseling and things like that. So they are equipped to handle the situation. Right? Then digital academy and online trainings, of course, they have come in a big way. I'm not saying they're a replacement to physical trainings, but definitely they are an alternative when things are hostile, like we had the COVID situation, then we did it. Awareness about the stigma discrimination, as I said, there has to be like thorough community-based campaigns. And community awareness, sitting in Delhi or maybe at the state headquarters, you cannot design the community awareness campaign. Am I right? Why is it so?
Because we don't understand the population's thought process. We don't understand how they will react to what we think at that level.
Exactly. So the perception of these issues are very different to different people. I may be thinking mental health very differently, somebody else. So we really have to get to the community if we want to plan the IEC, right? So these are some very beautiful images we've got from one of the states, wherein the Asha, she writes on the walls and at a common place, where people can just look and have. These are very simple, cheap, almost zero expenditure involved, right? But it spreads the message. So we can do that. Then secondly, we can have. Yes, ma'am.
क्या है चिकन तो घर आते हैं ना हमको भी बहुत एक चीज से पेट नहीं भरता ये खा लो वो खा लो एक चीज अभी खाने का मन नहीं करता नहीं मतलब कि वो हाँ मतलब होता है कि 3-4 कोर्स मील हो जाए तो जानते हो उसको हेल्थीफाई करने के लिए ऐसा करते हैं कि कल से ना कुछ सूप भी रख लेते हैं हाँ क्या सूप या स्मूदी कि पेट में चला जाए या कोल्ड कॉफी या समथिंग
services, you have like some of the states have done dedicated mental health care, like in Karnataka. So where like we have Imano Chaitanya on every Tuesday, wherein we and people have moved to taluka level. Then there are also other states who do it. These are specifically very dedicated services which encourage people, and ashas and community workers have been asked to gather patients and bring them to these health centers. Then availability of medicines and essentials. This is also very important, because unless you give them the entire treatment course, people will not come back. They'll say puri dawai to milti nahi hai, and they have to travel a long distance, so they may be not very keen to go the second time. So there is now the centralized procurement system, which avoids pilferage and all. And during the COVID, we've seen many states, like they are making extra efforts. They are going to the patients' houses, like in far-flung areas in Assam. We came to know that, like, you have these boats going with immunization. So they used to have these boats in the Brahmaputra Valley, Brahmaputra River. Beyond that, there are some islands in between Brahmaputra. So they used to go on boats to give them medicines. So you have them, I mean, especially in states where there is a lot, which is very riverine, lot of water bodies, people not only just on car or jeep, they also use the waterways to reach out. So special efforts have been made. Then record keeping, yes, now there is, I mean, Karnataka definitely is way ahead with others. They had devised a platform called eManas, and now it's being discussed how to like have it all India, how in one dashboard we can see what is going on. Then, as ma'am said, involvement, and also we had ma'am also speaking how to integrate it with other programs, other non-health sectors, and school is very important. Something very important which we tend to forget, and I strongly advocate, is old age mental health care, which we do give a lot of emphasis on child mental health, adolescent mental health, but we forget because but then we have a very fast growing number of older people. So we have to devise how to reach. We don't have that platform for schools and all, but schools also, there is a very large number of children who are out of school, how to reach them. And they are very, vulnerable to mental health issues. So that is something I think you people can devise something and come back and you can suggest to Government of India. Okay, please tell.
Within the RKSK, the peer educator model could be tapped into.
Right. Yes. Anganwadis is also good, wherein, we can, and Anganwadis, we can, because there are pregnant mothers and, lactating mothers. So maternal mental health, and also nowadays, many of the states like Chhattisgarh has a good model. They are trying to have mental health across life course, where maternal mental health, they have in that ASHA package, wherein, the antenatal advice is given, including family planning, etc. So they are the family is also given tips on how to maintain maternal mental health, because it's not. Yes, RCH programs. So it is not just post-natal, but even during pregnancy, there may be issues which has been documented. So if we include it in the ASHA package, if we include it in the antenatal back care package, when we are preparing the mother and the family for the delivery, I think these are few tips which go a long way. So these are there. Then something like how to targeted interventions to prevent suicides, very important. We have our some states have gone with something like suicide audits, death audits, like you have maternal death audits, they are going for, right. So they also have suicide death audits. What was the reason, right? So that also gives us some, because many a times suicides have got a lot of social linkages. There may be, what had been the cause, or if there are other children or other family members who have the tendency to commit suicide. So these are helpful. It is difficult to have, when people talk about these things, they are not very open in talking, but then yes, there are specialized, our cadres can be trained to actually get the story out, so that it it is going to help devise interventions which will save many, many lives. And our government is very keen. I mean, they are working on to have a national suicide prevention strategy, and very soon we are hopeful we'll have that. Also, then going to these Nasha Mukti Kendras, schools, workplaces, prisons are also very important because there are large number of drug addicts in the prison. So one has to take care of their mental health, and also being in the prison, they feel even juvenile homes, etc. Then best practices under DMHP. While COVID pandemic, we had very good work done by our people. DMHP, in fact, was one of the program which was operating even at the height of pandemic, where all other programs had come to a standstill. Do you agree? Do you have any good practices from your state during DMHP? Anybody would like to say? No, none of your state did any work during DMHP during the COVID times?
Working under SCA and mental health program is run by.
Is not under you. Okay, fine.
That's why we are not knowing.
Okay, that's why you're quiet. I understand. Okay, so what we had is the government put up a toll-free number, NIMHANS. So this is like you connect to that number, and then there are 14 languages in which you can speak. It is in line with what ma'am said, that unless we speak in the same language, we will not be able to, the person will not be able to express. So 14 languages. NIMHANS is the nodal center. When you make a call, then it goes to, there are different all over India. They have identified 14 institutes who will take the call, and then they have people to talk in their language. Second is the provision of psychosocial support through the inbound and outbound calls at the centers. So in the first and second phase, where you had people being in COVID centers, so they were given calls. And many a times what happened was, especially in the first wave, it was such a stigma that even if after you have been cured, the society was not accepting them. So district mental health program staff did counsel the colony people, and they were able to get these people again back to their homes. So, and then these calls, there was this number from where there were regular calls to the patients who were admitted in the COVID centers, also to their family members. So the district mental health program did come in a big way in that. Also, when initially this crisis for migrants were there, so the first picture you can see how these migrants had been rehabilitated, and people are being given psychosocial support. So they had contributed a lot. Not just, those days COVID was such a scare. They had not thought about their own health. They were so forthcoming. So I think they all need a salute. Then home delivery of psychotropic drugs. As I said, a lot of innovative methodologies were devised, how to reach out to them. Then provision of counseling in the quarantine and isolation centers we had. Capacity building came up in a big way. All the states had engaged these digital academies to train their staff. And as Dr. Sagar said, now a new program has been budgeted in this budget, where it is called the National Telemedicine Program. So we hope that in the near future, mental health will have a good, bright future. And from we will be in true spirits, moving from illness model to wellness, and we'll be able to prevent many cases with effective treatment. We'll not be able to prevent all, definitely. Some would be needing care, but yes, there is hope, and there is optimism in this. Thank you. So any questions? You all slept off? Oh.
Ma'am, I have two questions. So the first question is, what is your opinion about using non-medical treatment? Because there are a lot of beliefs in common public about like there is some spirit entered in the body, that's why he's behaving abnormally. So I have, in my state, Tamil Nadu, I have heard that like in one PHC, they were integrating this local priest in a PHC. They will also simultaneously treat along with the psychiatrist, and that model was bit of a success. So what is your opinion on that, ma'am?
Yeah, definitely. As I said, there's gone are the days wherein, only the psychiatrist would treat. We need to have a team, and counseling. There are different types. One is a very specialized counseling by clinical counselors, like those who are, PhD in clinical psychology. But even the other health staff also can be trained in certain degree of counseling. Even approaching the patient, asking the patient to sit, talking to the patient also has got a bearing on the treatment that is being given. Not always you need to give them a pill, but the way you speak to them, the way you tell them that this is curable if you adhere to the treatment. And of course, psychotherapy is one of the, standard means of treatment. It's not just the psychotropic drugs. So that's okay. And in fact, in these COVID centers, everybody was given a capsule of training, how to interact with the patient, how to interact with the family, how to break the, many of, especially in the second wave, we had a lot of mortalities, how to address that, how to break the news, grieving. These were very important and sensitive issues which, we need to take care. And that was done.
My second question is referring to that state mental health systems assessment and NMHS 2016. There are some gaps identified in district mental health program. One of it cited is there are lack of evaluation indicators, lack of evaluation. So one of the reasons might be lack of health records. So what are the various other reasons for lack of evaluation of DMH?
Well, see, evaluation, if has to be done, it is, it's a bit of a policy decision to go for evaluations. But yes, anything, I know if it is not evaluated, not monitored, then we are. But then these are all policy decisions. The government has to take a call whether they want to go for evaluation of a particular program or not. But then there is an internal system of monitoring. If you must have heard of the PIP, the program implementation plans. So all of you are state program officers, right? So when you are seeking funds for the next year, and this time it is for 2 years, right? So you have to give a performance. You have to show how your state has performed the progress. So that is a way of sort of evaluating or, keeping a tap of how things are. And definitely mental health, the number of districts being taken up is also an evidence that there is, more. Obviously, to have these mental health issues and engaging community in a big way, these are definitely indicators that the program is progressing. But of course, lots have to be done, lots need to be done. Yes. True, exactly. In fact, just to tell you, since this is beyond DMHP, WHO supported, there was a request from the nursing division in 2020, central government nursing division, because 2020 was also it was the 200th year of Florence Nightingale's birthday. So the International Day of Nursing and Midwifery, which falls on 12th of May, was celebrated in a big way. And those days in the first wave, a lot of nurses were really struggling, more than the doctors, because they had longer durations. So we supported through NIMHANS to create a module wherein, it can be self-training. The module is there, you can train it. Also, you can have it in a classroom wise. So this has to be, the nursing division is making it mandatory for all nursing institutions to follow. Of course, the doctors will also take it through. Yes, of course.
No one has, in Vijay Medical College, I have never seen a psychiatric department.
True. Yeah.
Till my PG completion.
Yes, of course. That is, in fact, everybody is saying we need really good advocates for that, because changing the medical curriculum is a mammoth task. Not so easy. But then in incorporating mental health in doctor's curriculum and nursing curriculum, rehabilitation medicine, all across is very important. We need to wind up.
Ma'am, how can we include the migratory population that comes to big cities without family support, and they have mental health issues, like no one to approach, even labor ministry doesn't respond? And I have that observation in industrialized cities that happens. A lot of people come in lakhs and then migrate, and no one is to take care of.
That is there because in urban setup, we really lack the societal support. Yes, but that is there. But again, people who come, they form peers. They can be of support to each other. That's the beginning. I would say we have to make our own efforts. We cannot have the government doing everything for us. So that is also, I mean, support. Yes. नहीं, वो DMHP का part ही है. You have these clinics wherein drug de-addiction. But it is it is included in the DMHP. The services to be provided under DMHP. Drug de-addiction is a mental health.
Thank you, everybody. It was a long day and maybe quite a bit of theory. One thing which we have not done is that we have not introduced each other. I think it's something we should happen maybe at the beginning. So I request my faculty colleagues to come here. And some of them have not been yet introduced. So why don't all four of you come? All of you, Bari, you also. You are also my faculty colleague. And we'll start with introduction of the participants who are online. So requesting all online participants to switch on their video and be ready to introduce themselves. Then we'll go to the introduction of people who are here. Then we move to the working group after that. So Abhishek, can we go for that? You have to stop sharing this. I think this is not required. So in the are they ready? But we can't see them on the screen, no? Okay. So in the meantime, we have two other faculty colleagues from my department. They also will be the facilitators for their own working groups. So first is Dr. Sumit Malhotra. He is additional professor in the department. And maybe you can want to say something more about yourself.
Okay, I think that's sufficient. Very good evening to all of you. I'm Sumit Malhotra. As I said, I work as additional professor at Center for Community Medicine, AIIMS, New Delhi. I'm very happy to be a part among all of you and very eager for all the group activity and interaction more that's going to happen for the next few days. Thank you.
I myself, Dr. Mohan Berwa, I'm faculty again in CCM. And in the next couple of days or next for up to 9th April, I would be with you regarding the work. And I'll work with you on the working group on people-centered care. Basically, we have started working on the people-centered care perspective because we have realized that NCDs have a different domains and different kind of the care is required rather than communicable diseases. So let's have a good discussion and good work on the people-centered care, learning, and thank you.
Thank you, Sumit and Mohan. We'll now go to introduction of participants. Online, I'm just going to call names which I can see from the beginning. The first one is Anita Kankaria. Ankita. So Ankita, can you introduce yourself?
Ankita,
you're muted. Yeah.
Good evening, everyone. It's a pleasure to be part of this course. And myself, Dr. Ankita Kankaria. I'm an assistant professor in Department of Community and Family Medicine at AIIMS Patinda.
Thank you, Ankita. Next is Subarna Sinha.
Thank you, sir. I am Dr. Subarna Sinha Mahapatra from West Bengal. I am currently working as a senior resident at the CMOH office, Paschim Bardhaman.
Okay, just a feedback from the people who are online. You could hear most of all the presentations today. There was no problem in
the middle. Sometimes there is a problem, but it was solved later.
haven't got response. Question.
Okay, so please feel free to, I know in online it is difficult to have a good interaction, but whatever we can do, we should try to do. Next is Varsha. Varsha Singh. We can neither see you nor hear you.
Maybe we can revisit again.
Ask to unmute.
Vaibhav.
Just click ask to unmute, that prompts them.
Yeah, Vaibhav Rastogi, I just saw your face while they were this thing. Well, he has worked with me before, so I recognize him. Arindam. सबको अनम्यूट कर दो ना, बेस्ट है for this session. Yeah. Just unmute everybody. Shivangi Rajput.
You can mute only.
No, but sometimes.
Hello.
Yeah.
Yeah.
Good evening, everyone. I'm Shivangi Rajput from BJ Medical College, Ahmedabad. I'm a second year resident.
Okay, we cannot see you. Maybe there's problem with the screen management. Okay. Your camera is on?
Yes, sir.
Just scroll on right. Focus nahi.
Yeah, maybe remove one or two, as kind of photos.
Remove the pin.
Spotlight kiya hua hai ya jo bhi kiya hua hai, you have to remove one or two, and then. Yeah, we can have a gallery view also, so that we can have more participants' faces visible to
better.
everyone.
And maybe you can take a photograph and screenshot for as a record purposes. This is the reason why we didn't have it in the morning, because
now we can
half
see
an hour, 45 minutes इसी में लग जाता हमारा. So why do we didn't want to do this? Yeah, okay. So Shivangi, we can see. So now Lakshmi, just unmute and introduce yourself. You are not unmute. You are muted.
Very good morning, sir. This is Dr. Lakshmi Rajiv. I'm currently working as senior resident in Government TD Medical College, Alabama.
Thank you. Next is Subarna. हो गया ना? Vaibhav.
Yeah, good evening, everyone. I'm Dr. Vaibhav Rastogi, currently working as consultant in the Child Health Division of Ministry of Health and Family Welfare.
Shalini. Paulami, you can go ahead.
Good evening, sir. Myself, Dr. Shalini Singh from BJ Medical
good evening,
College,
sir.
Ahmedabad.
Right, Shalini. Now we can go to Paulami.
Okay, sir.
Good evening, sir. Myself, Dr. Polam from Agartala Government Medical College. I'm from Tripura.
Melinda.
Good evening, sir.
Good evening, sir. I'm Dr. Belinda, working in Sri Chitra Institute of Medical Science as research officer.
Okay, Pallavi. We can't hear you. You are muted, Pallavi.
Hello, am I audible, sir?
Yeah.
Good evening, sir. I'm Dr. Pallavi Mishra. I'm from Lady Harding Medical College, second year postgraduate student.
Okay, thank you. Tripti. Tripti, can you introduce yourself? Priyank.
Good evening, sir. I am Dr. Priyank Sharma, second year medical
PG student, Lady Harding Medical College.
Thank you. So Tripti, can you hear us? Do you want to introduce yourself? Okay, Arindam.
Good afternoon, sir. This is Dr. Arindam Das, Agartala Government Medical College, second year postgraduate training.
Thank you. I request everybody to have their video on at this point of time, irrespective of whose name is being called, so that we can also have a screenshot. Shibaji Dev Burman.
Good evening, sir. Good evening, everyone. I am Dr. Shivaji, and currently I am Assistant Professor in Lady Harding Medical College, New Delhi. Thank you, sir.
Jagmohan Reddy, Jagannath Reddy, sorry.
Sir, I'm Jagannath Reddy, sir. I'm sitting outside the room, sir. I'm Jagannath Reddy, State Coordinator, Telangana, sir.
Oh, okay. No, he just told me that he has a video call with the Chief Minister's office. So he had gone out for a video.
Sir, sir.
Okay, Pankaj. Pankaj and Tripti, are you there? Satik, let's go ahead with.
I think we have covered everyone online.
Anybody online who is left out, who has not yet been introduced? Okay, now we'll start from this end and we'll introduce yourself.
What you're doing before,
Good evening, everyone. I am Dr. Swarnalata Das, working as Professor Pediatrics. I have come from Bhubaneswar.
You are Professor of Pediatrics.
Yes, sir.
So
But now I am doing PhD in community medicine.
So that's what I'm saying. Why should be a Professor of Pediatrics be here? Yeah, just this morning we discussed with the Ministry of Health and WHO how to start introducing childhood NCDs into the program. So we're about to frame guidelines and look at how we can integrate childhood NCDs, major and childhood NCDs into the program. So that initiative is going to happen. So
Yes, sir. I am interested in adolescent NCDs.
yeah, so
Good evening, sir, and everybody. I am Dr. Sonali Gar. I am from Kalinga Institute of Medical Sciences. I am a professor in community medicine.
Good evening, everyone. I am Dr. Pritam, junior resident, AIMS, Delhi.
we'll go this way and then come from there. It's easy for the mic to be.
Good evening, everybody. I am Dr. Shambhavi. I am doing my senior residency from University College of Medical Sciences and Community Medicine.
Good evening, sir. Myself, Dr. Priya Sharma, working as DNO NCD at Gurugram.
Sorry, you're working at?
District Nodal Officer,
Nodal
NCD
Officer.
at Gurugram. And just 1 week back, only I've received this chart. Basically, I'm an eye specialist.
You're an
Eye specialist.
Good evening, everyone. I am Dr. Anil Koparkar. I am Associate Professor in Department of Community Medicine and Family Medicine, AIMS Gorakhpur. Thank you.
Good evening, everyone. I am Dr. Manoj Bajaj, District Nodal Officer for NCD at District Faridabad, Haryana.
Good evening to the respected present over the dais, and good evening to all. I am Lalit Mohan Sahu, State Program Manager NCD from Directorate of Public Health, Government of Odisha.
Good evening to all. Myself, Mr. Vel Murugan, working as Assistant Professor in Nursing College, AIMS Bhopal.
Good evening, all. I am Mr. Kumarasamy, working as an Assistant Professor in Nursing College, AIMS Bhopal.
Hello everyone, I'm Dr. Ankit Chandra. I'm working as senior resident in Center for Community Medicine, AIMS Delhi.
Good evening all. Myself Dr. Girish, senior resident, CCM, AIMS New Delhi.
Good evening, organizers, and good evening, colleagues. I am Dr. Manoj Patruni. I am state consultant for Odisha State in India Hypertension Control Initiative from WHO.
Good evening, everyone. Myself, Rajratan Gupta, Assistant Professor, Department of Psychiatric Nursing, Nursing College, AIMS Bhopal.
Good evening, organizers. I am Dr. Tanya Khanna. I'm working as a project officer at Hriday, Delhi.
Good evening, everyone. I'm Dr. Shivangi Das. Currently, I'm working as a research assistant at Hriday, Delhi.
I think थोड़ी देर में अपने आप बंद हो जाता है.
Good evening, everyone. I am Dr. Nitesh Shah, State Program Officer, Gujarat.
Doctor, I didn't get your name.
Dr. Nitesh.
Nitesh. Okay.
Good evening, everyone. Myself, Dr. Anand.
Good evening, experts and delegates. Myself, Dr. Emmanuel Joshua, doing my second year junior residentship in Department of Community Medicine, Banaras Hindu University. Thank you.
Good evening to all. Myself, Dr. Vinodini, doing my second year post graduation in the Department of Community Medicine. I'm also from Banaras Hindu University.
Good evening, one and all. I'm Dr. Nikita, doing second year PG residency in Community Medicine Department, Banaras Hindu University. Thank you.
Good evening. I'm Dr. Shikha Bhasin, Senior Program Manager at Hriday, which is the Secretariat for the India chapter of the NCD, Global NCD Alliance.
Good evening, everyone. I'm Dr. Hanspreet, and I'm a cardiovascular health officer working for the project India Hypertension Control Initiative for the state of Haryana from WHO. Thank you.
Good evening, everyone. Myself, Dr. Karan Hiteshi. I'm looking after NCD program in Chamba district along with other programs, Chamba, Himachal Pradesh. Thank you.
Good evening, everyone. Myself, Dr. Kajal Taluja, MPH scholar from AIMS Jodhpur.
Good evening, everyone. I'm Dr. Ishani. I'm an MPS scholar at AIMS Jodhpur.
Good evening, everyone. Myself, Dr. Deepak Jaspal, District Nodal Officer, Surajpur from Chhattisgarh.
I am Dr. Srinath, Junior Resident, Center for Community Medicine, AIMS New Delhi.
Good evening, everyone. I'm Dr. Udita, Junior Resident, Center for Community Medicine, AIMS New Delhi.
Good evening, everyone. I'm Dr. Alicia, second year postgraduate from Lady Harding Medical College.
Good evening, everyone. Myself, Dr. Priyanka Pandey, second year PG resident from Lady Harding Medical College.
Good evening, everyone. Myself, Dr. Saurabh Chauhan, PG resident from Lady Harding Medical College.
सभी को नमस्कार. Myself, Dr. Abhishek, second year postgraduate, Lady Harding Medical College.
Hello, everyone. I'm Raj Lakshmi. I'm currently working as a public health consultant in NHM Tamil Nadu.
Good evening, everyone. I'm Dr. Lavanya. I'm working as a public health consultant in NHM Tamil Nadu.
Good evening, everyone. I'm Dr. Anam. I'm a junior resident in community medicine, AIMS Delhi.
Good evening, everyone. I am Dr. Soni Kumari, Lady Medical Officer, IGMS Patna, Community Medicine.
Hello, everyone. I'm Dr. Alka Sharma, State Nodal Officer, NP-CDCS, Uttar Pradesh.
Good evening, everyone. I'm Dr. Parijat from Chandigarh. I'm the Program Officer, NP-CDCS.
Good evening, everyone. Myself, Dr. Sanjay Singh, Store Program Officer for NP-CTCS and NTCP.
Good evening, everyone. I am Mrs. Satyakini Tangaraj, tutor in clinical nursing from Jitmar, Puducherry.
Good evening, all. I'm Dr. Anjusha Ranjit. I'm a junior resident at Center for Community Medicine, All India Institute of Medical Sciences, Delhi.
Good evening, everyone. I am myself, Dr. Vinod Pawar, District Nodal Officer, NCD, in District Bhiwani, Haryana.
Good evening, everyone. Myself, Dr. Pawan Yadav, District Nodal Officer, NCD at District Mahendragarh, Haryana.
Abhishek, you are introduced.
Hello everyone. I am Dr. Abhishek Jaiswal. I am currently working as a scientist C under Dr. Anand Krishna sir.
Okay. So it's already what long day 5:30. So today we'll just divide ourselves into groups just to know each other in the groups, and leave it to the groups to decide how much they want to work today. But if we can decide who will be your the team has already been divided. Abhishek will already give you the groups.
You can read out the names.
And let's today just get to know yourself, see what you have to do, plan what you want to do over the next 2-3 days. Maybe identify a sort of a moderator, a reporter who will prepare and present and those kind of things. After that, we can call it a day. So, Abhishek, you can announce, and we can just one group can be here, one here, there, those kind of things.
Dr. Abhishek Garg.
No, first you say which group and what is the
Terms of reference for the group one. What is group on what?
Group one. Team members under the group one will be Dr. Abhishek Garg, Dr. Emmanuel Joshua, Dr. Pallavi Mishra, Dr. Saurabh Chauhan, Dr. Shruti M, Dr. Alisha Raj, Dr. Ankit Chandra, Dr. Tanya Khanna, Dr. Kumar Sami, P. Rajratan, Dr. Swarnlata Das, Dr. Soni Kumari, Dr. Alka Sharma, Dr. Lalit Mohan, Dr. Manoj Bajaj, and Dr. Karan Hiteshi.
They announce the name of the group, no? They are working on which?
This is working group one, which is on situation analysis at a district using equity lens or something like that, right?
Group one is addressing inequities in the NCD care at a district.
Group one will look at how they can address inequities in NCDs. Faculty coordinator is myself. Group two.
Group two will be planning physical activity, behavior change in a setting approach. The group coordinator will be Dr. Harshal. Members under group two are Dr. Preeti, Dr. Paulami, Dr. Shalini, Dr. Lakshmi, Dr. Lalita Rai, Dr. Shivangi Rajput, Dr. Tripti Agarwal, Dr. Subarna Sinha, Dr. Mini S, Dr. Jamuna Adhikari, Dr. Arindam Das, Dr. Leena Charlotte, Dr. Vaibhav Rastogi, Dr. Belinda Gray.
all online?
This is online.
Yeah, so you say all
But
online
I heard a name in the previous, which was an online, which was in my group.
No, all online participants will be in group two. Whoever is there, they
I
will
thought I heard a name which was there, not here. I don't remember the name, but anyhow. So group two is entirely online, of online participants, right?
Group three is assessing and implementing people-centered NCD service in primary health facilities. Group coordinator will be Dr. Mohan. Members in this group will be Dr. Anam, Dr. J. Jyotni, Dr. Priyank Sharma, Dr. Udita Singh, Dr. Shyambhavi, Dr. Lata Venkateshan, Dr. Deepika Khaka, Dr. Sonali Kar, Dr. Ishani, Dr. Shivangi Das, Dr. Jagannath Reddy, Dr. Parijat, Raj Lakshmi V, Dr. Manoj Patruni, Dr. Ebenezer Fisau.
Ebenezer was there, no? Ebenezer was online in the list.
Next group is group 4. It is HMIS database monitoring of NCD program in a district. Group coordinator will be Dr. Baridali. Members in this group are Dr. Anjusha Ranjit, Dr. Nikita Pedpanga, Dr. Sumna VM, Dr. Preetam Haldar, Dr. Priyanka Pandey, Dr. Pragya Pathak, Dr. Suchita, Dr. Varsha Singh, Dr. Cecilia Mary, Dr. Barsa Priyadarshini, Dr. Nitesh Shah, Dr. Sanjay Singh, Dr. Pawan Yadav. Next group is group 5, that is implementation research related to NCD prevention and control. Group coordinator is Dr. Sumit. Members in this group are Dr. P. Ananda Selvadas, Dr. Rajendra Kumar, Dr. Srinath K, Dr. R. Velu Murugan, Dr. Kajal Taluja, Dr. Anil Koparkar, Dr. Reena Kumari, Dr. Sikha Bhasnin, Dr. Deepak Jaiswal, Dr. Vinod Pawar, Dr. Priya Sharma, and Lavanya Paramal.
So, okay, maybe we can divide. The simple is everybody who is online is with Dr. Harshal in group 2. Whatever name they are, even if they were currently named in some other working group, if they are online, they are in Dr. Harshal's group.
And Dr.
So, no,
Ankit will be
you said some names which are there online in some other group.
And Dr. Ankit will be announced.
And Ankit will be also in the Dr. Harshal's group. So we can now divide. I will take the prerogative of being the senior most की मैं इधर ही बैठने वाला हूँ. बाकी लोग सब please इधर उधर हिल जाइएगा. So this is group 1. We can sit here. Group 1 is here. Group 1 here. We'll sit here. You can one group can sit in the where we have tea and coffee. There is. No, you are group 2 here to confuse. अच्छा वो ले रहे हैं ऑनलाइन ठीक है whichever way. So here इसमें आ जाते हैं तो ठीक है ना बेटर है थोड़ा अलग से इधर भी कर सकते हैं ऐसे हो जाते हैं ठीक है ऐसे हो जाते हैं अच्छा आमने सामने हो जाते हैं हाँ ठीक है इधर हो जाते हैं ग्रुप तो एक बार you have the list of names no एक बार आ जाएंगे तो टिक कर लेना देखिए just one thing that CCM resident will not be your presenter. There is only one rule. Every working group has to make a presentation on last day. It cannot be a CCM resident. There is only one rule. बाकी आप कोई भी करो मुझे कोई I am not interested. But it cannot be a CCM resident. आ जाओ ना please come here. There is nothing in the stage. Stage is the stage. Anybody can sit on the stage. Nor is there anything in the chair. Chair is neutral. Anybody can sit.
So participants who have joined online. So all of you are in the group 2. You must have heard so far. On physical activity, we have to make a sort of discuss about planning physical activity behavior change in a setting approach.
फिर चिल्लाना पड़ेगा फिर ग्रुप डिस्टर्ब होंगे थोड़ा पास जाना पड़ेगा ना तो प्लीज मैडम आप लोग भी ग्रुप 1 में आप ग्रुप 1 में तो आगे आना पड़ेगा हाँ वो नहीं तो चिल्लाना पड़ेगा फिर बाकी ग्रुप डिस्टर्ब होगा जो भी है ये अभिषेक ये माइक को बंद कर देना भाई ये सारे माइक ऑन है मेरे ख्याल से
किस पे भेजा ये तुम्हारा नंबर है क्रिश क्या नहीं मेरे पास है ना फोन करना
मीटिंग रजिस्ट्रेशन क्या है?
सर थोड़ा डिटेल आना पड़ेगा, बस नेम एंड ईमेल एड्रेस, फर्स्ट नेम ईमेल एड्रेस।
तू भी लॉग्ड इन है? हैं? तो तू फोन लाया कि नहीं लाया, लैपटॉप नहीं लाया तो? हैं?
एक लिंक आएगा,
ईमेल पे आएगा?
ये सर बस ओपन करना।
Hear me? So participants, can you hear me? Speaker bana.
Your voice is echoing.
Yes, speaker of course. Speaker. Yeah. Off. Yeah. Can you hear me now? It's okay.
Yes, sir.
Yeah. So just to confirm, everybody is here. Just quick, can we just confirm their physical presence online? I can see Ankita. Others, please.
Yes, sir.
You can switch on, all of you can switch on the videos if possible. Yeah, I can see Ankita, Shalini, Dr. Lakshmi, Dr. Subarna, Dr. Belinda, Dr. Shivji. Yeah. Yes. So, hello once again, everyone. I'm Dr. Harshal Salve. So we have to, for next few days, work on basically the physical activity behavior. We'll be having Dr. Girish with us, right? Dr. Girish, can you introduce yourself?
I'm Dr. Girish. I'm senior resident, Center for Community Medicine in
Right. So ours will be a tough group in the sense that we are connected distantly, no online. So 3-4 things we can do fix up today. That who will be chairing the group? It's like who will be the sort of heading the group in a sense, and there will be no, they will not be from our organizing team. And we also need one rapporteur who will rather two rapporteurs who can work on and sort of prepare notes and prepare a presentation.
So I
So,
can volunteer
for
leading this, for presentation,
right.
like leading the
Okay.
presentation. Presentation.
Okay. So though you are not a current CCM, right, but I think we can give that part to you. Then next is rapporteur, Dr. Lakshmi. Is it okay?
Okay, sir.
Okay. And I can see somebody. Dr. Belinda. Am I saying it right?
Yes, sir.
Belinda, right?
Yeah, Belinda.
Okay, great. So will you be our second rapporteur? Just to, because it's online, so we need two people to sort of discuss that, to prepare notes and compile the things. And Ankita can present. Is it okay with everyone?
Yes, sir.
Right. So basically what we want to do in this group is basically utilize a setting-based approach, right, for intervention for non-communicable diseases. And one risk factor or one healthy behavior we are focusing here is a physical activity. So how we want to promote physical activity using setting-based approach. So there are few SOPs which are enlisted. I will request Abhishek to share this with them or here, right? You can take photograph and share whatever. So these SOPs will be shared with you. I will just read out for you. First is to identify various settings and at least one intervention for each setting for promotion of the physical activity. Setting, for example, is just to give some cues. School is a one setting. Another can be sort of, let's say, hospitals. So similar, we can identify various settings in this, and one intervention focusing on promoting physical activity. That is a one first step. Then identify the stakeholders for implementation of behavior change communication. So how whatever intervention we are planning, what are the stakeholders which are there who will be useful for implementing this behavior change. Then list out the specific component of behavior change intervention. So I'm just giving one example that is group to discuss further. For example, if we are planning physical activity, so let's suppose it's a office setting or workplace setting, a one day for physical activity or sports week. That can be just abstract this thing. Then fourth step is implementation strategy. How we should implement this intervention in one of the settings we identify, we finalize, and challenges of implementation and all the levels of the challenges we foresee for implementation. And last but not the least, the framework for monitoring this implementation and obviously behavior change. Right. So these are the few steps. What I think was if we can able to discuss and zero down one setting and one intervention. So I want what can be the appropriate setting which can give us a what we say the maximum output of our effort and the intervention for physical activity. Yes, any volunteers for the first this thing? Any volunteer will not. Anyone can come in.
Okay. So can I?
Yes.
So, different settings which I've just enlisted is starting from the family, then school, then college, then workplace, and then in the community, different institutions like Panchayati Raj institutes or the ICDS or the VHNC's committees can be another setting, and one important is residential societies. So these are the tentative settings which I've just thought while we were discussing. So like the group can definitely comment, and as you just asked, with one setting and with one intervention. So right from, if I start from the school, because family will be a complex thing, it will involve a lot of motivation. So we'll start from the school. So like again at the school level we have like play group and the primary, so we have to devise interventions accordingly. So basic and simple interventions for the primary age group, and middle and secondary students can have a different level of physical activity interventions. And
So we'll
suppose
setting first. We'll go step by step. So we list out the setting. Then today we will not decide which setting and which. We just list out. The first step is listing out the all settings and listing out the all intervention. Then the being all of have just individual level have a thought for it, and then tomorrow's group for discussion will finalize and the. So what I am thinking, just one setting and one intervention will work, right? So any more suggestions for setting first setting?
Sir, can I talk?
Please go ahead. For now.
Sir, I think most of us are from community medicine background, and we teach students regarding preventive aspect of medicine, but most of the time we don't follow this. So I think we start, our setting can be, one of the setting can be community medicine department of any institution.
Okay, good.
This is my side.
Right. Excellent. Any more suggestions on the setting?
Sir,
Yes. Let me. There is no right or wrong answer in the group work. Everything is right. Right. So don't hesitate to say everyone is right. So there is no wrong thing. Right. Okay. Yes. Go ahead, Dr. Shib.
Yeah. Yes, sir. Sir, I think any company or an office setup can be taken up for an IT sector, in the IT sector, any office in the IT sector. Because as Dr. Ankita was saying regarding the school, in the context of school, I believe in schools already we have this physical education classes and all. Plus they have this lunch period in which the students are already involved in physical activities. So I guess in some setting where the people are not like mostly accustomed with the sedentary lifestyle or sedentary work, it will be better beneficial for that setting, I guess.
Okay, IT sector, the IT employees you are saying, right?
Yes.
Yes. Any more questions?
Sir, can I speak?
Please go ahead.
Sir, as it was like just previously told that since we belong to community medicine, so I think that the caters of the primary health services like primary health centers, PHCs, and in urban setting, if I talk about, it could be urban health centers where we can like carry out this behavioral change for physical education thing or physical exercises.
Okay, so more primary health care setting you are saying in terms of urban health center, right?
Yes, sir. Yes, sir.
Yes, very good. Shivangi, can see you. So we have the residents also. So please participate. That will increase your confidence also, right? As I said, there is no wrong thing. You're muted, Shivangi. Unmute yourself.
Hello.
Yes. Go ahead.
Hello.
Yes, Shivangi, go ahead.
Sir. Sir, as the media, internet is the basic necessity for all of us. So we can make small ad or something for the promotional activities for the children, so that we can display it in the school or in the for the ASHA worker, which can be easily accessible to all of them. We can use our media and internet for that purpose.
No, so we are talking the setting. What you are referring is the schools, basically school-based.
School or the school and the ASHA workers, ground, those who are working on the ground level.
Okay. Fine. Who else? Dr. Lakshmi? No, you also have to say. It doesn't fit. You have to only write. Please go ahead.
I can't think of any other setting other than this. If personally asked for, I will go with the community medicine department.
Okay, community medicine department. Good, good. We already included. Dr. Subarna? Subarna, Arindam, follow me.
Yes, sir, I have already spoken.
Okay, sorry. Follow me, Arindam, Vaibhav. We got disconnected with Vaibhav. Arindam? Follow me, Randeep.
Sir, I also. Hello.
Yes, yes, follow me.
Sir, I also think community medicine department from an
Okay,
institute to bed creatures.
good, good. Randeep? Introduce Randeep. Randeep, are you there?
Yes, sir. Hello.
So have you introduced Randeep? Did recollect?
Not yet, sir. Actually, I had some internet issue in the meeting.
Yeah, yeah. Please introduce. Introduce.
Myself, Dr. Ronaldin Romek. I'm PCT Community Medicine from AGMC.
From where? Which state?
AGMC, Agartala Government Medical College, Tripura. So right now, also, I'm having some bad internet connection. I don't know whether you are being
Okay.
able to listen me.
So we were just discussing about the various settings where we can plan our intervention for physical activity promotion.
Sir, nothing new from my side. I will go with this community medicine department, sir.
Okay. We are connected with Vaibhav. Dr. Vaibhav?
Yeah. Good evening, sir. I am Dr. Vaibhav. I am currently working as consultant in the Ministry of Health and Family Welfare.
Yes. What are your thoughts, Dr. Vaibhav?
Sorry, sir. I got disconnected in between. So can you please?
No. Yes, we are identifying the settings for promotion physical activity behavior. What is the appropriate setting to plan our intervention?
Okay. So it can be at different levels. With respect to different ages, I believe schools will be the best place for adolescents. And with respect to the community, we have to see the socioeconomic and the culture with respect to that we can plan. So like in the corporates, it can be a separate activity altogether. And with like, I would say housewives or people who are staying in their at homes, it can be a small social group which can work their locality. So these can be the different possibilities, I believe.
Okay. Anything else from your side? Alicia? Alicia, are you there? Okay. Alicia?
Sir, Alicia is attending it physically out there.
Oh,
She is in the group 1.
physically. Okay, fine, fine. Okay. So we have a good number of settings. Does anyone have any experience of working in a setting-based approach for planning any NCD-related intervention? Any experience? No? Okay. Anyone has
Sir,
any experience? Yes, go ahead.
Sir, I was involved in setting up diabetic retinopathy screening services at primary and secondary care level when I was working in PJ. But it is a complication of, like one of the complications of diabetes.
Anyone has experience of or working in activity where physical activity has been promoted in a sense? Any intervention? Any experience? Oh, that's good. So, Dr. Lakshmi, can you just read out the settings we have got so far?
So they are starting from family, then schools, colleges, workplace, ICDS, village health, sanitation and nutrition committees, residential society, community medicine department, IT sector, PHCs.
Okay. So if I sort of, let's keep zero down on 3 settings so that we can finalize tomorrow. One, I think majority were there for the community medicine department as a setting. So let's keep the medical college as a setting. Second is secondly, obviously a school that is which is coming up, and third what was what? Yeah, third is the IT sector which has come up. The employees are working in IT sector. So let's keep these 3 settings in the mind and let's finalize tomorrow the setting. And also I request everyone to think about what are the interventions or for promotion of the physical activity we can plan. Just think about it in the evening, sleep over it, and then tomorrow when we will begin, we'll finalize the setting and also discuss about the interventions which we are going to sort of discuss and finalize. So at the end of day 2, we'll able to sort of discuss more detail about the intervention. And whenever you think about the intervention, think in the component wise manner, like what should be its component, how it will get implemented, what are the stakeholders involved, so that it will be easy for zeroing down on interventions. Is it okay?
Yes.
So anyone wants to say more about it? To this decision, move forward. Okay, then Dr. Ankita, should we call it a day?
Yes, sir.
Okay.
Sir, on the lighter note, I just want to comment one thing. In Punjab, we see security guards and police person who are actually obese, and although they have given their entrance when they join the job, but over the course of time, they lose their physical activity, and there are more of dhabas here, so their eating pattern and it's all changes. So that can be one of the settings, but we can cover in different like medical colleges also.
Obviously. So, okay, then we have a long day and it's mostly a theoretical lecture, I will say. Hopefully tomorrow onwards will be more hands-on, sort of group work will be more. So the engagement will be more. So we'll again connect tomorrow for this group work where we'll finalize the sort of settings and the interventions. So if there is no more comment or suggestion, could we close the session?
Yeah.
Okay.
Thank
Good
you,
evening.
everyone.
Okay. See you tomorrow. Bye-bye.
Thank you.